session would I would like to request Dr. Balla, Dr. Sadik Sikora, Dr. Ashok, Venkatram Reddy, Dr. Yashwant, and Dr. Birappa. You can start.
Good morning, respected teachers and my dear colleague. I am Dr. Rajat from Nizam Institute of Medical Sciences. Today I am going to present a case of 58-year-old male from Assam who is an engineer by occupation, presented with chief complaint of yellowish discoloration of eyes from 4 months and episodes of pain 4 months back. He presented with the chief complaint of in a history of present illness. He was apparently asymptomatic 4 months back when he noticed a yellowish discoloration of his eyes and the urine, which was insidious in onset and waxing waning type in nature. It was associated with generalized pruritus, not affecting the sleep and lifestyle pattern. Initially, it was associated with the vomiting episodes, which were small in amount and non-bilious. Later, he developed epigastric pain abdomen, which was dull aching, lasting for 5 to 6 hours and intermittent in nature, mild to moderate in intensity, non-radiating type, and requiring oral and IV medication to subside. There are no aggravating or relieving factors. There were 2 episodes only, which were a result of the medication and didn't appear in last 3 months. There is a 1 episode of fever with the chills in last 1 month, following which he underwent endoscopic intervention, and after that he improved. It was associated with the 10 kg of weight loss and loss of appetite. Last 4 days back, he again underwent endoscopic intervention for increased jaundice again. There was no association with the clay-colored stool, GI bleed, or there is a no abdominal distension, altered sensorium, decreased urine output. There was no hemoptysis, back pain, seizure episodes, and there is no history of night vision loss, easy bruisability, and bony pain. In past history, there is no similar complaint. He is a known hypertensive, diabetic from 8 years and hypothyroid from 12 years. There is no recent change in the diabetic profile. He underwent a spine surgery for disc prolapse 12 years back. In personal history, there is no addiction. He is mixed diet. He is of mixed diet, normal sleep pattern. Family history is not contributory.
You summarize your history?
Yes, sir. 58-year male from Assam is a hypertensive, diabetic, and hypothyroidism. Presented with complaint from 4 months of waxing waning type of jaundice associated with the pruritus and epigastric pain with 1 episode of fever, and associated with the 10 kg weight loss and loss of appetite. He underwent twice endoscopic intervention, following which he improved but recur. So second intervention was done 1 week back.
So what do you infer from the history and also the part of 2 times intervention in the form of endoscopy?
Yeah, before that, how did you come to waxing waning jaundice?
Sir, actually patient was telling that after hospital management it decreased but never subside completely. His urine and
That
eyes.
is intervention for management, right?
From last before that intervention also he was admitted in the hospital and conservatively managed. He improved, but all the symptoms like pain, vomiting, and fever subside, but jaundice never came to the normal, sir. He was persistently having jaundice. It decreased.
What is the significance of waxing waning jaundice per se, and is that statement has to be backed up by adequate information that yes, it is a waxing waning, right? So how did you, because you made a specific statement that it was a waxing waning jaundice. So how did you,
And Dr.
how do you
Sadik
figure out?
want to say, you mentioned the jaundice was high, it never came to the normal. It means it decreased, but it never reached to the borderline.
Exactly, sir.
But you define the waxing waning is a different terminology. So what do you mean by waxing and waning, and what in the history to say the jaundice nature or waxing and waning?
Sir, actually pattern of jaundice is like it was not progressive and it never came to baseline. It was increased and decreased as per on history. So I made a conclusion like waxing and waning to differentiate other form of patterns. Yeah, he is
Waning pattern.
Yeah, yes, a patient was telling like that, and he is educated engineer, sir. So, I took it.
How many such episodes you had
Sir, 3 episodes, sir.
within 4 months duration?
Yeah, yes, sir.
So the question is based on your history and this kind of twice intervention in the form of endoscopy, what is your possibility or what do we infer from this?
Sir, my first provisional will be malignant obstructive jaundice. Most likely will be secondary to periampullary cancer, sir.
So why do you think it's a malignant obstructive jaundice?
Sir, because that it is associated with significant weight loss and loss of appetite, and apart from that, it is patient is having pruritus, and there is a no prolonged history of colicky pain abdomen or previous episodes of cholangitis. So benign etiology will be less likely. So I kept as a malignant, and in view of pattern of
I'm not asking you to negate the benign pathology because the question was why do you think it's a malignant obstructive jaundice? So there are two terminology here. One, obstructive jaundice, and second, due to some malignancy.
yes, sir.
So why do you think so? Why do you think the obstructive jaundice and why you feel it's malignant in nature?
Sir, obstructive jaundice is associated with the generalized body pruritus, and second, it is associated with the significant weight loss and loss of appetite, which is an alarming signal for malignancy. So I'm keeping as a malignancy as my first provision.
You said
So if it is a malignant obstructive jaundice, what are the more likely site of, the pathological nature of this jaundice? Yesterday we have discussed the case of surgical obstructive jaundice. So what are the possibility based on the other presentation and symptoms and intervention? What could be the pathological nature of this disease? The site of lesions and also the pathology most likely.
So it can be secondary to carcinoma head of pancreas also.
1, 2, 3, you tell 1, 2, 3.
Carcinoma head of pancreas, and third will be carcinoma gallbladder, sir.
So why do you think this is the carcinoma of the gallbladder? Come
Sir.
with the third differential diagnosis first.
So because it's associated with the pain abdomen, sir.
Pain abdomen, there may be hundreds of causes of pain abdomen. So you should know what is the character of pain, what is the site of pain, nature of the pain, referral pattern, what is the aggravating or relieving factor of the pain, and other associated symptoms. So you have not described, just to say pain into the abdomen, it's a big terminology.
No, sir.
Nobody can.
In history, sir, it is a epigastric pain, sir, which is dull aching, intermittent in nature, mild to moderate in intensity, non-radiating, and no relieving or aggravating factor, sir.
So what are the causes of dull aching pain into the epigastrium?
Sir, peptic ulcer disease.
Okay, one is the peptic ulcer disease. Second,
Sir, it can be secondary to gastritis or esophagitis also.
so gastritis and esophagitis. Other causes.
Uh,
So if suppose that if only 3 causes, then you mentioned the gallbladder pathology, CAGV in this patient. What would be the character of pain in CAGV? It is the similar to that of ulcer, peptic ulcer disease.
Yes.
It's similar to gastritis, similar to the esophageal pathology.
no, sir, it is dull aching, sir, dragging type. And
So why do you giving this because the patient has pain, that's why you are thinking of carcinoma of the gallbladder? What kind of pain would be in a patient with carcinoma of gallbladder?
it's a aching type pain and can be radiating to the infrascapular region of the right side.
What else? So suppose that too, it's very important to elaborate the character of pain, nature of patient, associated symptoms, and how it is get relieved or not relieved. So gallbladder pain patient may likely to have maybe the history of biliary colic in the past if they have one. If not, then gallbladder pain, if a sudden in de novo malignancy, would be persistent pain, and mostly epigastrium or maybe subcostal area. Sometimes you mentioned the referral zone, and pain may not be relieved at any point of time. It may decrease, but it may persist throughout the day and throughout the night because the character is malignant.
So, Rajat, now let's get on. So, you listed three. Any reason why you put periampullary as first?
The pattern of jaundice, only
What?
thing, yes, sir.
What pattern of jaundice?
Sir, non-progressive and it is in increasing and decreasing pattern, never come down to the baseline or normalize it.
So, which periampullary? Which behave like this?
What is the
Very
definition of a
classical.
periampular?
Sir, any tumor around the around the ampulla in the region of 2 centimeter is a periampullary. It can involve duodenum, it can involve distal CBD, or it
Is
can
it ampulla or it is papilla?
papilla, sir.
So, which one would behave since you are paying so much attention to vaccine waning? So, there has to be one characteristic site which behaves like that. So, small CA pancreas will have vaccine waning?
Less likely, sir.
Less likely or
No, sir.
unlikely?
Not unlikely, sir.
Unlikely. Cholangiocarcinoma,
Unlikely,
lower,
sir. That
duodenal,
duodenal can be,
and
and ampullary.
ampullary. So, you're putting that. Another thing you said, there's no history of cholangitis.
One episode is there, sir.
But you mentioned in your summary that no cholangitis. Now, why do you think this intervention was done?
Sir, he presented with the fever with the chills and pain abdomen. So at that time, intervention was
How
done.
common is cholangitis in malignant biliary obstruction?
Is cholangitis a presenting symptom in
No, sir.
malignancy?
No, sir. Sir,
How common it is? If it's
sir, very less likely, sir. It only occurs when the any intervention done to release the jaundice or drain the biliary system, then only it occurs.
And it can occur. It's not that it is unlikely,
Yes, sir.
but it is much less, about 10% or 15% maybe, may have an initial set of symptoms which may be suggestive associated cholangitis, but it's not as a presenting symptom it comes. So, and yes, more likely this vaccine waning or these kind of tumors are more likely to have because they are sort of degenerating or necrosing, and there is likelihood of reflux and cholangitis occurring in such situations. All right.
You mentioned two intervention. We don't know what kind of what are the possibility, which kind of intervention has been done twice in this patient?
Sir, first, like in examination will be detailed, sir. But
Speculation based on the history.
first intervention to really to treat the cholangitis, sir, and after that might be the place distance got blocked and requiring second intervention.
Okay, let's
So when you talk about waxing and waning, what are the other causes of waxing and waning jaundice? And why
Can
are
you-
they not here?
pass
why-
it on to the next person. Who wants-
We jumped straight to a malignancy,
Yes, sir.
very amply. But are there any other possibilities? And why should we not consider this?
Waxing and waning type mostly, it is pertaining to the periampullary carcinoma, not for the benign diseases. Only intermittent jaundice is possible for the benign diseases like cholelithiasis. That is age of the patient, significant loss of weight,
Loss of weight is usually not associated with choledocholitis.
cholelithiasis, benign conditions.
You have to give it out. The other I want to know is, why did you give us this? Why did you place emphasis on the negative history of diminished night vision? You said night vision. What was in your mind?
That is actually for in case of prolonged obstructive jaundice, there will be the fat soluble vitamin deficiency, vitamin A deficiency. To rule out that, just asked about the history of reduced night vision. But that is possible only in the prolonged obstructive jaundice.
Far-fetched.
This duration of symptoms, you are expecting these kind of changes to occur?
No, sir.
Have you ever seen that the patient having a vision deficiency in any periampullary?
No, sir.
Like, short duration, all these.
Yes, sir.
I want to ask, he has done twice endoscopy, right? That time nobody has noticed the tumor at that time. We don't have.
No,
We don't have.
We have not yet
information.
gone into
We are
it.
totally blind for this
So
investigation.
let's quickly complete who's getting the examination.
Examinations. I'll
Yes.
tell.
Okay.
So, general examination, my patient is an elderly male who is moderately built and moderately nourished with the BMI 24.2 and ECOG 1 performance status. He is conscious, cooperative, and well oriented to time, place, person, lying comfortably in bed, well hydrated, and afebrile. Thin tube seen coming out of the nostril connected to the urobag, which is draining bile around 400 ml. And the vitals pulse rate is 80 per minute and the blood pressure 120 bar 75 millimeter mercury, respiratory rate is 18 per minute, breath holding time is 35 seconds. He is citric and scratch marks presented over the trunk. No pallor, cyanosis, clubbing, generalized or localized lymphadenopathy, no palpable left supraclavicular lymph node enlargement, no pedal edema, no peripheral signs of chronic liver disease. And systemic examination, examination of abdomen. On inspection, abdomen is flat, umbilicus is central and inverted, all quadrants moving equally with respiration, no visible lump, scratch marks seen, no scar, sinuses, engorged veins, pulsation, peristalsis. Inspection of groin, hernial sites reveals no swelling or cough impulse, and inspection of genitalia is unremarkable, no renal angle fullness seen. On palpation, abdomen is soft, not warm, not tender, liver and spleen not palpable, no palpable lump, and no palpable cough impulse over the groin hernia sites, and examination of genitalia is unremarkable. There is no tenderness in the renal angle. Examination of back and spine is essentially normal. On percussion, upper border of liver dialysis is in the 15 intercostal space and midclavicular line, with the liver span being 14 centimeter. Rest of the abdomen is tympanic with no evidence of free fluid. On auscultation, normal bowel sounds here, no bruit or hum here, and per rectal examination is normal. Other system examination, respiratory system, normal acicular breath sounds here, no added sounds. Cardiovascular system, S1, S2 here, no murmur.
So the next question, I suppose that you have examined the patient,
Yes, sir.
and how your examination contribute to the presumptive or differential diagnosis based on the history. I mean, how it can help you to reach the diagnosis. You have met 3 differential diagnosis: periamputary, period of pancreas, and carcinoma of the gallbladder. Can you put anything based on the examination, emphasize on these 3 diagnoses? You can exclude or include some more diagnoses. Another question to you: there is a tube is coming out of the nose. What kind of tube is this, and what is its implication? So first you, and then.
Actually, that is most probably nasobiliary catheter, which is a thin tube, draining the bile. Mostly it's nasobiliary catheter, which is
Why one you prefer nasobiliary drainage over internal drainage? I mean, internal stenting.
that is because this was actually done at the second time of endoscopic intervention. Previous endoscopic stenting may get blocked and stent blockage. Because of that, they removed that stent and they put a nasobiliary catheter.
One possibility they must have removed. Sometime even not removed, but they put
They-
on the nasobiliary by
nasobiliary.
the side. What is the one question is, what is the advantage of nasobiliary or disadvantage over the internal stenting? Advantage and disadvantage.
Advantage is less chance of tube blockage. We can flush it off, and we can. It is physiological also. But disadvantage is there is more chance for dislodgement, and patient can self remove that, and patient compliance is very less with the nasobiliary catheter.
Can we send bile per culture, aspirate and send for bile per culture
Yes, sir.
and keep aspirating? Can we instill an antibiotic locally?
So one obviously train externally. That is a, you can send the bile for culture.
Culture.
You can flush it, remove this clogging.
Clogging.
Either it's a infected bile or maybe tumor itself, fluffing of tumor. And sometimes very helpful to do the cholangiogram
Cholangiography.
if you need
Need.
it. But disadvantage is that if high amount of bile is there, then it may lead to some kind of dyslipidemia, and also sometimes because if it goes through the nose, it may lead to the pharyngitis, nasal irritation, sometimes bleeding, and if long term, it may lead to even stricture.
Okay.
So there were 3 differential diagnoses.
Yes, sir.
Can you modify the sequence or remains the same, or you can delete any of the differential diagnoses based on examination?
Based on examination, I could eliminate the third possibility, carcinoma gallbladder. Most probably it is a distal blockade, which was tackled with endoscopic nasobiliary drainage. So I would like to keep the, possibilities of periambulary carcinoma first.
No, the question was that you have to emphasize on any positive or important negative findings to refute or confirm or support your diagnosis. So go in that manner.
Negative findings, there is
Nasopilary drainage, where the block is not probably the best thing to start off with.
there is no palpable.
And even we don't know, we have not done a cholangiogram, we don't know the endoscopic finding during ERCP, that keep inside.
Okay. No palpable gallbladder. That is against for the carcinoma gallbladder.
We find palpable gallbladder mass or palpable gallbladder in carcinoma gallbladder always, and more so a patient who has already undergone ERC stenting.
If it is a distal blockade, we will not able to palpate the gallbladder if after the drainage. If it is a carcinoma gallbladder, most probably we can have the palpable mass in the right hypochondrium, because most of the patients will present late in case of CA gallbladder. So even after drainage, we could palpate some mass in the right hypochondrium in case of CA gallbladder.
So what you're trying to say is that a CA gallbladder presenting with jaundice is more likely to have a mass palpable, and since I'm not feeling, I may put it down.
Yes.
So
I want to eliminate
it's
that.
not always, it's not never.
Yes.
So you need to make your statement accordingly,
Okay.
right? So that is one. Second, the question between mass and palpable gallbladder.
Yes.
Do you understand the difference?
Yes.
What is it and how does it help? Mass,
there-
gallbladder mass and palpable gallbladder.
If there is a, suppose that the gallbladder is replaced by a mass, or there is a mass into the gallbladder, or a small lesion which infiltrating the liver, you can feel a mass.
Yes.
But distended gallbladder, that is the palpable gallbladder, it could be because of a kind of, even you find in periampullary carcinoma, you can find if there's a block at the mid CVD level, you can block at the cystic duct block, you cannot feel a mass, but if there is a lesion in cystic duct, or so you will find a distended gallbladder, palpable gallbladder.
Consistency maybe differ.
Distended gallbladder before
What is
below the
unusual,
insertion.
what is unusual in your history? I mean, in your examination, you've got this patient who's got an ENBD, who's got 400 ml of fluid.
Yes,
You didn't mention the character, which would be a good thing to do. If you find a drain and there's the bag attached to it, you should mention the character of the contents.
Yes, sir.
Gives us an idea.
Yes.
Now, he's got this ENBD drain, this is what we are presuming. He's got 400 ml of bilious content. Still itching. What's happening?
Now he's feeling better. He's not having that much
You
symptom.
just mentioned during your examination.
Scratch marks present.
Usually when you have a ENBD drainage or a drainage of an obstructed system, why do you do it in the first place? One is to preserve the liver function, the other is to relieve him of his itching.
Yes.
If the itching still persists, it suggests to me that there is still some blockage somewhere.
So, extension to the same thing, one, ideally itching should subside it, but there is various pathogenic mechanism for itching in jaundice patient. So one of the mechanism may be not working in this patient, because many people feels the irritation of the nerve indexing because of the hyperbilirubinemia. There are many other pathway for nerve, so there may be not always a big correlation into the fall of bilirubin and disappearance of the itching or maybe pruritus. So, or maybe you have just put few days back and bilirubin has not completely come down, obstruction has not really, that's why patient is having it.
Yes, sir.
You did not answer the question, the gallbladder distension versus a mass arising from the gallbladder. What Sadhika asked.
Gallbladder mass. Maybe the consistency will be firm to hard in case of, so tensely cystic in case of distended Gallbladder.
Where there's a block below the interstitial
Yes.
system, that gallbladder will get distended.
Yes.
Whereas in the gallbladder carcinoma, it's in a mass.
Mass.
Palpable.
Hard
That's what we would
inconsistency.
like.
Yes.
It's very basic.
We would not say that it's a mass in the gallbladder. If you feel a distended, tense gallbladder, you should be able to distinctly make out compared to a mass.
Mass.
It should be
Smooth.
firm to hard, nodular, as opposed to a cystic, palpable,
Smooth
oblong, ovoid kind of swelling. So it has relevance, but again, it is not sine qua non that if you don't have this, this is not the diet.
Okay.
Right? Okay. So can we proceed? So
Gallbladder has been removed as per after examination, and out of there are two possibilities.
Yes, sir.
One is the periampullary and second would be
Carcinoma.
carcinoma. Can you put any other diagnosis at this point of time? Yes or no?
No,
be,
sir.
be very strong.
No, sir.
No, okay. So now how will you confirm your diagnosis?
Sir, I would like to review the old records and blood investigations. Any other imaging is done previously.
Blood investigation will confirm the diagnosis or prove the diagnosis.
Whether based on the liver function test, whether it is an obstructive pattern is there, we can diagnose obstructive jaundice. And
you still in doubt? A procedure has been done. You have had classic symptoms. So now you still want to prove whether it is obstruction in the biliary system?
no, sir.
So see again, we need to be clear about answering what question. How will you go about confirming the diagnosis or getting a sense of where the problem is? So you need not necessarily go into a hemoglobin TNC and all that. That may come when they are talking of preparation of the patient. But right now, we want to figure out what is the problem which we are dealing with. Right?
You know, finally we have narrowed down at two, periampullary and seed of pancreas, and both can lead to the obstruction, and both have been proven that it's malignant obstructive jaundice. So the question is that how to confirm whether or prove whether it's a periampullary or at the head of pancreas.
So one thing you said, review the investigations, which is a good place to start with. So which investigations you would say you were managing that? What would you have done at that point of time, which you would want to review before doing an intervention? You get my point?
Before we get into
Suppose-
this, just one point. When you're looking at the investigations, you have to ask yourself a question: okay, why am I investigating it, and what information am I looking for? So give me the answer to that. At this point in time, what is the challenge? What investigations will you see?
sir,
You want to know the cause, and you want to know the level. So what are the investigations you will do to determine the cause and the level of the block?
sir, actually for periampullary carcinoma and pancreatic cancer, CT is the best investigation.
Straight away you go for an CT, or would you like to have a less invasive and sonography and then decide? Like to know where the level of an obstruction based on ultrasound.
Sir, if a patient comes initially, first I will do after blood investigation, I will do ultrasound to know where is the level of the lesion. And,
What would you like to know in an ultrasound?
in the ultrasound, first I will like to know what is the liver contour and IHBRD dilatation and common hepatic duct CBD and up to which level it is dilated and
This
whether-
patient has an nasopiliary drainage, so you may not see all those things. System must have been collapsed.
when the
The
patient
gallbladder is not palpable clinically. So
this patient ultrasound will not be much helpful, sir. If patient
why
came-
it will be helpful?
any pancreatic mass is there, we can.
That's a big statement to say that ultrasound will not be helpful in this situation. in any patient with obstructive jaundice, what are the findings you can get on an ultrasound? It's a broader question.
We've discussed this yesterday.
Yeah.
If you're paying attention, so now you should be
You
reeling
can't
it out.
make this statement.
You can't keep on going. And as you answer that, I mean, even the first point, I negate that. The reason being, you need to see whether there is a collapse of the biliary system, and that will tell you how effective the drainage is. So that's an important point. That if you put a drainage and if you see that the biliary system is not persistently dilated, it tells you that whatever you have done to relieve that obstruction is good enough. So the negative finding is also useful, right? So now please answer. Apart from this biliary system, what else? You should be able to reel it off now, at this stage.
Apart from the level of obstruction, any portal hypertension, splenomegaly, any collateral vessels in portal pedicle, you
So
can.
you are more interested in
why-
splenomegaly and portal pedicle. Study we said you should look for liver, you should look for the level of obstruction, aerobilia, pneumobilia, ISBRD, and then if you can see, enzymologists can see they can tell the PD is dilated, or maybe sometime the double duct sign is there or not, free fluid is there or not, if there is a cholangitic evidence of cholangitic abscess or SOL in the liver. These are so many things you can find the information. Grass mass in the pancreas, pulmonologist may be able in a small percentage that there is a mass into the head of pancreas.
Liver metastasis there we can see in the ultrasound.
When you said you review the investigations, are you not interested to see the endoscopy and side viewing scopy? Because they have done that, no? That itself will give you the
The
diagnosis.
Epigastrium we can.
Yeah, so why don't you review that investigation than going for CT, ultrasound and all that? Definitely patient will have this information with him. So that's going to give you a diagnosis.
I'll suggest go to the ultrasound.
Liver is normal. There is bilateral IHBRD. The CBD is dilated till the visualize the extent. So, the distal end of the CBD, there may be obstruction.
One thing I'll interrupt. This is the
Prior to
before endoscopy.
Before intervention.
Okay, because it's emphasized that it's before endoscopy.
Gallbladder is distended and thickening is normal. Pancreas not visualized to gas. Spleen is 10 centimeter and so the level of obstruction is distal end of CBD and the pancreas is not visualized, sir. So you cannot rule out the pancreas.
So be more confident. So from this ultrasound, the information we get is there is a distal block. The cause of block is not evident and there is no evidence of any ascites or dissemination on this ultrasound. Now I would like to review the endoscope. Whatever intervention procedure they had done.
Before the stenting or not, and registered that information in your head, because this is a reviewed investigation you are looking at, and whether that must have been done before the stenting, that's why there's no stent seen. Otherwise, you should be able to see the stent also, in addition to what Dr. Ashok and Dr. Virender said. You look for the stent, some of the nasopiliary drainage position also.
Let's find it is a before endoscopy.
So ERCP, sir, CBD is dilated with distal narrowing.
So you do ERCP in this patient who has an ampular lesion.
Any
like to do?
side viewing endoscopy finding, because it's mentioned biopsy has been taken.
Yes.
I would be love to see the side view endoscopy actually.
I would like to know whether he does an ERCP for this patient or
Sir, first endoscopy and side view scope. should
side
be
viewing
done, sir.
endoscopy. We may not inject the contrast because he had an cholangitis.
If any any growth is there, we can take
Yes.
the biopsy. For endoscopic ultrasound, gallbladder is distended with sludge and CBD is dilated with the distal narrowing. There is hypoechoic ampullary lesion. Pancreas, there is heterogeneous echo texture in the extent and prominent PD. PD is
So
around
you
5.
have seen the ultrasound, you have seen the endoscopic ultrasound. what do you interfer after these two investigation, and what would be your next plan? Forget what has been done in this patient. What you will do based on this investigation, keeping two differential diagnoses in mind, that is the peri-emperody vis-a-vis the head of pancreas, vis-a-vis patient has a high bilirubin and maybe pruritus.
Patient is having a
Don't repeat it. It has been given, you know. You have two imaging. I gave you this two imaging. You know the patient with presumptive two differential diagnosis. What would be your next step for this patient?
sir, I would like to do CT.
CT. Why do you want CT scan? Okay, if you do a CT, first, why you want a CT scan?
CT to confirm the diagnosis, sir.
How will you confirm the diagnosis in CT?
Peri-ampullary growth is there, and we can know whether
That is
But
quite
that is
evident on
already given
endo-ES.
here. You see in endoscopic ultrasound.
Yes.
You go back to endoscopic ultrasound.
Endo-ES shows that lesion there in the ampulla.
You see?
What extra information you want to get on a CT scan?
Diagnosis is very much clear.
staging we can do.
Staging,
Any lymph node metastasis and what is the T stage?
It's not about being right or wrong. It's about the thought process, no? So obviously now you have there is a mass lesion in the ampulla has been identified. They have taken a biopsy. They've taken a biopsy, right?
Yes, sir. Biopsy.
Biopsy has been taken. So now you have two options. Patient has cholangitis and you want to drain or treat medically. That we have to figure that out, what I want to do. And second, you want to stage the disease because EUS is not the staging diagnosis. So you say confidently, and before you put and intervene and put a stent or so, you may want to do a CT scan quickly enough if it gives you time, because it would again cause errors in interpretation due to the artifacts because of the presence of stent. So see, whatever you want to say, you can't be hesitant looking at the examiners, will he approve this or not? It is what you are thinking that is important. So you have to have clarity. Then you can discuss and argue also what line of or what approach you have taken. But if you are always looking for confirmation and support, then you will not progress very far.
So Dr. Sadiq said, what even I believe in, sequence of investigation may change, vary on what you. So you have to justify your view of point. Why want to CT scan first? Maybe I would not do a CT scan. I will first do ERC stenting, relieve it. The only disadvantage of stenting is that interpret the imaging, and usually plastic stent is there. It does not much matters, but obviously it interprets the correct interpretation of the site of lesion. Then staging also affects size of the lesion. So many things, and artifact, you know how affect the vascularity all around also. So you should justify whatever you do. Why do you want to do that? We may be wrong, or you may be wrong. You may be right. I may be wrong.
So in general, ampular area is a gray area. The best invest in US. In ampular lesion, local stage is better done with US if available. Of course, there is always the artifact. But here in ampular region, the stage is better done by US.
T stage better by EUS, but for lymph node metastasis, the distant metastasis CT will be a better option.
Biopsies, well to moderate differential adenocarcinoma. What next?
CT, I want.
Like to have CT. Like to have PET CT or CT? Would you like to have PET CT or a CT scan?
Sir, ampullary carcinoma CT,
I am just asking.
yes, sir, CT is
Scan.
PET CT is not needed.
Fine. Very good.
This is a plain CT. Plain CT.
Quickly read what you want
axial
to.
section, plain CT, chest and abdomen. Chest, there is no pulmonary metastasis or pleural effusion. Liver parenchyma.
You should see the lung windows if you want to comment on. Not on these windows. Anyway.
Liver contour was normal. Gallbladder is distended. There is no I have seen, sir. Let me go back. This is a arterial contrast CT. In the arterial contrast, I would like to see any aberrant anatomy, aberrant arterial hepatic artery anatomy is there. Right hepatic artery, I am able to see this.
Your suspicion is
yes.
an ampular lesion.
Yes, sir.
So your concentration on more on a hepatic artery or supramesenteric vessels. So okay, what happens? What's happening
Sir,
to the portal vein?
mainly portal venous phase.
Yeah, can see the portal vein there? It's an arterial.
SMA is there.
Then it's an arterial vein.
Yes, sir.
Yeah, please go ahead.
Coming off, I think.
Is it normal, abnormal? Yeah, this cut. There's a big vessel coming
Sir,
from the SMA.
Right hepatic artery is coming from.
But right hepatic, does this take this course, the aberrant right hepatic? Does it
Usually
take this
below
course?
the pancreas
It's,
it will
it's
go.
going through the
Yes,
pancreas.
sir. Below the pancreas. It will.
Huh?
Below and posterior it will go, sir.
It's crossing lateral to the bile duct in the pancreatic
Intrapancreatic.
parenchyma. That is not the usual course of an aberrant right hepatic artery. It's coursing through the pancreas. No. So that's what we are looking at. It is not the common course. So you have to. It has bearing on what you're going to do, since it is going through the pancreas, as opposed to a standard aberrant right hepatic artery, which would go along the right border of the portal vein or under the portal vein.
Right side of this.
So it's a. I'm glad you said that in arterial phase, you're going to look at two things: the arterial anatomy, and also, since it's an ampullary mass, is it enhancing brightly,
Neuroendocrine.
so as to look for that? Although you have a histology of well-differentiated adenocarcinoma. Okay, go ahead.
Portal venous.
Okay, venous phase.
From above it. HBRD is there.
Sorry?
HBRD is there.
So what was the purpose you got this scan done? You told us, no?
Yes,
So
sir.
look at that and tell us.
Hypotenuse mass and
Sorry?
lymph nodes is there. On
Yeah. So tell clearly about lymph nodes. Tell if there are any metastases in the liver. You have to spell it out.
Avoid making a comment like we've been through all the investigations, everything, and then very quietly you are saying IHBRD is there. This is the wrong time to say this now. This takes you away from the main thing.
Are there any liver lesions? What's happening to the portal vein? What's happening to the supramesenteric artery? Are there any lymph nodes? Are there any is there any ascites?
No, sir. No ascites.
Yeah, no
no
ascites.
liver metastasis.
No liver lesions are there.
No lesion.
What's
and,
happening to the SMA and SMV?
They are free, sir.
They're free.
Yes, sir.
Okay. Rest of the parenchyma, pancreatic parenchyma.
Parenchyma was
Duct is not dilated as per the CT. Okay.
that is a little bit dilated.
Okay. So what next now? There are no any lymph nodes seen there.
Yes.
Except that
Maybe as a T1 or T2 lesion.
So it seems to be operable lesion.
Yes, sir.
What is your next step for this patient?
I would like to see the liver function.
Say again.
Liver function test.
Show the liver function. He wants liver function, hemogram both.
so why do you want to know liver function? Total bilirubin is 20. Total bilirubin is 20.
Yes, sir.
Yes.
Cholangitis is there as not I have to see, sir.
Cholangitis. How do you know on the LFT that where the patient has any cholangitis?
SGOT and PT will be elevated, sir.
Pardon?
SGOT and PT will be elevated.
Okay.
And patient total counts will be high, sir.
On LFT. Okay. Go ahead.
Sir, bilirubin,
This is after endoscopic intervention.
Prior to NBT, sir.
Prior
Between
to
stenting, stent has blocked, and prior to NBT, this is the picture.
So
SGOT, PT are
you
high.
show the latest one after the ENBD, both hemogram and LFT.
NBT to
After ENBD,
that to be repeated, sir.
that's it to be not done.
Not
When was the ENBD put?
2 days ago, sir.
2 days. So you know the discussion, that's why it has not come normal. It's just 2 days. So what would be the next plan? You will discharge the patient and go home, ask to reoperate, or you will operate right now. So, and then what would be your surgical strategy, surgical plan in this patient, either this time or after?
The patient is having cholangitis, sir. So we cannot operate now, sir. So I want the cholangitis to subside.
I would like to continue IV antibiotics and hydration and repeat the LFT. If it shows gradual declining trend and there is no fever,
What
patient is
antibiotics
asymptomatic.
you prefer? What antibiotics you prefer? The patient has cholangitis.
Yes, sir. I will prefer, sir, 4th generation, 3rd generation cephalosporin is better, sir.
Okay.
If the LFT shows gradual declining trend and the patient is asymptomatic, then I'll probably discharge the patient for surgery later, sir.
You want to discharge him at this stage.
After the patient is asymptomatic and the LFT shows gradual declining trend, sir.
Yeah, this is the LFT and cholangitis has been subsided. You have given an IV antibiotic, cholangitis subsided.
Yes, sir.
So what is your next plan?
Next plan is, sir, counsel the patient for surgery in a later date, sir. Preferably 3 to 4 weeks later, sir.
3 to, yeah.
Let me get this clear.
Yes, sir.
So you waited for the patient to become better. Once the patient became better, you discharged the patient. And now you want to wait. Wait for any stent related complication to develop? What are you waiting for?
early surgery after the stenting, sir, is associated with morbidity complications, sir.
Really? Like what? What related to early surgery and what is related to late surgery?
Like, sir, infective complications are more in the early days.
And what happens if you wait for long?
Wait for long, sir, there is more fibrosis leading to.
I think your logic is really going out of the line.
Fibrosis we're talking, where fibrosis?
In the
Now, what is the definition of early and what is the definition of late surgery? I mean, is there a time gap? Is there some data to suggest that one or the other? Is it based on, is your plan based on resolution of the reason for which stenting was done? Or is it based on some invisible time period? Is it based on repeated stent blockage? What is the plan? There has to be a plan.
The resolution of the current problems, sir.
And that is not time bound.
Yes, sir.
It may happen in 2 weeks or it may not happen at all. You may require an expandable stent to achieve it or something like that.
Yes, sir.
And you are saying that once you have achieved that goal, you will discharge the patient.
No, sir.
No, that's exactly what you said. If the patient is well and all, I will discharge, wait for 3 to 4 weeks. That's not how it works, you know. So you need to, as everyone is trying to point out, the reason for intervention has to be clear. What are the goal of that intervention has to be clear. So here it is primarily cholangitis. Now once the cholangitis resolves, you need to look at whether you can intervene. And that's the time you have to evaluate this patient for the patient to be ready to undergo a surgical procedure which you plan for this patient, right? So this is the time to do. If the cholangitis is not resolving, then the other questions come. Suppose there is a persistent low-grade fever, leukocytosis, and there is persistent IHBRD. Then what will you do? Same patient. Dr. Ramesh gave some hints also.
We may have to place a metallic stent or self-expandable.
So what is the rationale of that? Metallic stent, you said. What is the rationale and what are the things you'll keep in mind when you put the stent?
It will be a short metallic sensor and it is covered metallic sensor. There is
Covered?
there.
No, but not only that, if you're covered, it can block the pancreatic duct below. If your cover doesn't, you don't accurately place it, then the patient may develop a very severe pancreatitis. So, I don't think any of us use the cover. We don't use.
You should know it is not a cholangiocarcinoma mid CVD. It's the pathology in the periembolic region. The obstruction is lower down. You should think how it can be put so that it's lying and relieve into the periembolic obstruction. So one end should be where and distal end should be where. So it's not a what you are thinking is kind of mid CVD, maybe lower end, upper where you can put a stent, metallic stent and relieve this. And do you think the metallic stent has a better control of cholangitis than the plastic stent?
Better patency rate, sir.
What are the indications of metallic stent in periembolic carcinoma? Target, no cholangitis. Patient has no cholangitis, but somebody advise metallic stent. What situation would be?
In palliative settings, sir. And
when? What are the situations where we will just palliate the jaundice or cholangitis?
Metastatic disease, sir.
Okay. What else?
Patient is not fit for undergoing surgery, sir.
Agreed.
And
Any situation where you may want to operate later on this patient?
in borderline resectable pancreatic cancer, sir.
Madam, you tell is metallic stent is a contraindication of surgery? How it makes the lives of surgeon easy, difficult if metallic stent or surgeon cannot operate?
If the metallic stent is left in situ for longer, there will be tissue ingrowth and dense adhesions, which may make the surgery technically difficult.
Right? How where the adhesions and this thing where it causes, if it is left for a long time.
Between the wall of the CBD and surrounding the stent and the stent.
No, but that's why he has put a short stent, so that you can excise the entire
That the
stent
whole
with the
thing is
specimen.
going to come out, whatever. So anything else? So that's
If
not
it
a good enough.
migrates, if it migrates,
Yes, okay. If it migrates where? Above, below, what happens?
So now tell the complication of the metallic stent. Migration
No,
is
let's just complete it. What other problems of stent? Since he has asked, what are the problems, technical problems related to stent?
erosion into surrounding structures, migration.
Anything else?
grade 2, and what can it lead to subsequently after migration? Surrounding structure is portal vein. Surrounding structure would be arteries. Surrounding structure would be duodenum. Surrounding structure would be liver. Even the first part of the duodenum is stomach. There are so many organs. What it can lead to if it migrate to?
It can erode into the vessels and cause bleeding.
Have you
But
ever read it? Or,
Sadek,
yeah.
the answer for you have asked is for preparation of a patient, and I don't think you're ever going to wait that long that the stent
Yeah.
will cause all these
See,
problems.
one of the things which you have to notice is that's why we keep on emphasizing a short stent. If there is a misplaced stent or a longer stent which goes high up in the hilum, then you will be forced to make that transaction of the bile duct much higher, because taking out this uncovered stent or metallic stent, it causes lot of reaction on the mucosa, which makes your subsequent anastomosis and all at risk. And that is why the key is it should not go high up into the hilum, because that is what makes the technical difficulty or additional problem during surgery. Okay.
I think we can go to the another. We can
So-
stop it here, and we can go for the another
But
case.
you have not given an answer
No.
to them about patient has come with cholangitis having had a stent. You have put an NBD. 2 days later, he is afebrile. He is perfectly eating well. His cholangitis is gone.
Yeah.
When are you going to take
Yeah,
him
Uma,
for
you want to
surgery?
tell?
You have not said that.
Yeah, she will tell.
We'll follow the patient up clinically and with the investigation, sir. If the LFTs are okay and TLCs are better, we may consider operating in the same admission, sir. Probably maybe within a week or so.
Yeah, so I mean the delay is not related to, unless the bilirubin is very high, it's not coming down. There are other comorbidities for which you want to optimize the patient. If the need for intervention or drainage was only cholangitis, you can clinically evaluate that. And once it settles and is reasonably well, the patient, then you can opt for surgery. Because the longer you leave the stent,
I would disagree a little bit that
just
if
can
the
I
patient, yeah.
finish? So if you leave it a little longer, then you run the risk of having complications due to blockage of stent, and again you have to go through that cycle all over again. So you need to find the optimum window wherein, depending on the severity of cholangitis, how long you want to wait and get the patient in a condition where you have to operate. There's no set time that this is the time after which you can do, or this is you must wait. So it's a dynamic assessment of a patient based on all these factors. Yes, Dr. Ramesh.
No, I just want to tell you exactly the same thing, the severity. That is, if the patient presented with shock and was very sick with the cholangitis, definitely my period of waiting is going to be longer. But if the patient just came with mild fever with chills and his BP was okay, then probably I'll wait for a shorter period. But I would wait minimum for 2 weeks from the time cholangitis resolves. That will be my personal preference. Minimum.
Yeah, I do also agree with that, because invariably these people will have an septic complications post-operatively. So instead, I do wait for a week or two. So I think we need to have a consensus on this.
May I suggest that this is beyond the scope of this PG clinic?
Since
and a case basis decision only can be taken by the treating clinician. A patient who improves dramatically and who has no risk factors may be considered earlier. A patient who is still not thriving and who still has subclinical cholangitis, then you have to search for what the cause is and treat it. If there are comorbid illnesses to be corrected, you have to spend time for that. So I think summarize it by saying that yes, on a case by case basis, a decision has to be taken, but inordinate delay runs the risk of recreating the same indication for which the stenting was done. That should be emphasized.
So
that's all.
the conclusion based on discussion is that it should be decided case to case basis, preferably maybe 1 week to 2 weeks of time. That's all. We can go to the next.
Just one point you said, you made a very broad statement. You said LFT is okay. So when you are in a situation like this, you should be more objective and look at the various parameters of the LFT which will prevent you from doing a procedure now. Or which will say, okay, everything is fine, go ahead. So don't generalize it, be more specific.
Who have not involved actively should take part here.
16-year-old female, resident of Kolkata, student, they came with the chief complaints of pain in the right upper abdomen with fever, high grade, and yellowish discoloration of eyes for a period of 10 days in May this year. History of present illness, she was apparently alright when she developed a pain in the right upper quadrant, dull aching, continuous, aggravated on taking food, and also complained of high grade fever associated with chills and rigor, associated with yellowish discoloration of eyes, high colored urine, and pale colored stools for a period of 10 days. There is no history of itching, no history of weight loss or loss of appetite, no history of vomiting, or no history of any altered bowel habits. The patient gives a history of similar complaints in the past for the twice in 2014 and 15, for which she was admitted and managed conservatively. At present, she is asymptomatic. Coming to the past medical history, she is a known case of hypothyroid on tablet Theranom 75 mcg since 1 year. No previous any surgical history and nil family history. Coming to the general physical examination, she is conscious, coherent, well oriented to time and place, well hydrated, nutritionally adequate, performance status ECOG 0, afebrile, no pallor, no icterus, no cyanosis and clubbing and pedal edema. Coming to the systemic examination, inspection, abdomen is flat, umbilicus is central, all quadrants moving equal with respiration, no scars, sinuses, engorged veins, hernial orifices normal. Coming to the palpation, abdomen is soft, liver spleen is non-palpable, no other mass is palpable. On percussion, upper border of liver dullness 6 intercostal space, liver span is 12 centimeters. Auscultation, normal vowel sounds. On digital rectal examination, patient is not willing, and other systemic examinations are within normal limits.
So, madam, what is the diagnosis? The diagnosis.
She's a young female presenting with
No,
symptoms of
I don't
colitis.
want explanation. We will come later. Why do you want to think this differential diagnosis?
Most likely choledochal cyst with cystolithiasis.
Yeah. What? Say again.
Choledochal cyst with cystolithiasis.
You know both are same in one diagnosis. If I say the patient has choledocholithiasis, no choledochal cyst, you repeat me.
Because of the age, I was considering choledochal cyst as.
And you said cystolithiasis. Why do you think choledochal cyst with cystolithiasis? You know the diagnosis?
No, sir. It can be simple choledochal cyst.
Simple choledochal cyst.
Also.
Any other differential diagnosis? Can it be choledocholithiasis?
It can be choledochal.
Cholelithiasis with choledocholithiasis?
Yes, sir.
But why it can't be the first diagnosis?
At this age and with repeated symptoms, I thought it was less likely.
What is less likely at this age?
Choledocholithiasis.
Is less likely? Why it is less likely at 16-year-old patient?
She also had symptoms before.
That's why it's very much clear. Symptoms before twice, and this time it's a benign disease. No difference of opinion. Most likely 99.9% benign disease. Now at this age, you should think what are the benign disease one patient can have, and the gender is female. So any disease which is a predilection at this age with the female or no predilection? Why do you want polylocal cyst as a first diagnosis?
Because of the young age.
Okay.
I mean,
Second, you tell. What you do you agree with her or you differ?
I'll agree, sir.
Agree.
So, just
Why?
because of this age and recurrent cholangitis in a young age,
Yeah.
most probably choledochal cyst rather than choledocholithiasis.
What you find if you examine a patient of polylocal cyst at this age? This is a classical finding on examination finding in young patient.
Young patients, usually abdominal lump will be there as a sign for, in choledochal cyst.
So
but
what was the
presentation-
examination finding in this patient?
No positive findings in the examinations.
So
But
what do you think now?
That is not the classical finding. I mean, that is not the most common, finding in the choledochal cyst.
Okay.
Mostly the patients will present with jaundice or abdomen pain rather than abdominal lump. So that is not mandatory to tell it is not a choledochal cyst.
So what will you do to confirm the diagnosis?
Confirm the diagnosis.
See, let me again say this, that at this age, at 16 years old, jaundice as a presentation of choledochal cyst is again unusual. Jaundice is good in children
Infants.
and infancy. So early presentation of choledochal cyst in children presents with jaundice as one of the important features. As you go up the age group, the likelihood of jaundice occurring with choledochal cyst, not that it is not that common. So there will be other symptoms more
Abdomen
common.
pain.
I would still keep as first thing, even if there is choledochal cyst, these symptoms are probably due to stone disease.
Choledocholithiasis.
So you have to keep that as the primary diagnosis and say that possibly there is associated choledochal cyst, which why at the early age this patient is presenting
Developing,
with
right.
these. That may be a better way than straight away committing to a diagnosis of choledochal cyst.
If you say choledochal cyst as the first diagnosis, then every examiner is going to think you have been tipped out of the diagnosis if it turns out to be choledochal cyst. So because you will see 100 CBD stones before you see one choledochal cyst. The ratio is so different. So what is common is common. So I think the
Because this gives an impression to me that this patient has choledochal cyst with cystolithiasis. So suddenly I struck in mind, you are seeing the stone into the cyst means you know the diagnosis.
cyst is explainable because if she thinks of choledochal cyst, then the cholangitis can only be explained by a stone. So that is a given. I think that I can understand. But to tell the first diagnosis of if there was a lump, it's totally a different issue.
Yeah.
Without a lump, I
So-
think CBD stones are so much more common.
So what would you do now? Because we need to go to the examination and evaluation, coming to a diagnosis and treatment plan.
Sir, I would like to investigate the patient, sir.
Exactly what I asked you to do. Now you're saying I will want to do that.
Sir, ultrasound abdomen I will do, sir.
Huh?
Ultrasound abdomen.
With this
Okay.
patient, okay. Ultrasound.
Liver is normal, normal ecotexture. No intrahepatic extrahepatic dilatation. Gallbladder is contracted. Common bile duct, proximal CBD is 10 centimeter and distal CBD obscured by the gas. Water vein. Spleen is normal. So CBD dilatation is there, sir.
So what are the important other points which you wanted to see is not there? You have to highlight that.
Stones, any
No?
stone.
So there are no stones either in the gallbladder or in
No.
the bile duct,
Yes.
which is seen at least on ultrasound.
In no intrahepatic dilatation, sir. So
Important thing is the distal CBD is still we don't know because of the obscure. So it's not clear what is lying. Maybe still choledocus, the type 3 type of choledochal cyst here. So what will you do next? Because it's the diagnostic dilemma is there. What next investigation?
it can be also stone in the distal insert. So
So what would be the next
MRCP, MRCP.
MRCP. Go to the MRCP.
MRCP, MRCP.
While we are waiting for that, any other possible diagnosis in a patient 16-year-old with recurrent episodes of jaundice and cholangitis with lower end, presumably a lower end block?
And no IHBRD. The patient with jaundice who has no intrahepatic biliary radical dilatation. What are the causes?
Autoimmune disorder. Any
The question is very simple. In a patient with obstructive jaundice, there is no intrahepatic biliary radical dilatation. What are the possibilities?
Find a colorectal cyst. Intrahepatic radical would be dilated, not dilated, or centrally dilated. Have you heard this terminology? To answer this question based on this, there may be some situation where intrahepatic duct does not dilate, but CBD still would be dilated.
So, type 1 to colorectal cyst. Type 1, sir.
Okay, read the MR.
Liver is contour is normal, sir. There is no lesions in the liver, and there is IHBR dilatation is there, sir.
IHBR is there? Where is that? Go back. There is of this left duct, left lobe.
Phylum, the hepatic duct is dilated, sir. Common hepatic. CBD is dilated. And there is a smooth narrowing. Not able to see the PD.
Just scroll up a little bit. PD, can we see PD? Not seeing it.
Anything else you can see on the image which is significant, which looks prominent? Is the spleen normal size?
Spleen is in line.
Is that significant in this case? A 15-year-old with some jaundice.
Hemolytic anemia.
How would you evaluate that?
Complete hemogram and peripheral smear.
That's it. That would be enough. Okay.
The left duct is dilated, sir, and
So now,
CHD-CBD.
now you're seeing, just describe all the findings, or can you just window it a little bit to see the... Okay.
The common channel is long, sir. There is abnormal pancreas junction.
Yes.
When do you say that common channel is long? How do you know that this common channel is long?
Sir, when it is inside the duodenal wall, it is normal, sir. When both the join outside the duodenal wall, it is abnormal pancreatobiliary junction. More than 5 mm, it will be usually outside.
5 mm.
11 mm, 10 more than 10 mm.
15 mm is the usual thing. Joining outside the duodenal wall and a length of at least 15 mm. And what is this kind of union?
Tomy classification.
Yeah, what is that?
Don't
So it's a acute joining.
Type 2.
It is the PB type of union. Any other findings you have?
There is narrowing.
No, another very distinct finding. Look at the cystic duct. Cystic duct is normal.
It
is
is
also
dilated.
Right. So this is one of the variants of choledochal cyst wherein the cystic duct is also dilated.
Type 6.
Yeah. Not type,
Type
6.
6 is isolated.
Isolated.
Isolated cystic dilatation is type
1D.
6. So this is type. Which type of cystic? Choledochal cyst.
1D, sir.
D.
Cystic duct also dilated.
That way.
A is cystic, B is saccular, and C is fusiform, sir, and D is associated with cystic duct dilation.
Okay. So now this is choledochal cyst. Why do you think patient has jaundice? Is there any reason for that in this? You can find out.
There is no stone.
That's a little unusual, right? You would expect with the presentation. Of course, patients with choledochal cyst can present with jaundice, but the way this is with cholangitis and all, it's a little unusual not to see a specific reason. You could still have some sludge or debris in the choledochal cyst, which could be leading to this type of clinical presentation. So, what's the plan?
So just one question.
Yeah.
You said that Dr. Ramesh pointed out spleen is enlarged. Here is a patient who has recurrent cholangitis. Is there any other reason other than hemolytic jaundice?
Total hepatitis.
You too? Secondary biliary cirrhosis.
Sir.
So that brings us to the answer to the question which I was asking you. The causes of typical or obstructive jaundice without IHBRD. One is cirrhosis. Second is cirrhosis cholangitis. Third is
AIDS
liver which is riddled with metastasis. If you look at the surface of the liver, you see outline. Keep your mind open for causing.
One thing is, the early obstruct, it may take up to 2 weeks for IHPR to dilate. TB dilation is instantaneous. It may take up to 2 weeks also. So one of the more common causes.
Yeah, I think with jaundice, we ought to see the liver function there. But with jaundice, splenomegaly, and this kind of clinical presentation, you have to see things beyond just choledochal cyst as the primary problem. There are associated problems which you need to resolve before you, as part of your management strategy. So,
I had a question. There was a left hepatic duct dilatation in a discontinuous fashion on the MR with a Mickey Mouse ear kind of a configuration. I thought that's immediately should raise the suspicion of something and should also mean that some intraoperative aspects have to be covered. There was no reference to that, so I wonder whether you have a. Did you look at that at in the MRCP?
Yes, sir.
Okay. I don't know why it was not highlighted. It's certainly there.
The septum is there.
You can see almost discontinuous left hepatic duct dilatation with a typical Mickey Mouse ear.
But does it change the classification or the type of choledochal cyst? Type 4, what happens in type 4?
Type 4A, B, sir. A is both intra and extrahepatic.
Yeah,
Multiple.
so what is the sort of morphological pattern which determines type 4? What are the characteristic features of that?
Multiple cystic dilatation.
So this is because either of strictures or membranes or webs which lead to saccular
Yes.
dilatation, usually of the left duct. It could be on both sides, right? So that is what Dr. Ramesh is trying to point out. So we would have, that's the reason I was saying just window it a little bit more so that we can appreciate all the ducts. So that is, how does it change the management? There.
Intraoperatively, we have to do cholangioscope and see the left.
So you need to be more vigilant about dealing. So it can't be just subhilar transaction. Even if you do a subhilar transaction, you have to go in and take care of these webs and strictures while managing this.
In the right hepatic duct is seen here.
Even at the hilum, this seems to narrow, and you see that
Okay.
at that point, and
The left duct origin.
yeah,
appears
it
right.
appears to narrow. Now the problem is that many people will just go and cut it at where it's dilated and do a bypass, but the narrowing will lead to long-term secondary biliary cirrhosis or
Yeah, that's
and
what
complications.
that we have to address that. So again,
There-
now prior to planning the treatment, anything else that you would want to do in this patient with all that what we discussed, which Dr. Bhalla pointed out, which Dr. Ramesh pointed out, and the presentation of this patient? Or is it just a run-of-the-mill, straightforward choledochal cyst?
ERCP and can evaluate that left.
We were just discussing, no? Because of splenomegaly, jaundice, all this,
Sir.
does it fit with what you're saying as a morphological choledochal cyst morphology which you're saying? Does it, you want to see the LFT to see what is the extent of jaundice?
Ultrasound also we want to see. Bilirubin is normal, sir. OTPT.
There was a history of jaundice, I thought somewhere jaundice was there. Without
OTPT is
intervention, it has settled
normal,
down.
sir. Albumin is 4.3 normal.
Okay, anything else you want to do before you plan the treatment? Splenomegaly is there.
Endoscopy we will do, sir. Arisis.
Upper GI endoscopy. Is it done?
It was normal, sir. Report is not there, sir. It was normal. Sir.
Okay. Okay. Right. So anybody else wants to take up some of the things which, so what are the, who wants to take up? Yeah. Rajat, you want to take up? You are not spoken since.
Yes.
So how will you plan the treatment for this patient?
Sir, after looking up, after PAC workup and the patient's functional status is fine, sir, I will put for surgery, sir. And I would like to do cyst excision and Roux-en-Y hepaticojejunostomy.
So in this choledochal cyst, when you deal with it, what are the important technical considerations that you will have in this patient?
Sir, after opening the cyst, I would like to do choledocoscopy to see any debris is there or not, or any septation are there. If it is there, I have to extend the that stoma toward the left duct so that the proper drainage will be there in the future.
So the proximal ducts, you will pay specific attention because of the issues that are stricture and webs which we have pointed out. So that needs to be dealt with, otherwise it will be an incomplete. So you have to have a subhilar transaction, extension into the left duct, and if you have facility of choledocoscopy, look into the left duct and ensure that all the webs and strictures have been taken care of. So that is the proximal part. Then distal.
What about the distal? The main concern would be your distal transection and pancreatic duct to avoid injury to the how far you can go, how will untie the end, and where will you divide. Otherwise, you may likely to injure the pancreatic
yes, sir.
duct, post-operative pancreatic fistula.
Sir, that distal extension will be up to where the smooth tapering in the distal CBD, and as possible to remove and limiting to up to 5 mm, not more than that, from the
See,
junction.
again, don't give theoretical answers. You have seen the cholangiogram.
Yes, sir.
What do you mean where it is distal tapering?
It's
You're
nearby pancreatic duct only.
So pancreatic duct, and there's an acute union of pancreatic duct and biliary duct.
Yes, sir.
And the tapering is going on to a great distance.
Yes, sir.
So how will you decide, or how will you make sure that you don't injure the pancreatic duct in this situation? Not theoretically.
Sir, I limit my dissections in the intrapancreatic portion and remove it little earlier than the usual.
Okay. So what you have to say is that you will open that cyst towards the lower part in order to visualize from inside, and then carefully dissect the intrapancreatic portion. There is very little you can do to identify intraoperatively where the duct is opening, unfortunately. So you have to have these measurements pre-op on this and make an assessment intra-op that above that how much distance, and with the pancreas how much intrapancreatic part you have to remove. And then you have to do that excision, ensuring that you don't disrupt the or damage the union part between the pancreatic duct. So that it's a tough decision, and I agree with you that it is better to err towards preventing injury to that than ensuring that I'm removing every bit of extra choledochal cyst in the intrapancreatic part.
Then I would like to get a PD stenting, sir, for a post-op period.
Is there a way, anything to do on the table?
Yes, sir. Lateral duodenotomy and pancreatic duct stenting, and then
how easy is that? Identifying the ampulla and then stenting the pancreatic duct. If it's, yes, theoretically it looks very easy, but doing it, it's not easy. Yeah.
Dilating the ampulla, or papilla, trying to get, it's not direct communication to the PD. It's going through the common channel into the bile duct and then going to direct that. It's not easy. So see, this question often comes up and it is a difficult problem. I think at that point, I would not try to do anything heroic in this situation. There are two options you have. You have a small sort of cup over there where you have dissected that. So you can put that same rule loop with the anastomosis there so that the pancreatic juice will drain in on that. And if you are not certain of that, and if things are not very clear, you may leave for the time being with a drain so that we will see that over a period how it behaves. But doing something heroic as at that time doing a duodenotomy, identifying the ampulla, trying to cannulate, ensuring it goes into the pancreatic duct and put a stent, it's quite tough.
Is there a way endoscopically can we do a table stent?
yes, sir. On table endoscopy can be done.
Yeah, good endoscopy.
Okay, we can now.
No, but the only problem with leaving it alone and putting a drain is that at that point it will stricture. And then you will get chronic pancreatitis and other complications.
No.
So you have to.
That will anyway stricture whatever you do.
No,
of
if you put a stent like he's saying, if you do it in some way early, either by endoscopy or by opening the papilla, it's not difficult. Once you open the papilla, you will have to, anyway the bile duct is gone. So if you just open the papilla, there'll be only one duct into which it will go. It will go into the PD. You can get a stent across the guide wire. You don't put a stent straight in, you put a guide wire. You put it in. That will prevent a stricture.
Okay, can we wind up now? So thank you very much. We have a wonderful discussion and maybe good clinical discussion. Thank you.
Thank you, sir.
Move on to the next case. I'd like to request Saurav, Usha, Supreet, Srinivas and Archit to come. Faculty for this session, I would like to request Dr. R. A. Shastri, Dr. Anil Agarwal, Dr. Chetan Kantharia, Dr. Pawan Kumar, Dr. Vikram Kate, Dr. Ramesh Ardhanari. Okay.
Good morning, sir. We'll be presenting the case of a 68-year-old gentleman hailing from Nellore district of Andhra Pradesh, businessman by occupation, who presented with chief complaints of difficulty in swallowing since 1 month. History of presenting illness. Patient was apparently normal 1 month back till he developed difficulty in swallowing solid food, which was insidious in onset, and it was associated with sensation of the food sticking in the upper part of the chest. Initially, he was able to swallow solid food with some difficulty, which has now progressed, and now he needs liquids along with the solids to facilitate the swallowing of the food. This is associated with unquantified loss of weight and with decreased appetite. There is no history of odynophagia, halitosis, neck swelling, gurgling sound while swallowing, and he does not give a history of difficulty in initiating swallowing, nasal regurgitation, nasal twang, dysarthria, or choking sensation. He has no history of chest pain, regurgitation, relationship of dysphagia with the temperature of the food, or posture change to facilitate the swallowing of the solid food. There is no history suggestive of cough with expectoration, upper respiratory tract infection, and recurrent fever with chills. There is no history of coughing or choking after the swallowing, hoarseness of the voice, or pain in the back. There is no hematemesis melena, no abdominal pain, nausea, vomiting, or altered bowel habits. He doesn't have any history of corrosive intake or long-standing symptoms of gastroesophageal reflux. There is no history of jaundice, respiratory distress, or bony pain. For the above mentioned complaints, he sought medical attention. He was evaluated at a medical facility and he was subjected to an upper GI endoscopy. And he was referred to higher medical center for further assessment and evaluation. That is why he has come to Asian Institute of Gastroenterology. He has not received any modality of treatment so far. The past history, there is no history of tuberculosis, chronic obstructive pulmonary disease, diabetes mellitus, hypertension. Family history is not contributory. He does not smoke, he doesn't consume alcohol, has mixed diet, normal bowel and bladder habit, there's no sleep disturbances. There is no history of any major abdominal surgeries in the past. He is able to perform all the daily routine activities without difficulty and is able to climb 2 flights of stairs without any difficulty.
So your history was very complete. Based on your history, what do you think you are dealing with?
Can I summarize my case first?
Yeah, please summarize.
So we have a 68-year-old gentleman without any comorbidities, with no history of smoking, alcohol consumption, has presented with 1 month history of progressive dysphagia to solids, which is associated with unquantified loss of weight and loss of appetite. Based on the history, sir, my provisional diagnosis would be a dysphagia of malignant etiology, most probably carcinoma of the esophagus.
Yeah, I also must compliment you for a good history. Very well delivered. Just for revision's sake, you mentioned a lot of negative features in the history, which are not generally illustrated by many people. Can you just tell us each one and what clinical relevance does it have in terms of the level of obstruction, the cause of obstruction? So a clinical correlation.
And the complications.
Yeah.
Sir, I had asked initially the first part about odynophagia and halitosis. Odynophagia, I wanted to rule out any pharyngeal cause which is leading to dysphagia. And halitosis, neck swelling, gurgling sound. He's an elderly man with complaints of dysphagia. So I just wanted to rule out a Zenker's diverticulum and whether he has symptoms suggest.
Just a bit before you
Sir.
proceed. Okay, let's take the first thing what you said, odynophagia.
Yes, sir.
In a patient who has got odynophagia,
Yes.
shouldn't they have this what you said, that difficulty in solids, and the patient has to take liquids and then pass the solids with the help of liquids? Should it be like that?
No, sir.
So that is a little difference. No? Is it not? In
Yes.
odynophagia, the patient will have pain on swallowing everything.
Yes, sir.
Please proceed.
And sir, I have asked about whether he has any difficulty in initiating the swallowing and whether he has any nasal regurgitation, to rule out any pharyngeal cause or to rule out any neuromuscular causes of dysphagia. And I wanted to rule out whether he has any stroke or anything. So I wanted to ask that part. And doesn't give any history of chest pain, regurgitation, or relation of dysphagia to temperature or any postural variation. I wanted to rule out any motility disorder of the esophagus, which probably compels the patient to change the posture or which is aggravated by the change in temperature of the food. So I wanted to rule out a motility disorder with this history. And expectoration, a cough with expectoration.
Anything else will you suspect?
Sir.
When you said postural relationship.
Yes, sir.
If a patient has a particular respiratory symptom related to posture, and then you're suspecting, I'm sure you're going to tell that this patient is likely to have malignancy. You're suspecting malignancy related to posture, what could be the cause?
Sir, it's a tracheoesophageal fistula the patient has. As he initiates the act of swallowing, he'll start coughing. That is the O-nose sign. So that probably
Yes,
suggests
the patient can actually adjust the posture, is it not?
adjust the
To
posture.
have a better elevation of symptoms.
Yes, sir.
Good answer.
Yes. And sir, next I asked about coughing or choking after swallowing, hoarseness of the voice, and the pain radiating to the back. I wanted to, because I had a diagnosis of carcinoma of the esophagus in the mind while I was evaluating this dysphagia. I wanted to find out whether the growth is limited to the esophagus or it is advanced, which may lead to cause in the pain in the back and the associated symptoms. So I ruled it out by asking this question. Hematemesis melina, abdominal pain, nausea, vomiting, and history of corrosive intake. I just wanted to find out whether the dysphagia is because of any inadvertent consumption of corrosives or accidental consumption of corrosive in the past, which may lead to dysphagia. Jaundice, respiratory distress,
I
and
think
bony
that
pain.
might not be related, is it not? Even if it is an inadvertent.
Sir.
A patient will have severe symptoms after inhalation, even if it is inadvertent.
Sir.
Very unlikely that the patient will be
Sir.
unless and until there is a deliberate attempt on the part of the patient not to tell this type of history for some particular social reasons, then you can suspect. That is how you have to answer it.
And I asked about long-standing symptoms of reflux. He does not have any symptoms of reflux. I just wanted to have had a differential in mind. It can be a malignancy of the lower end of the esophagus also. So he does not have any prolonged history of GERD.
No, when you said reflux, was it a correlation with lower end malignancy or something else? I thought you are suspecting something else.
Sir, I had the intention.
If a patient has history of reflux
Yes.
for a long time,
Yes.
now the patient is presenting with dysphagia for 4
Sir,
weeks.
it can be a peptic stricture also, prolonged
That is what
acid
you have to
peptic
suspect
disease.
more often.
Yes.
Yes. That's a very rare thing nowadays, but still,
Sir,
because
peptic
you are
stricture.
mentioning that, you should mention that.
Sir.
Please carry on.
And jaundice, respiratory distress, and bony pain. I wanted to rule out any distant metastatic disease if the patient has, sir. So, and what prompted me to ask is the patient sought medical attention and endoscopy was done, and he was referred to a higher center. So that is the history that. So, thank you.
Yeah, overall, very good presentation. This is
Perfect.
how actually it should be done. Very confident and very good.
If I can just add a word here, a generalized way of approaching a patient. Basically, from what when you take a history examination or investigation, basically you have three things in mind. One is at diagnosis. Second, the extent of the disease. Third, the complement. So if you direct all your questioning, examination, or whatever investigations you are doing towards these three things in a classified manner, you would not be missing anything. Instead of presenting at random, people would tend to present at random. Whatever comes to your mind, suddenly you remember. That though you might have completed entire points, but they are not in sequence and they would not be.
I would compliment the presenter on the history presentation. I could find no fault with it. And actually, from yesterday, from all the history presentations we heard, this is probably the best.
Yeah,
it
it is
was
excellent.
relevant, it was clear, and it was followed
the
in a
point and
step-by-step.
precise.
I liked it.
So what's the current level of dysphagia? With solids about how
Yes, sir.
long ago?
Sir, it started 1 month back.
Right.
He had mild difficulty while swallowing the solids. Within a period of 1 month, it has progressed, and now he has to take water along with the solids to facilitate the passage of the food contents. So it is.
That is for the solid filter.
That is
He's
for the.
able to take the
He's able to
semi-solid
take. He's able to take semi-solids, sir, and he's able to tolerate liquids also.
Okay, next person can present the
Yeah,
examination.
just one line I would like to add, just complimenting him again, that actually basically when you are asking history, you should actually place yourself as a clinician who is in charge of the patient and then think, instead of a stereotype what you actually read from the books or from the manuals or from the previous students, how to take a history, you might be having an idea, this is this case, and then going into it, then it doesn't come out that way. So the thought process has to be like that this patient is there, come with dysphagia, what are the things it could be, and you should consider yourself as the in charge of the patient and then think about it. Then it actually comes out very. This is how actually he has done it. That is why it has come out well. I'm sure others also can take that tip and follow that in future. Thank you. Please proceed.
General examination of the patient. Patient was conscious, cooperative, well-oriented, moderately built and moderately nourished. ECOG status was 1, breath holding time of 20 seconds. He was 175 centimeters tall and weighed 61 kgs with a BMI of 19.9 kg per meter square. There was no pallor, icterus, cyanosis, clubbing or pedal edema. Upon examination, there was palpable left supraclavicular node, which was about 1 into 1 centimeters noted. Vitally the patient was stable, afebrile with the pulse with all values within normal limit. Upon examination, systemic examination, oral examination, hygiene was good. The patient was well hydrated with moist tongue, normal teeth, buccal mucosa, gingiva, tongue, facial pillars, posterior pharyngeal wall, all appeared normal. Upon cervical examination, trachea appeared to be present in the central There was no engorged veins, no swellings, sinuses, or fistula. Thyroid was not enlarged. There was a cervical lymph node left supraclavicular, which was palpable, as already mentioned.
Just a second. Something you said about fistula. What was that?
It's a cervical fistula, sir. Any cervical fistulas. On abdominal examination, on inspection.
Why did you ask that cervical fistula?
Sir,
Maybe suspecting a patient with
malignant tracheal, malignant esophagocutaneous fistulas.
Very rare.
Very, very
Spontaneous.
rare. Why it should
Post-operative, yes, but spontaneous, I have never seen a case.
I don't think that should be mentioned.
I don't think I have seen a case.
Unless and until the patient has undergone surgery and you have been referred
Has
to
anybody
post-op
seen a
case, then only that is the relevant.
This is the result of trying to be too thorough.
Yeah.
You know, without keeping your feet on the ground. You ask yourself, have you ever heard of such a complication or seen your complication before you
Too
voice-
theoretical, actually.
So just because it's an exam, don't go overboard with your, one in a billion complications or one in a trillion complications. You don't have to say that. Okay, the notes are important. The fact that the hyoid is not enlarged, even that I am not sure is very important in this.
Thyroid, sir. Thyroid was not enlarged.
The hyoid you said, not
Thyroid, sir.
thyroid. Okay.
Sir, well, during reconstruction, it might pose out difficulty when cervical anastomosis is done.
Will it cause, if it's enlarged, will it cause a big problem?
You've come
You're
across,
already thinking of surgery. I don't think you need
so
to
you've
think
come
of
across any case reports wherein people have modified because the thyroid
Thyroid?
of reconstruction?
See, generally you don't
Have you-
mention all these things in your journal. You keep things very common. What is commonly said, you mention that. Okay? Unless you have something which is there, you mention. Otherwise, don't go out of your way to mention things theoretically.
I would actually appreciate it if you had told us what was the status of his muscles, the deltoid, the triceps, and the leg muscles, whether it was muscular or there was evidence of wasting, because if he's not been eating, he has gone down, there'll be some evidence that the muscles are wasted. That would be relevant to the history.
So keep it simple, because general examination something you should finish fast and come to your main exam.
Yeah.
In fact, you may look for it, but if there was something positive, like in the sense that if there was a obvious thyroid enlargement, you could mention about it. But if it is not there,
then you need not tell it.
Then you need not tell.
Abdominal examination. Upon inspection, umbilicus was centrally placed, inverted, with no discharge or swelling visualized. All quadrants of abdomen moved equally with respiration. There was no flank fullness, no sinuses, scars, or dilated veins, or abnormal pulsations or peristalsis. Hernial orifices appeared normal, with genitalia normal, sir. Upon palpation, abdomen was non-tender, no local rise of temperature, no palpable lumps, no any other organomegaly, no hepatosplenomegaly. Rest of the inspective findings were confirmed. Liver span was 14 centimeters. On percussion, it was 14 centimeters from 5th intercostal space till the costal margin along the right mid-clavicular line. There was no free fluid, no shifting dullness, no normal bowel sounds were heard. Rectal examination, normal, sir. Respiratory, chest uniformly expanding with bilateral resonant node. There was bilateral vesicular breath sounds heard. Rest of the systemic examinations were within normal limits. Summarizing my patient, a 68 years old old gentleman who is a non-alcoholic, non-smoker with the ECOG functional status of 1, presented with progressive dysphagia to solids since 1 month and associated with unquantified loss of weight and appetite, with a BMI of 19.1 with a palpable left cervical lymph nodes. I would like to retain the provisional diagnosis after the history that we had respected. The same thing, sir.
How would you know if he has lost weight?
Sir,
he says, I am not sure. So you want to...
Loosening of the dress, sir, loosening of the dresses.
What dresses?
Sir, shirt and the waist.
Shirt you can't make out in a male patient because the shirt is always loose. Waiting for. In a female patient, the blouse is a correct way to see. You will see the loosening. Male, you won't be able to make out from the shirt. You have to look at the waist, and see whether, and ask him whether he has tightened his belt or not.
Trousers, yeah.
Trouser, that is what you want to ask and see if you are going to observe. That is a good sign of a weight loss.
Do you want to add anything from the provisional diagnosis because you have got some positive findings?
Sir, I would, with lymphadenopathy, sir.
With presence of cervical left
lymphadenopathy.
Okay, let's move on to the
next.
Just one,
Before you
in
move-
summary, yeah, please,
Yeah,
please.
just again, one more word of, over, local rise of temperature in the abdomen is something which you don't look for at all. What is local rise of temperature in the abdomen? Which is the local area you're looking for and why? I mean, these invite questions. They're something. So try and avoid.
I think that
As a matter of fact, I think in a MCH exam, I would not object to somebody presenting a long case to save time on the examination if they say that the examination of the abdomen is unremarkable in one sentence. Because we know that you have been asked about all these questions in your MS. So we know that you're now doing MCH. We are more interested in the management and how you're going to approach. So if it is unremarkable, that is what you write in the case sheet, and you can say that. I wouldn't mind, some examiners might ask, but nowadays with 15 minutes, with 4 cases or 1 hour, I don't think you have time to say everything. So you can just say it was unremarkable and dismiss it off.
And just a couple of comments in the summary that you're talking about. You talked about dysphagia 1 month. It is good to add also the current state of dysphagia, right? To the present status of this, whatever it is. And the second thing is that, as what has been pointed out, in the examination at this level, you don't really, it should be obvious from the way you're speaking rather than saying inspection this, on palpation this, and that kind of a thing, which is always. And the other thing is that, did you include some part of the nutritional assessment in the examination?
No, sir.
Is that important?
What is the status of dysphagia right now?
Sir, currently, according to Sugahara, he's grade 2, sir.
That's it.
Wherein he's taking solids with some amount of liquid with it.
What is the importance of this? In this?
Didn't get you, sir.
Yeah, this information, how it is useful to you as far as management is concerned.
Sir, it depends upon like the complete whether there is a complete obstruction that include with like if the patient is not able to tolerate solids, it means that it might be a completely mural involvement.
No, it's not from that point of view. It's from the point of view if the patient is taking, a patient can take adequate even liquids. Okay, we can maintain the nutrition of the patient while we are actually managing the patient. It's not an urgent thing. On the other hand, if you have a patient who cannot swallow saliva and there is complete obstruction, then you have to take emergent treatment. You have to start the thing in such a manner that if whatever treatment you are giving, okay, it is going to take time. Like if you have to have a new adjuvant therapy, something like that, you have to have an enteral access. That is why it's important to know exactly. If you're saying the patient is still consuming solids with liquids, that is good.
So, madam, coming to you. Now, this patient is with you. You have made a provisional diagnosis of CA esophagus. He has a left supraclavicular lymph node present. How will you proceed?
Sir, first it would be the diagnostic workup, sir. First, I would like to do an upper GI endoscopy along with the blood investigations to get a biopsy of the lesion as well as.
You said upper GI endoscopy with blood investigations to get a biopsy.
Sir, I would like to do an upper GI endoscopy,
Yesterday
sir.
somebody said, no, you have to say the investigation you want and say, and I think Puneet said, along with the routine blood. So,
no, but
so that's why he said.
Upper GI
I think
endoscopy
that is
with
why
biopsy
she said
and
it
blood
like that.
Sir, upper GI endoscopy.
Or is it any liquid biopsy you're talking about?
No, sir. Upper GI endoscopy with biopsy. I want to rule out if there is any mass, see, and then, like along with that, any blood investigation, sir.
Any other investigation you do along with that? When you do your endoscopy, you are going to do blood test. That's different.
Yes, sir.
Anything else you would like to do that? On the same time, you can do it.
Test X-ray, sir.
No, would you not like to do an FNAC from that left supraclavicular lymph node?
That is why I particularly mentioned that you have a patient of malignancy of esophagus with left supraclavicular lymph node. So what would you want to do?
Sir, yes, sir. The FNAC of the left supraclavicular lymph node.
Yes,
as well.
it should be done.
Yes.
And it can do it at the same time as the endoscopy. You can ask the cytologist to come and take the FNAC at the same time. Okay.
So what all would you see on upper GI endoscopy in this particular patient? What do you want to see?
So first, I would like to evaluate the esophagus if there is any mass, and know the proximal and the distal extent of the mass. What is the extent, the
What do you
distance
mean
of the
by
mass?
Mass, what do you mean by mass?
You don't see a mass there.
See, what do you see? A growth.
Growth.
When you,
Yeah.
when you
Normally
look
we
at
see a growth.
endoscope,
Okay, sir.
what are the things you want to see exactly?
So what is the like the type of the growth? What is the extent of the growth? Like the extent of the growth from the incisors, the proximal and the distant extent of the growth. If like the circumferential extent also of the growth.
If you can't pass your endoscope,
And
do the
whether
growth.
you can pass the endoscope.
Sir, mostly because I think the endoscope could be passed because the
So
patient
that
is
is what you have to
having.
mention. I'll see whether the endoscope goes distally into
Yes,
the
sir.
stomach or not.
Yes, sir.
And how will you
Can
get
we have the
that?
endoscopy report?
So, what's the significance of supraclavicular, left supraclavicular lymph node in this kind of a place?
Sir, it gives an idea that what we are dealing with is already an advanced carcinoma, sir. Advanced growth.
So, for carcinoma esophagus, is the significance of left supraclavicular lymph node any different from other intra-abdominal malignancy with left supraclavicular lymph node positive?
Yes, sir. Sir, it is, I would like to say it was advanced, sir, because the supraclavicular is the
What do
cervical
you
group
know
of
about
lymph
the
nodes.
lymphatic drainage of the carcinoma esophagus? And do you think that for some carcinoma esophagus, this may be the early station of lymph node?
Yes, sir. In case if I'm talking about the upper or the middle thoracic tumors, sir, then it is mostly a regional extent of the disease.
Is that the way to tell whether it's middle or upper third? What is essential to say whether it is metastatic or whether it is a locoregional spread? It depends on the biopsy. If your squamous cell carcinoma, then this becomes a locoregional disease.
Locoregional.
If it is an adenocarcinoma, it becomes a metastatic disease. That is the most important thing that I would be looking at.
So, whose paper, this is a very important paper, which is quoted for lymphatic drainage?
We can't hear you, Anil.
No, I'm saying that, can you quote that paper that everybody quotes for lymphatic
Akiyama,
drainage?
sir.
Yeah.
So this is the endoscopy picture. Can you describe what you're going to find in this?
So this is a polypoidal growth, sir. It is there in the esophagus, sir. And
What information you additionally want? Do you think this is circumferential or it's involving one wall?
sir, it is a one wall, sir.
Proximally it is one wall, distally we do not know unless and until we pass the
Yes,
scope.
sir.
It's not actually in one wall. It covers about 2/3 of the lumen. Isn't it? Just 1/3 free.
Yeah, a little bit lower down if you see, there is a possibility that it might be circumferential. When you
Circumferential.
pass the scope only, you will know.
Yes, sir.
Is it not? So
Yes,
that
sir.
information you see, you said you wanted to know the distance from the incisors.
Yes, sir.
Why you wanted to know that?
So because I would have the idea whether it is in the middle third or the upper third or the lower third, sir.
Why do you want to know that?
Sir, because the patient supraclavicular lymph node is also positive, so I would just
Just now you are asked the question, no? If you have upper third tumor, middle third tumor, what is the likely histopathology? Lower third tumor, what is the likely
a squamous cell
histopathology?
carcinoma, sir. So that time this becomes a locoregional disease.
You
Yes,
would
sir.
like to know? You ask that information. Can we have the information how
So
far
here
from
it
the
is.
incisors?
So here it is.
So
So
the
that's what it is.
The G junction is noted at 42 centimeters, and ulcerative lesion starting from 32 centimeters, extending up to 36
Is
centimeters.
that a common site of G junction? 42?
No, sir.
Why it is 42 in this patient?
Maybe he's taller, 175
Not
centimeters.
maybe, yeah, 175. He
175
is tall.
centimeters, he's taller. Yes, sir.
He is tall, that is why that is at 42.
Yes,
So
sir.
32 becomes how much? What part of the esophagus? How do you calculate?
Esophagus is divided into three parts, isn't it? Upper.
In exams,
Sir,
you
it is
don't do
some-
this.
Sir, it is somewhere
How far is the cricopharynx from the incisors? Conventionally.
cricopharynx to incisors is 15, sir.
15. So this is a tall patient, so it could be around 16, is it not?
Yes, sir.
So you subtract 16 from that 42. How much is remaining? What maths you have to do?
28, 26.
How much?
26, sir.
26. Divide by 3. Comes to roughly 9.
3 8, 9.
9,
Yes,
is it
sir.
not? So now you calculate and tell me where it is. The starting point of the disease is middle third, upper third, or lower third?
Sir, it is around, it's a lower thoracic, sir. Lower thoracic.
It starts in the middle.
It
It
starts
starts
at
in
just
the
at
middle and
the
at
junction
the
of the
end of
middle
the
and
middle,
lower
and
third.
it is
Say nine,
And
he has given you
approximately
calculation. 9
Yes, sir.
18 centimeters.
Yes, sir. 18.
18 plus 16 is inside the 34. So
Yes, sir.
34 is where your lower esophagus
Yes,
starts.
sir.
It's around 32. So it just starts in the middle as per this
And
thing,
proceeds
and
to the lower
proceeds into the
thoracic.
lower esophagus.
So likely to be, can be both.
It
Can
can
be
be
squamous cell, it can be
Adenocarcinoma
That is how,
as
that's
well.
why it's very important to do the calculation.
Okay, sir. Yes, sir.
When it is starting point, and then if you ask them whether they could pass the scope through the growth, it's written there.
Yes, sir. The stomach, the duodenal cap, the second part.
Yeah,
they have
everything is there.
passed.
So, so what is the distal limit of the lesion?
36.
36. Lower thoracic.
So 34 centimeters.
As a surgeon, based on this upper GI endoscopy, what impressions have you made with regards to this patient as far as the management strategy is concerned? Of course, we'll wait for the biopsy report and the operability, but what do you start thinking?
Sir, upon this upper GI endoscopy as well as
upper GI endoscopy,
as well as the left supraclavicular lymph node, I would say if it comes,
It's squamous cell carcinoma.
it is the squam.
It is squamous cell carcinoma. Go
It
ahead.
is squamous cell carcinoma. So this
to the
patient
biopsy.
this patient would, on further workup, sir, mostly he would require, he would require a neoadjuvant therapy, and
okay. So the biopsy report has come as
squamous cell
moderately
carcinoma, well,
differentiated
to
with
moderately
squamous cell
differentiated.
carcinoma.
Yes, sir.
So now what
Have you done
next?
an FNAC? FNAC is awaited, they are saying. But let us, for the sake of argument, accept that the FNAC will also show squamous cell carcinoma deposit. For the sake of argument.
For the discussion purpose, we'll assume that the FNAC report is also squamous cell carcinoma, as sir said. Now, how will you proceed? This is your biopsy report. You have seen upper GI endoscopy, your FNAC report. What next would you do?
Sir, I would do an imaging study, sir.
What imaging?
Sir, a PET CT, sir.
You want to do directly PET CT.
With what aim?
What is the objective? What do you want to know?
Sir, because if the left supraclavicular lymph node has also come as positive, and this is squamous cell carcinoma,
Okay,
so
let us-
anyway, it
no
is
one
going
wants
to be
to
neoadjuvant therapy, sir. So it is,
No. Let us, for sake of argument, say there is no supraclavicular lymph node. What would your imaging be?
so then I would do a CCT chest, a neck, chest, and abdomen, sir, and then proceed to PET CT. Sir.
And
then proceed to PET CT, sir.
So, whether this is a supraclavicular lymph node or not, you're going to do a PET CT, isn't it?
Yes, sir.
So you started by arguing that there is a node, therefore I will do a PET CT.
Yes, sir.
But
Definitely.
the node is immaterial as far as you're concerned, because even if it is not there, you're going to do a PET CT for it.
Yes, sir.
Yeah. So why are you going to do a PET CT for it?
What is the objective?
Sir, to
If it was a CS stomach, would you do a PET CT upfront?
no, sir.
CA rectum?
No, sir.
Then why for this CA you are going to do a PET CT upfront?
Sir, in this particular patient, I will do a PET CT upfront, sir.
Why?
Why only in this particular?
Because you said in both the circumstances, you would still go ahead and do PET CT, whether the lymph node was there or not. So why?
No, no, sir. If the lymph node is not there, I would do a CECT chest and then do PET CT.
So then you would have definitely
But
done
you
it.
would still.
May I ask
Yes,
a question?
Dr. Ramesh. Yes.
No, suppose you have a carcinoma of esophagus biopsy proven of the lower third or the middle third, you would do a CCT, you say,
Yes, sir.
and then you would do a PET CT.
Yes, sir.
Is there any situation where you would not proceed to PET CT? You would just stop at CCT and go in a different
No, no,
route?
sir. For all the cases, we have to do PET CT, sir.
Then why should you do a CCT in the first place? Is a
Because
CCT
PET CT will give you the
all information.
things.
Why should you
If
do
you
a
are-
CCT?
As a
unless-
natural corollary, you are saying that from CT, you'll do a PET CT. So then why have in one situation CT followed
Sir,
by PET CT?
CECT is
and
the
in-
iodinated contrast, sir, whereas the PET CT is the FDG PET CT.
Cannot
So
give
can't you do
iodinated
it?
contrast
Can't
in a
you
C-
do?
the standard PET CT involves use of contrast also.
And
It
if
is
you
not
talk
done
to-
plain.
And if
plain,
you-
a plain PET CT is actually to be condemned, and that is the weakness of the PET CT. It can be done in selected cases if your renal functions are kind of compromised, but the ideal PET CT is a PET CT which has contrast enhancements.
But there is a logic in doing the CECT. And
What
then
is it?
What is the logic? Say you found multiple pulmonary secondaries or multiple hepatic secondaries. You found pleural effusion on one side. Then would you do a PET CT?
No, sir.
No, now see, that's what I'm saying. The CECT is useful to rule out a metastatic disease at its level.
Yes, sir.
Yeah. So you're right in doing a CECT because it's much cheaper than a PET CT. Difference is between 5 and 15,000 rupees. At a cheaper rate, you may find some and often you will find metastasis in CH of it. So that is the reason why you do a CECT.
Ramesh, would you like to use the analogy of the ultrasound and the CT
Yeah.
as you do in for HPV
Yeah.
disease?
So that is why Dr. Ramesh asked you a very pointed question that would you do a CCT scan and not do a PET CT in certain circumstances? That is what he asked. So these are the conditions where based on CCT scan findings, you may not do PET CT.
Yes, sir.
So that is why you're answering the question by saying you'll do a CT followed by PET would not be acceptable, because I think, and whenever you talk about an investigation, then you have to look at that what is your aim. And on CT, as it has been pointed out, some findings will make you not go to the PET CT, because the situation that he talked about on CT, if you had these multiple sites of metastasis, why do you want to do a PET? Do you want to do a PET?
No, sir.
Right. So, and then the cost consideration is there, because if the cost was the same, and as Dr. H. Ramesh said that even in PET CT, if you told your people, they would give you the films as you would do for a CT, contrast images. So in fact, in situations where you need both the complete information that you get from a CT and a PET, you could do one investigation.
No, but unfortunately, most of the PET CT, the CT scan is usually a 16 slice at the very maximum. Though some centers now have even a 128 slice.
Now I think that
now
is
they have.
changing.
But if they have
Now that
only a
is changing
16
in the
slice,
sense of that.
you may not get the information that you.
In exam,
But sir, but the point is, because again you have to be clear in your mind that when you talk about different 16 slice or 128 slice, I mean, what additional information you're getting? Like for carcinoma esophagus, probably in a 16 slice also, you would get the same information that
Secondaries
you are
you would
looking for.
probably get, yeah.
Right, because I think it's the acquisition time that we are talking about. That is why when we talk about 128 or 256 and others, it is more to do with the acquisition time between one heartbeat. So I think probably,
May I just add to that, because radiologists are very clear about this, that if you have a multi-detector row CT, a 16 slice CT will give you admirably good picture.
Exactly.
It will take a little longer time to acquire,
Yes.
as Dr. Anil Agarwal so eminently put it. So there's nothing fancy in the 256 slice.
And also,
CT.
It's acquisition time.
A lot of it is software as well.
And
Software
also you should know that if you actually go to the radiation, if you go to the CT scan room, even if you have a 128 or 256 slice scanner, most common CTs are done only with 16 slices. Because if you use 128 slice on every patient, your tubes will go very fast. It's very expensive. So they usually use only 16 slides. So that way you will get.
Yeah, I mean, as he's saying that in fact now a lot of centers actually have one high-end 256 or 128 slice CT and one maybe 16 slice or 32 or whatever.
Basically, in exams, you being a good student, you should say that I would like to do a CCT scan where I like to see so and things, and based on that, proceed ahead to do a PET CT to rule out this thing.
So,
Yes, sir.
if the normal CT shows no second, are you going to proceed to a PET CT? Because for rectum and for stomach, you said no. For this, are you going to do a routine PET CT for all patients?
Yes, sir.
Why?
Sir, the metastatic potential of esophageal cancer is very high, sir. And
Very good.
the second is all the guidelines, sir. The NCCN
Yes.
also recommends FDG
So,
PET routinely. In
why do they
carcinoma
recommend?
esophagus.
Because the metastatic potential being high, they don't want you to embark on a curative maneuver if already there's a brain met, bone met, or a hidden met somewhere. They don't want you to proceed on a neoadjuvant path or other curative path, but to go on a palliative treatment path. So they want to eliminate, because there's a high percentage of metastasis in squamous cell carcinoma.
Yes, sir.
And part of how you proceed from here will depend on what interpretation have you made of the left supraclavicular limb. You know, on one hand, you are talking about that it being an advanced disease, because then the neoadjuvant doesn't come into it.
Yes, sir.
But if you are talking about neoadjuvant, that means that you are considering it as a loco-regional disease and trying to do with your management.
Yes, sir.
Do we have CT findings?
Yeah, can you interpret the CT? No, instead of finding, you would have shown the picture.
Yeah, read it for us. Yep.
He is putting up the CT. Is there a role of endoscopic ultrasound in this case or otherwise in carcinoma esophagus?
Sir, in this case, there's no role of EUS, sir. But in case if it is an early stage disease, then to differentiate between the T1 versus T2, to see the local regional lymph node, local lymph nodes. Yes, sir.
How is it helping in the early stage?
Sir,
I
if
mean,
you are
these are two
planning an
different things that you are
endoscopic,
talking about, because one you are talking about the T stage,
yes, sir.
and one is the lymph nodal stage.
Yes, sir.
And what is the significance of better assessing with an endoscopic ultrasound, and how does endoscopic ultrasound compare with the CT scan for T stage and for
Sir, first, the T1 versus T2 is a very, very early stage tumor, which is quite rare to find. But if it is a T1 tumor on endoscopy, the EUS will give us a better understanding of the T1 subsections, T1A, T1B, or T2, and also the local lymph nodes. So if we are planning an endoscopic resection, that's where the role of EUS.
We'll come back to that. CT is already put up, so read that CT.
Do you have a pain CT with only oral contact?
Sir, there's a lesion, the esophagus, the trachea, and the arch of aorta, sir. The tracheal bifurcation. There are no obvious lung metastasis, sir.
Okay.
And there's an esophageal growth, sir, towards the lower thoracic part, at least after the tracheal bifurcation. There is no obvious involvement of the
Or bifurcated.
Yes, sir.
Growth there or there's no growth?
There's a growth, sir.
There's no growth.
Just
Above the
below.
bifurcation.
I mean,
Is there a growth
just below.
at the tracheal bifurcation? Is there a growth? What are you talking about? Maybe are you looking at the collapsed esophagus there, or is there a growth there? Because that is not congruous with your endoscopy finding. What level is carina?
The carina is around 25 centimeters, sir.
I think classically it is talked about 24, no? 24
24 centimeters.
Okay. So yeah, so I mean,
Sir, I will just point out where I have exactly seen the growth, sir.
yeah, but this cut, you may point out where you have seen the growth, but if you are put up this cut, you should be able to tell that he asked you this question, that is there a growth on this cut or not? Looks like that you can see the lumen. There's some dye in the lumen.
Yes, sir.
Right? And though it seems to be a collapsed kind of a thing, but you don't see any asymmetry in the wall, do you?
No, sir.
I mean, probably the thickened wall of the collapsed esophagus is what you are probably interpreting that as tumor.
Yes, sir.
So you have to look up and down.
So here on, there's a growth, sir. A little bit.
The pointer is with you.
Yeah. Now I think because then you had seen on the asymmetry on the wall and the wall. Yeah, that's probably the tumor. That there it's pretty.
What is that? Let me show you.
Sir, there is no obvious tracheal bronchial invasion, sir, but there could be a contact with the aorta, sir.
Is it more than 90 degrees or less than 90?
Less than 90, sir. Less than 90.
What is worrying you there?
So this diaphragm.
Yeah. Right. What is that?
There is contact.
Contact or maybe
Diaphragm, sir. Yes, sir.
Maybe very that.
Yes, sir.
Locally at all.
Yes, sir.
Insufficient oral. They're not given oral contrast.
Yeah,
This is they are showing clean with
Plain,
some oral
plain, I
content.
Yeah,
So maybe that was just the lumen which was.
no oral contrast in the middle. But in an esophagus, radiologist should have done an oral contrast without IV contrast.
Yes,
Because
sir.
that will show you better the dilated portion, where is the tumor, how far is the narrowing. The oral contrast would have got a lot of information. They have given it, but all over there is some oral contrast. Not.
So is the length of the esophageal involvement has a bearing on the management? Like in this case, it was 4 centimeter. Let's say on CT, it is assessed to be 5 centimeter. Does it have any bearing? 4, 5, 7? Is there any literature talking about it?
Sir, it is said that if the extent is more than 7 centimeter, it is bound to be a highly advanced tumor.
Don't
or
use such
metastatic.
strong words. Bound to be?
Matlab, it is assumed to be a metastatic tumor, sir.
Metastatic tumor.
Sir, if it is more than 7
Metastatic. Metastatic.
Advanced tumor, sir.
I mean, if
Advanced.
it is metastatic, then you will get to know by the other investigation.
No, sir, it is an advanced
and
tumor.
you said that even if it is not a high risk metastatic, you are going for PET. So how does it matter?
Sir, it
so
is.
I am just talking about that. A is the length, or do you take into account some other things when you talk about management rather than just the length of the lesion involvement? And what does it connote? So are you trying to say that if it is 5 or 7, then you don't consider surgery?
No, sir. I don't remember the exact article, sir, but it is said that if it's more than 7 centimeter, it is most likely that we will not go for an upfront resection, sir. These patients are advanced tumor.
I mean, that is what used to be said, but now even much before that, you will go for neoadjuvant.
Yes, sir.
So that logic again also doesn't hold so much.
Yes, sir.
That in 7 centimeter only you are going for neoadjuvant. Are you looking for other factors in addition to the length of the lesion?
Yes, sir. The other factors.
What are the other factors? I'm talking about the
Like-
lesion. Yeah.
The lesion on endoscopy, sir. The endoscopic extent.
Endoscopy or imaging, yeah.
What is the extent of the tumor from the incisors, from the GE junction?
Let's say it is starting at 32 centimeter, the same tumor, but extending till a little above the G junction. That is 7, so 32 to 39.
Does it matter on the endoscopy whether you see an ulcerated growth or you see a proliferative growth hanging into the lumen? Both are squamous cell carcinoma.
Sir, yes. Whether it is an ulcerated growth or a stricturing growth.
How does it matter?
How does it matter?
Sir, that is because
So you could have stricture, you could have ulceration, or it could be a polypoid growth growing into the lumen with no ulcer.
Yes, sir.
So which has the best outlook?
Sir, among them is the polypoidal growth, sir.
Why?
Because it has a stalk, so the infiltration of the tumor.
No. What is the difference between an ulcerated growth and why is that growth ulcerated?
It is an advanced, sir. It is
No.
the difference.
It is growing so fast that it is outstripping its blood supply. See, that's what the ulcer in a growth means. That it is growing faster than its blood supply. When you have proliferative growth with no ulcer, that means the blood vessels are keeping pace with so it's a slower growing tumor. Therefore, the prognosis is better everywhere where there is a polypoid lesion and an ulcerated lesion has a worse prognosis. The simple logic to it.
Okay.
So, you have got a contrast CT of the chest. Can you see and tell me what you see there? Point out the important structures as you go.
So this is the aorta, sir. This is the tracheal
No.
bifurcation.
You can't say aorta. Aorta has 4 or 5 parts. Which
yes,
part
sir.
is it?
The descending aorta.
So this is the descending aorta. Okay, then?
Then this is the tracheal bifurcation, sir. This is the esophagus.
Where is the tracheal bifurcation?
The one.
Much higher. That's much higher. It's not here.
Sir, okay. Yes, sir. Here.
So it's much higher, not where you showed it. This is significantly at the higher level. Yeah. At the site of the tumor, you don't have a bifurcation. What else you have?
This is the esophagus, sir.
Hmm.
This is the lumen of the esophagus, sir.
Oh,
There
what
is
is that
obvious
vessel going up from the aorta up like that? You see the aorta and then in front of that a vessel which goes up adjacent to the esophagus. Go up.
This one?
No, yeah, that one. What is that? Very
Pulmonary
important
artery.
landmark in esophageal surgery.
Pulmonary artery, sir.
It's the inferior pulmonary.
Inferior pulmonary vein.
It is very low down. So very often you will stop doing dissection line at that stop, at that stage, because beyond that if you injure it, you just can't control it. It will bleed. It's a very thin vessel.
Okay, sir.
Is it a very thin vessel? Which is thinner, the pulmonary artery or the pulmonary vein?
Inferior pulmonary vein, sir.
So, the inferior pulmonary vein seems to be quite close to the tumor, isn't it? See that at one point actually it sort of lies on the tumor. So you have to be very careful whenever you operate, if you operate, for that point. Okay.
Yes,
Sir, we now move to the next person.
Next person, yeah.
So this is the imaging.
So now you got the images. PET CT, what is the report? Just give the PET CT report. Images are not required.
Just to put that in perspective, it's just not the length, but also one used to look at the axis deviation and also the T stage in terms of how much it is circumferentially spreading in addition to the lymph nodes, etc. So I think you take all that in toto and then decide. And yes, most of them you may go for neoadjuvant before taking up. And I think together with that what is the stage of dysphagia would be contributed to how you manage such cases.
So this is your PET CT report. Okay. For the purpose of discussion, we forget about this bilateral supraclavicular and subcarinal. Okay, we assume that there is no metabolic activity there. For the purpose of discussion, so now how will you proceed?
I would first like to, with this and the squamous cell carcinoma as the biopsy, I would like to first start the patient on a prehabilitation protocol and then plan the patient for a neoadjuvant chemoradiotherapy in this case.
What is this prehabilitation protocol?
So prehabilitation consists of various parts. Sir, it involves starting the patient on taking care of the patient's nutrition, taking care of the patient's respiratory patterns and even the psychological.
No. So how long you're going to spend on this before you start your treatment?
So, it gives us, if we are planning for a neoadjuvant protocol and then contemplating a surgery, it gives us a window for this for planning a prehabilitation in these patients till the time we prepare, till the time we come to surgery, during the neoadjuvant and the post neoadjuvant waiting.
So it's an ongoing process. It's not a separate process where you spend some time on it. So you do it with the neoadjuvant protocol. So that is fine.
So do you mean to say you would be doing rehabilitation as a part of ERAS protocol, or you're going to do rehabilitation as an isolated protocol?
The rehabilitation as an isolated protocol.
Why not ERAS protocol? That is the standard of care now.
Does improving the preoperative nutrition make any difference in the outcome of the treatment?
Sir, not just the nutrition, sir. Prehabilitation.
I'm asking you a specific question. You said nutrition. So does nutritional rehabilitation have any outcome effect on the treatment?
Sir, in upper GI cancers, it is believed to reduce the ICU stay in these patients.
Do you have the proof from any paper? Most of the papers suggest that even improving the weight. So there was a time when esophageal cancer patients used to be routinely put on total parenteral nutrition if they couldn't eat by mouth, or on a jejunostomy or a Weil's tube feed, try to improving their weight and waiting for a 10% gain. But none of these have shown any improvements in the outcome of treatment. They have not shown better wound healing. They have not shown better survival. Somehow the nutritional treatment up front doesn't seem to affect the outcome of surgery in GI cancer. This is the overall picture that we get from most of the patients. So, as you do your neoadjuvant, you may give treatment.
What are the components of rehabilitation protocol?
I also want to draw your attention to what you said. You said it is because it is squamous cell carcinoma, you will go for a prehabilitation protocol. Do you still, can you explain that? You mean if it is adenocarcinoma, you would not?
No, he didn't mean that, I'm sure. It was just,
so you, please do not
it
blurt
came
out
out such a way that you said
came out in such a way, but he didn't probably mean it. It was a
obviously, but
slip of the tongue.
Once you have said at least you should correct yourself. If you
Yes.
sometimes you flutter, then you should immediately correct yourself before.
Yes. Yes.
What are the components?
Now you have decided, it seems, on a neoadjuvant protocol. When you say neoadjuvant, that means that you're going to follow it up with surgery. It means you're going to follow it up with surgery. Extensive nodal metastasis.
So we said that for the purpose of discussion, we are going to keep this by the side.
Oh, you're keeping it by the side. Okay. Let us keep
Before you embark on
even
this,
let us keep it by the side. Let us say no nodal. Are there any other treatment protocols available for esophageal cancer?
Yes, sir. Sir, it can be we can plan the patient for a neoadjuvant or a definitive chemoradiation, sir.
Okay. How are the results between definitive chemoradiotherapy and neoadjuvant followed by surgery?
Sir, in definite chemoradiation, sir, if it is a cervical tumor or an upper thoracic tumor, definite chemoradiation may be preferred to a neoadjuvant followed by.
No, let us talk of mid third and lower third, because that's the other third we don't usually treat. It goes to the oncologist.
that is the only treat for the upper third. That is the only treatment.
Yeah.
So assuming that this patient, where it starts from the middle third and goes, and
What is the outcomes of treatment of chemoradiotherapy versus your neoadjuvant and surgery?
The neoadjuvant followed by surgery is the standard of care in these patients. Definite chemoradiation may be an option only in elderly patients or patients who are probably not fit for surgery or not willing to undergo a surgery.
I'm not sure that that's a absolutely correct statement. There are centers which practice chemoradiotherapy as definitive chemoradiotherapy as the first line of treatment and use salvage surgery, not as a neoadjuvant, salvage surgery for those who still have residual tumor. That is one approach which people use. And from what I have read, and it seems to me that the two results seem to be the same. If you look at the survival.
But I feel for the exam purposes, what
But
you
what you
told
said
is
is also
acceptable.
perfect,
Yeah.
yeah.
If a patient has got a complete clinical response, okay, in those circumstances, all the investigations following neoadjuvant therapy do not show any evidence of tumor. In spite of that, you should go ahead with the surgery, because esophagus is a very aggressive tumor as compared to the rectal tumor. So there, if you have a complete clinical response, it is justified in wait and watch policy. But as far as esophagus is concerned, it's always better that window of opportunity what you get. If you lose that window, there is a possibility that the outcome in that patient may not.
But if you give a definitive chemoradiotherapy and there's a complete clinical response, then you're justified in waiting, because the regimes are different.
So
the amount of radiation, chemo is different.
you were right in saying that this, but only thing is that what you should have said ideally is that I will discuss with the patient and patient's family with regards to the management plan, where I'll explain them that he requires a neoadjuvant followed by this surgery.
Why should you discuss this? Why not just send him for radiation and chemotherapy? You could anyway say, I will continue with definitive chemoradiotherapy. Why should you explain this point that Chetan is saying?
So if we explain it to the patient, it is he'll follow.
Can you hold the mic closer and speak it louder?
Sir, if we counsel the patient, it is likely that the patient will follow up after the neoadjuvant is complete for a surgical intervention rather than just.
That's not the reason.
That is not
That's
the reason.
Primary reason. The primary reason.
That's another reason. You see, the neoadjuvant protocols are designed to be followed by surgery always, unless the patient becomes unfit in the meantime or the tumor spreads in the meantime. So you can't switch protocols. So the radiation and chemotherapist cannot give a neoadjuvant protocol and in the middle decide, I will change it to a definitive chemoradiotherapy. They have to start for a definitive chemotherapy with a different regime. So they can't switch in the middle. So they would like you to explain that this should be followed by surgery, because you cannot switch to another line of treatment later. If they want to switch, they have to switch at the beginning itself, refuse the surgery and go for definitive chemotherapy. That is the reason why Chetan said you should explain this to the patient. And in all patients, you should tell them that there's an alternative line of therapy, of definitive chemotherapy, radiotherapy, which in literature seems to have equivalent success to this. But then, of course, you may lose many patients from a surgical point of view. That is true. But this is something that very often we only tell one side of the story to the patient.
You give them an option.
You
that
should
this
give
is
them the
there,
option.
But you should say that I would like to do this because of whatever reasons you can give the evidence, and say that generally I would like to do this and I would recommend this.
So what regime you will use for your neoadjuvant for this patient? You have decided on neoadjuvant. What regime are you going to use?
Sir, I would do it as per the cross protocol, wherein I would give 41.4 gray of radiation divided in 23 fractions with 1.8 gray per fraction in 23 days with chemotherapy in the form of paclitaxel 50 milligram per meter square, which will be given on day 1, 8, 15, 22 and 29, and carboplatin with a dose of area under the curve 2.
Do Indian patients tolerate this regime as it is given? What is the percentage of patients who complete the protocol or who drop out of the protocol?
There are a good number of patients do drop out because of the...
Yes, a very heavy number of patients drop out because for them this dose of radiation and chemotherapy they are not able to tolerate. So for Indian patients, actually our oncologists lower the doses of chemotherapy.
It's a very toxic regimen.
It's a
How
very
much
toxic.
time do we have?
They lower.
So
One
the
last question, this is not from my
We
side.
need
at
to
least.
move to-
If
Yes,
you
sir.
have got a complete clinical response and you have
Yes,
followed
sir.
up with surgery, what you'd like to, how the pathological report will dictate the outcome?
Sir,
Patient has a complete clinical response.
Sir, if there is a complete clinical response, the overall prognosis of the patient, if the pathological, if there is PT0, N0, sir, then...
I'll repeat the question. There is
You can
complete
give it to
clinical
the next person.
response.
He can
You
answer.
have done the surgery. You have sent the specimen to the pathologist. Now you are reading the report. What on the report will tell you this patient has got good prognosis? What on the report will tell you less than that prognosis?
what do you want to see?
So
on
what are
these
the prognostic factors on the pathology report?
The basal lamina is involved by the post chemo, post
Can you hold the mic closer and speak?
post neoadjuvant chemotherapy, whether the tumor has regressed. So the now
No, you're operated. You sent a specimen.
And you will
for
only
biopsy.
have one specimen with you.
post
So how are you?
post neoadjuvant therapy.
Let me be more
Yes.
specific on the question. Which type of report will have the best possible outcome for the patient? Made it very specific. Answer is also one line.
histopathological?
The growth is still the muscularis propria.
No.
Okay, I'll give you an abbreviation at least on that answer. It's called CPR. What do you mean by that?
Complete pathological response.
What do you mean by that?
Right. Okay. So I think because in the
But I will
interest of
get no
time,
foci. I will get no foci of
maybe
growth.
Okay, so what surgery would you plan, and
Yeah,
how, after
let's
what
do surgery.
duration of time will you operate?
Sir,
You have
actually-
given neoadjuvant.
so you have given neoadjuvant. Now the patient is ready for surgery.
You have given
How do you
NACRT.
proceed?
How long will you wait after NACRT?
So after neoadjuvant chemotherapy, I will wait for 4 weeks.
And then upfront take for surgery, or you'll do some investigation again?
Sir, again I will repeat the PET CT.
Okay.
Again I will repeat the PET CT and see whether the tumor has regressed. Whether in this case the subclavicular lymph nodes, the mediastinum.
No, we have for a discussion. Okay.
Okay, sir, I will-
What surgery will you perform?
Sir, in this patient, I will do sir three-field McEwen's three-field total esophageectomy with the McEwen's three-field lymphadenectomy in this patient.
This is the lower
Three-field.
Have you ever done in your life a McEwen procedure with a 3-field dissection? Have you ever done? Huh? Have you ever assisted on one? Have you seen one? No. See, that is what he said. What you will do, okay? And you gave a theoretical answer based on what you have read. But there are a few esophageal surgeons who would do a 3-field dissection. Of course, leave the Japanese. In India, there are still a few, but a few, very few. Most of us don't do a 3-field dissection. That is, I don't do. And even in Japanese hands, what is the morbidity of the operation?
The high morbidity.
What is the high morbidity? Where is the morbidity?
What is the morbidity? Why? What is?
Chylothorax.
No. What is the main morbidity?
Cervical gastric.
No, it is the lung morbidity. So in Japan, if they do the three-field dissection, from the time of the patient coming to from the theater, every 12 hours they do a bronchoscopic lavage for the first 5 days. Yeah. 25% of their patients end up on at least a temporary tracheostomy. 15 to 12% end up with a permanent tracheostomy. Okay, and it's a very morbid operation. In India, some of the people who started doing it initially had virtually 100% mortality rate when they first did.
What is the rationale of doing three-field? Why three-field?
Because particularly in this patient, I got that palpable.
Not this patient, generally. What is the rationale?
The rationale is to get sir R0 dissection, but I have
What do you do in three-field?
To get more curative dissection.
What do you do extra in three-field, but you don't do in two-field?
Sir, in three-field we go to the cervical lymph nodes. In that two-field we avoid the cervical lymph nodes. So
the
usually we
is
don't
that
do.
they
But I
believe
thought,
that there are occult micrometastases
Yes,
which occurs, which you take care of.
yes, sir.
So is there a modification that people adopt?
Yes, sir.
Trying to limit the morbidity of the procedure and still have the advantage.
Modified three-field.
Oh,
Yes, sir.
so what is that modified?
So now we avoid the cervical lymph nodes also, and we avoid the right-sided.
And what does the literature say of the results of two-field and three-field?
Equivalent, sir.
See,
Equivalent for what? Then there is no case for doing it.
why is the morbidity reason? Why do they get complications?
Bronchoria and other.
Everything. Why do they get that?
Mediastinum is rich in lymphatics, so but the more number of lymph nodes we try to pick up, we are injuring the lymphatics also. So there will be a huge chylothorax. So there will be huge protein.
It's not the chylothorax that causes. It is the bronchoria, because the lymph of the lung cannot drain. See, when you do an axillary lymph node dissection for a breast cancer, patient develop lymphedema of the arm. Similarly, when you do wide lymph node dissection in the chest, you remove the lymph nodes draining the lung. So the lung, that is why they have to do a 12th hourly
So if the literature is supporting two-field and three-field, how would you justify doing a limited lymph nodal dissection? Is there a counter argument how people try to say that, why we don't go for it? One is, of course, morbidity, and they think that the morbidity doesn't counterbalance the improved survival. Is there other reasons for that?
We are more depending upon the chemoradiotherapy. So
sorry,
we are more trusting upon the more chemoradiotherapy that it will take care of that.
No, I don't think. I mean, one of the argument also they say is that it is better staging, like he talked about micrometastasis and other. So probably at the moment the basket changes, because I think then when you are doing a three-field lymphadenectomy, what station lymph nodes are involved is a truer staging. So the patients that you're comparing with, actually some of them may be in the more advanced category. So I think that is not counterbalanced. So I think that is why it has not still become, so to say, a standard of care across all centers. And even though after Japanese literature, now there is from the West also the literature talking about improved survival of 2-stage and 3-stage, but you should be clear about what you're talking about.
And also you should know that when you give radiation, there are some centers which will include the cervical lymph nodes in the radiation, and therefore they hope that will sterilize
care of it. Yeah.
So they'll take care of that. Though the cross protocol doesn't say cervical radiation, but some of the centers would do. But in definitive chemoradiotherapy, you would cover the neck.
So let's say in this case you plan for surgery. So you are, as I understand that you are planning a neck anastomosis, right? So how do you go about it? What is the approach that you're going to take in terms of the sequence of thing, or laparoscopic versus, thoracoscopic versus robotic versus open?
I'll give 3 incisions, sir.
Sorry, mic, take the mic near.
Sir, from the abdomen incision, I will mobilize the G junction, sir. Then with the
right thoracotomy incision, I will mobilize the esophagus. Then from the neck incision, I will mobilize the.
In McEwen's, what is the sequence? Is this the sequence what you mentioned?
So first in McEwen, sir, first abdominal, then followed by thoracic.
Are you sure?
And you realize that you've done
No, sir,
the abdominal mobilization, you do go to the thorax,
And it
and
is.
you realize it is stuck and you can't
Yes, sir.
proceed
First I
with
should do the
resection.
thoracic.
No, be
Sir,
clear.
thoracic.
You see, there is an operation called as Ivor Lewis.
Yes,
What is the
sir.
primary difference between Ivor Lewis and McEwen's? And when is Ivor Lewis used? When is McEwen's used?
Sir, Ivor Lewis is using 2 phase, and McEwen's is in Ivor Lewis we do intrathoracic anastomosis, so it is 2 phase.
It's not a question of anastomosis. It's a question of approach.
In Ivor Lewis we don't touch
In one of the operations, we open the thorax first. In one of the operations, we open the abdomen first. Why?
Sir, in Ivor Lewis we open the
Abdomen first,
Abdomen
yes.
Why?
Why?
Sir,
That's
maybe-
not
sir, because we are
answered
dealing.
the question.
Sir, in Ivor Lewis we are dealing with the lower esophageal tumors.
Not
Sir,
only that,
Lower third, this patient has got a lower third. Is
Yes,
it not?
sir.
It
Then
starts at the junction and going in the lower third.
Yes, sir.
Still, you said you will do McEwen's.
No, sir. Then I should do Ivor Lewis, sir, in this case.
no, but if you do Ivor Lewis, why is it that you do the abdomen first?
When the lower third esophageal tumors have the tendency to involve the.
No. How do you do the Ivor Lewis? Do you know? Have you seen an Ivor Lewis? The abdomen is done with the patient supine, but the chest is done with the patient in a lateral position. So, you do the abdomen, mobilize everything, including the hiatus, then you put the patient in the lateral position, do the esophagectomy, then you can pull the specimen into the chest and do the anastomosis. Because you have to change the position. In McEwen, you don't change the position. You have the patient supine throughout. See, so these points you should know. Why Ivor Lewis? Now, there is a trend in literature and in practice for people coming back to Ivor Lewis now. You know why?
Because McEwen has more morbidity.
What morbidity?
That same you told that increased bronchodia.
No, McEwen has a higher leak rate of nearly 30% accepted leak rate in literature. Whereas Ivor Lewis has a leak rate less than 5%.
What is the reason for that?
Because the neck anastomosis will be always in a more tension, sir. But
No, that's not the reason. Why it will be in tension? When you do surgery, you should
so
avoid
maybe
tension.
the vascularity is more in the
Vascularity.
thoracic
When
anastomosis
you do neck anastomosis, the vascularity
will be less.
Compared to intrathoracic anastomosis.
I think Mahesh is telling us we have gone way beyond the time.
Just
Oh,
2
we
minutes.
didn't know
Just
that.
2 minutes. Just a chocolate question. The answer to that question that he said that why now there's a resurgence of interest. Why early on? Because the leak rates have been comparable. I mean, leak rates have been remained almost the same of intrathoracic versus the neck anastomosis, right? But early on, people were going for a neck anastomosis preferably. But now you don't mind and you can go ahead with an intrathoracic anastomosis. So why do you think that changes?
Because the leak rate is less, sir.
No, leak rate, that was always there. That was always there. There's something else which has changed. If you don't know, the thing is that early on, the leak related morbidity, mortality used to be very high. And that is why early on, when people were preferring, the argument used to be that the leak related mortality was much higher in intrathoracic leaks as compared, and with advancement in rest everything. And they used to say even at that time, the chances of dying because of a neck or this leak would be comparable. Because even though it was thought that the neck leak was absolutely safe, it wasn't so. Because there was only a difference of 3 centimeters between the anastomosis.
And actually, when
the
you do a
thought-
thoracoscopy,
mediastinum
you
is
open it
still-
so wide that the leak invariably goes even from the neck into the chest.
So the mediastinitis incidence was also there. So now with the improvement in all this, and I was going to ask you that other
So maybe
question
because of
also,
the-
but we didn't go to the laparoscopic or thoracoscopic because, and the prone position, and also the thing is about the leak related, I mean, can you do a stapled anastomosis
Yes,
in
sir,
the
maybe because
chest
of this-
and the, so these are some of the things, and then
We'll go to the
will not
case
go into, but maybe you should be ready with these answers. And I think the question that he asked you, what will you do? And as Dr. Ramesh said, that it is better to do a safe this thing. But you should be aware about all the literature. You should be aware about what people are doing. If you are not doing thoracoscopic and you are not doing robotic, it's fine. I mean, you can say that
you
this
can
is
say I
what
will
you
do
have to
open,
You
and
can
if you
depend
don't do
on-
a three field, you say I have not
Yeah.
seen a three field. See, three field is a very difficult operation. You have to expose the entire recurrent laryngeal nerve. The morbidity of the operation actually comes from the recurrent laryngeal nerve parts.
That is the thing.
Is it? So if you don't, you've not done it or seen it, please do. See, so when your question is what can be done, what you will do, they are different answers.
So best in exam is say that I would like to do this. However, this could be also done this way. I have not done it. That is the best way to say it.
Yeah.
Let us go to case.
In the case capsule, we don't discuss the history or the findings. We'll go straight to the management.
With you only. So we'll go this way. Yeah.
So regarding bronchoria, I think it's because of bronchial artery injury rather than lymphatic.
No, it's the lymphatics. It's the lymphatics. Because the lymphatics will drain the fluid. And when the lymphatics are gone, like that's what I said, breast, you get lymphedema of the arm, you get bronchoria in,
But probably what
it's not
he's
the
saying-
arterial injury.
But what
the
he's saying is right in the sense that it may not be injury, but it is a kind of devascularization of the
that process,
bronchus
yeah.
and that region.
No, that
So
leads-
you are
that-
taking away
Lot of
the
mucus
effective
secretion.
blood supply to them.
Cause a lot of mucus secretion.
Yeah.
Yeah, go ahead.
Coming to the case capsule, a patient is 29 years, female resident of Telangana, presuming private job in a software company, presented with the chief complaints of difficulty in swallowing for the past 3 months. She had a history of suicidal consumption of around 100 ml of Harpic on 12th of June this year, following which she had 5 to 6 episodes of vomiting associated with breathing difficulty, and was taken to the local hospital where she was admitted in the ICU, and endoscopy was done on 15th of June and was treated conservatively. At the time of discharge, she was not able to tolerate even liquids. She again revisited to the other hospital after 2 weeks in view of difficulty in swallowing liquids, where she was admitted and endoscopy intervention was done on 5th of this month, following which the patient developed vomiting and pain abdomen. Feeding jejunostomy was done on 13th of this month. Patient was referred to our AIG for the further management. At present, she is not able to swallow liquids, unable to swallow saliva. Tolerating FJ feed. With FJ feed in situ, she is maintaining the nutrition.
Yes, sir, tell us. What do you know? What do you think this case is? Quickly.
Just let
History
him
of
complete that
case of
one more
esophageal
slide.
stricture post-corrosive injection.
You can complete that last slide also of the
Coming to the past history, sir. Patient who joined in the software company in the Jan 2022, where she developed a depression, but she was not on any medication from then. But she started to have these medications of antipsychotic drugs since June after having this suicidal attempt. No suicidal attempt in the past and no significant medical illness, and she underwent FJ on 13th of this month. Personal history and family history are not significant. Coming to the general examination, BMI is 19.7, no pallor, no icterus, no hoarseness of voice, oral cavity, healthy mucosa of tongue and visible part of the pharynx, no scarring, mouth opening is adequate.
Height I want to know. Separately height I want to know.
5
feet.
Okay, you have got.
See, the conduit
Sorry, sir.
will be as long as the patient.
Sorry, sir.
So if the patient is taller, they will have a longer
Don't be
colon.
sorry.
I don't think that's very that's relevant in the exam.
And this
Don't get
size
into
also
trouble
will
like
be
this.
proportional.
Examination is normal.
Normal, sir. Only FJ.
Yeah. So what is your diagnosis? You know the entire history? Tell us the diagnosis.
Sir, corrosive esophageal stricture following stricture in esophagus following acid injection.
So dysphagia following corrosive injection with what intent?
Suicidal attempt.
With suicide intent because she was depressed.
Yes.
And what is the current status?
Unable to swallow saliva also. Sir.
And on post-feeding jejunum.
Post-feeding jejunum.
What is your plan for this patient? She's come to you now.
Sir, now only it is I think 1 month only.
What is your plan? You tell us.
Sir, plan and now as of now I will optimize. Sir. I will optimize. I will counsel. I will I can get an ENT checkup and now already this now I can refer to sir. I can do a barium
You
swallow.
are talking to patient and patient's relative. How will you explain? What is your long-term plan?
It's a long-term plan that it will take a long-term decision because the strictures need stabilization. It takes 6 months to stabilize the esophageal strictures, and for the gastric strictures, it needs 3 months to stabilize. So at least minimum 3 months I have to wait. In this
You have to wait for what?
Minimum 3 months.
For what?
to stabilize the stricture.
What do you mean by stabilizing the
So that
structure?
means the definitive treatment you start after 6 months.
No, I will explain, sir.
What?
The
Yeah.
fitting jejunostomy has already done, sir.
See,
So
what you're telling is true for the surgeon, but that is not true for other
I will tell,
treatments.
sir. I will tell.
So you should don't say I will wait for 3 months.
No, I'm not waiting, sir.
Yeah,
I will get
you
a
tell
barium.
what you're going
I will
to do.
get a barium swallow done, sir. I will get a barium swallow done.
Okay, that's
I will
the
refer-
first and best answer I'm expecting.
And
That
I
you
will
get a
refer to the
barium.
medical gastro people. So if there is any possibility of dilate, first I will
Where
see
is the barium
picture.
swallow? Ask them for that.
Before that,
And before that also that, yeah, please. Yeah.
yeah, you saw in that history that
Yeah.
at second week, somebody did an
Endoscopic
endoscopy and
intervention.
intervention there.
2 days after.
2
No,
weeks
2
after.
weeks
No, 2
after.
weeks after.
2 weeks. No, no,
2
2
weeks.
weeks after. No. 2 weeks after. Go
2
back to your
weeks
first
after.
slide.
There is one more endoscopy 2 weeks after, and an intervention was done.
22nd June was
Yes,
the.
and following which she had pain of abdomen and
Can you go back?
Already
Go back to the
dilatation
first
started.
slide. No, go back to the first slide.
some intervention was done and she had pain in abdomen and
Yes.
Yeah,
Yes.
the second week she had an
What are your
intervention.
comments?
Yeah,
there?
this one.
Yeah.
She visited her another hospital after 2 weeks in view of difficulty in swallowing. So, which would mean towards the end of June.
It
No.
was too early.
No, she already had an endoscopy
initially.
when she was initially done.
Initially,
Right.
but again 2 weeks.
Then
hence
2 weeks
there.
later only that was done. But
Why, if you were,
Straight away
would
they
you
did
do the
it.
same? What would have been
2
your
weeks.
approach?
2 weeks is too early, sir.
No, 2
No,
weeks
sir
is
is
too early
asking
for
you
what?
what would you have done differently?
I mean, 2 weeks is too early for what?
To do a dilatation therapy.
Is it written that it was dilatation which was done?
What is? They're
so
telling
that's
us
what
that-
I'm
you have to
asking
tell
you.
in exams that I most probably feel that dilatation may have been attempted.
Yes, sir.
That is what you feel,
I'm feeling.
probably. That is
Probably.
what you have to answer.
Because
I
they
mean,
are
I mean, probably. I mean, you are saying dilatation. They have written endoscopic procedure.
Yes, sir.
What all things come to your mind? Because you have to give credit to the other person also.
Okay, then
I mean, if
maybe-
you think that dilatation should not be done 2 weeks, probably that endoscopist also might be having. So, but
Maybe they did
what could be
additional
the
lysis.
other indications of doing an endoscopy at 2
additional
weeks?
lysis. Additional lysis they have done.
Additional lysis in
Scientific-
endoscopy.
They were, the
In
scientific gave us-
endoscopy,
You
do you
don't
do that?
You do
No.
indirect laryngoscopy and this.
That is a different thing. Here you are talking about endoscopy. What would you have done? What could have been done?
Placement of a rice tube.
Right. So
Feeding-
that is
for
what
feeding.
some people may think in terms of. So I think unfortunately we always go with an idea that the person who has dealt with this is probably a novice and doesn't know anything what is to be done.
Sorry,
You have
sir.
to give credence to that you know that might be. And you are sweeping statement, you are saying that no, it was not a good time to dilate. Then you would have asked you that what would you have been your approach? So I mean you have to look at, or there could be, what could be the other reason for doing an early
Actually-
endoscopy? What could be the other indication for doing, not over just putting it at you?
So basically, when I asked you the
When, what
question,
happens when we have, like, I don't know, we don't have the findings of the first endoscopy. Sometimes when there's a suspected complication or there's a, ischemia or the necrosis of the, sometimes you may need to do an endoscopy for some of those things. So I think you have to be clear about what you're talking.
So
And
when-
then other thing is you said you can do this. You can have an ENT referral. We want you, what will you do?
you do exactly. So
What
when I asked you this question, the ideal answer would have been that I counsel the patient and patient's relatives that this is an evolving process. A definitive treatment would be given at a later stage. At this present time, nutrition
that is the unfortunate thing about
Previous
you
one.
are just trying to somehow get the patient eating. But they said it's just suicidal. They said that she has a history of depression and the treatment. In the interim, when you already have feeding gynostomy, would you not want to get a psychiatric consultation and to, otherwise while you are doing all these things, she again has one more, and that's it. Yeah, that's it.
Jump off the 6th floor. And
Yeah, and that's it.
That's it.
They mentioned that she was started on olanzapine and
taking treatment, but you would further counsel and see that that issue is also taken care of. What investigations now will you ask for?
So this is the first endoscopy done 2 days after taking the fluid. And
It might detect, might guide you for repeat endoscopy in the early part. So you have to keep it. In fact, the question that I would have asked you is that what all are the indications of early endoscopy in corrosive injury?
In patients with higher grades of injuries are grade.
Go ahead.
This patient has a grade 3 injury.
Speak it louder, speak it closer.
so let me put it very frankly. There are two schools of thought. There is one school of thought to which a majority of gastroenterologists and surgeons believe that is an early endoscopy. There is a minority school which had two champions. Unfortunately, we have lost one champion, Chandramohan, and I remain the sole champion. I do not believe in early endoscopy. I use critical clinical criteria. The
We
patient
also
can
follow
swallow
you, so
liquids,
they're followers.
then the path is free. They can't swallow, they've got some block, and doing an early endoscopy, in my opinion, doesn't change my management. Therefore, I don't believe, but I know that almost everybody here believes that they should do early endoscopy. I'm telling it to you open. So, I would not have done an endoscopy on the 15th, but they have done it, and you know, and it gives you exactly what that patient is not able to swallow. That this you know that from the clinical history, so it doesn't leave me wiser. Okay, so can we have the endoscopy on 22nd of?
So
From this endoscopy,
the
what do you
early
interpret?
endoscopy, what do you gain by it, and what decisions can you take from the early endoscopy?
One is to prognosticate the patient, sir. It's a grade 1 injury or grade 2A injury. We might keep the patient for 24 hours and then probably early discharge for the patient. In higher grades of injury, then the management changes. We longer hospital course, and possibly in grade 3B or 4 injuries, we might even. I
Yeah, but what you said is fine, the documentation is fine. That is
So
why early
what did the
endoscopy is done.
UGI scopy show, the earlier one?
It was
If you had
grade,
read?
grade 3A injury in the esophagus and grade 3B injury in the.
So what additional information you have got is that even the stomach is
Gastric injury.
involved apart from the esophagus. Now this is the next.
Is this significant injury, 3A, 3B?
Yes.
It is it not?
Yes, sir.
So you presume that these patients are likely to have problems in the future. Yeah, one point on endoscopy, what precaution will you take when you do this early endoscopy in these patients?
And we do not, there's a chance of perforation because of insufflation of air. Sir.
So we use low pressure. There's a button on that. We use low pressure endoscopy. We do a quick endoscopy.
So this is the second after 2 weeks done.
What is SG?
Abricular dilatation.
I think we are not going into the details, but I think here you may be asked a question that what all are the kinds of dilators that you know and where do you use what?
What is important here written?
That the patient had a post-procedure pain abdomen and it was a localized perforation and a CCT had a pre-air but no oral contrast.
So what do you think must have happened?
There might have been a perforation from the small perforation from the stomach which they've managed. Probably
Why
managed
stomach?
conservatively.
This is at strictly 35 centimeter. So how do you think that the stomach got perforated? What is the side? Then the other thing is that whether it's a guide wire perforation or at the time of dilatation that you're talking. So probably it is still possible that it was a guide wire perforation which was through the stomach and there was some free air, there was no leak. So that was managed conservatively and the patient improved. And the fact that a little while after this, they've done probably looks like a short episode which was managed conservatively.
It could also be different dilator. Okay, severe Gallard is a little different dilator as compared to balloon dilator.
So now
balloon
you have-
dilators are safer as compared
You
to
have now
SG.
reviewed this Okay. Now what next do you want to do? You have reviewed the previous reports.
I want to see the barium swallow.
Why? What will it tell you? And with what
Sir,
intention? What do you want to?
Or if the patient still has symptoms, so the site of obstruction of the site of obstruction, so site of the stricture inside.
25 centimeters.
35
centimeters.
I would like to see if in the barium if the contrast is passing further to the stomach or there is complete obstruction. And
Basically, you would want to characterize the stricture. You want to see what is the length, whether it's an long stricture, irregular stricture, whether there's a deep block lying in the stomach.
35 centimeters for this particular patient, where would it come? What part of the esophagus? Her height was only 5 feet. That is why you should know the height.
probably the G junction.
G junction, yes. 35 centimeter will come in the range of G junction per 150 centimeter individual. So you have to note that thing because.
So this is the barium.
In any X-rays, a barium swallow showing anteroposterior and lateral images. That's how you should start by describe, not the findings straight away, because then you know what X-ray you are describing. That is how you should describe any X-ray. So X-ray to show a barium esophagogram lateral and in the anteroposterior.
In subsequent sections also, so
It is persistent, number one. Number two, an important finding is seen there.
A little dilatation above.
Fluid level, can you see that?
Yes.
Hold up.
Hold up of contrast is there.
Yes, the fluid level is seen there.
So how does this leave you wiser, or does it change your management?
So we'll go
So
to the
the-
next. So madam, what do you want to do for this now? Here you have got a barium swallow done, and this is the finding. What
This
next?
is about 2 months post ingestion, sir.
Okay.
And there's a stricture in the lower thoracic.
Not 2 months. I think 12 only this patient had.
No, the 6th of month.
1.5 months.
Yeah.
And she's also maintaining nutritional. So my plan would be for now
You
now
said she is
conservative.
maintaining nutrition. How do you know she is maintaining nutrition? What is the best
Sir,
parameter? to know? Pre-ingestion weight and now the present weight. There should not be
Yes,
much
sir.
of difference in the weight.
Probably if it has gone up, it don't go up. At least it should not go down.
Yes, sir.
So now what? Yeah.
Sir, now there's a stricture also. I counsel the patient about the possibility of endoscopic dilation. Possibility in the sense, I will counsel them about the endoscopic dilatation, sir.
Of what?
And of the esophageal structure.
Then they'll ask, what about the stomach structure?
Sir, but that anyway, we will wait at least for about 4 to 6 months, minimum 6 months, sir, for any definitive operative management.
Then they will ask,
For-
why don't you wait till 4 to 6 months before you do the dilatation? Why do you want to do the dilatation now?
Sir, because if the the corrosive strictures, they evolve over time, sir. And if the stomach has not contracted completely, and if there is a single stricture in the lower thoracic esophagus, and if it is able to dilate properly, and also she is maintaining nutrition, we can just give, we can be okay without surgery, sir.
No, will the stomach be okay without surgery?
So how will you say this in exam is that the stomach will require a definitive surgery, and this being an evolving in the intervening period, I'm going to keep on doing a regular dilatation for this period so that the esophagus becomes normal, and at the end of whatever 6 months, you will do only a surgery for the stomach.
And if you want to, the question they ask, why you can't dilate later? You should start dilatations by 4 to 6 weeks, because it is still supple, the stricture. The later you start dilatation, the poorer the results of dilatation. So by starting the dilatation early, you may avoid an esophageal replacement, which is actually very morbid, whereas the stomach is not so morbid. So she can have esophageal dilatation, continue with feeding jejunostomy, and then later, if required, she can have something for the stomach done.
When looking at this barium swallow, are you tempted to do a balloon dilatation, considering the fact that she had perforation using SG dilator at the first time?
Sir, the endoscopy has not been performed in our center, sir, or wherever it was performed.
So keeping that in mind, would you contemplate doing a balloon dilatation rather than doing an SG dilatation?
Sir, I would give a trial of SG dilator, sir, before saying let's go for balloon dilatation, sir, because that is the standard everywhere. And already the previous...
That's the standard everywhere, but not everybody has a perforation.
The question is really the relative merits and demerits of radial dilatation versus axial dilatation.
What is the mechanism of SG dilatation versus balloon dilatation? How does it help in corrosive symptoms?
Sir, in SG dilator, there is a radial as well as a circumferential dilatation, sir, whereas in balloon dilator, there is just an axial dilatation. Radial force. The perforation chances are in fact more with balloon dilators rather than the SG dilators, sir.
So you use balloon dilatation where generally?
Apart from the dilator, isn't the guide wire important? What is the difference between an SG guide wire and a normal guide wire?
I don't have an idea.
See, the original SG dilator, some people now use normal guide wires to use the SG dilator. So that is safe. But the original SG dilator is a metal dilator. And it has got a floppy tip, with circles. So it's supposed to slide through strictures. That actually has a higher incidence of perforation.
Telling that
last 2 minutes, the organizers are questions here. One is that when do you say it's a failure to dilate? Failure of dilatation?
Sir, at least five sessions of dilatation they have failed over the 5 sessions of dilatation they have failed, sir. Each session.
Is it 5 sessions of dilatation failed?
5.
And also as a corollary question would be that how much do you dilate in one go?
Sir, not more than 3, at least not more than 3 consecutive dilators, sir.
Okay.
The size of the SG dilators?
Sir, 9, 10, 11, sir, and 11, 13, and 15.
No, just cooking it up.
10.8,
7, 9, 10.8, and
12, 14, 15.
How much dilatation is required to alleviate dysphagia?
At least 14, sir.
14. At least 14 you should.
14.
What are the definitive contraindications when you will not dilate? Then you will not dilate. Definitive contraindications for dilatation.
Sorry, and I think before that also, that question you did complete that failure of dilatation. You were
Sir,
talking about 5. So I was trying to learn some new things.
Sir, the failure of dilatation up to 14 mm, sir, that is the first. Then at least we have completed 5 sessions, each session separated by at least 2 weeks, and there is no progress in dilatation. This is defined as dilatation failure, sir.
No progress in dilatation for 5 dilatation.
5 sessions, sir.
The simple clinical way of telling that dilatation has failed is, if after 5 dilatations you reach 14 millimeters, but the patient comes back unable to eat solids and is only able to tolerate liquids, the dilatation has failed. they should be able to eat solids after 5 dilatations at 14 millimeters. They can't eat solids, it has failed.
I think apart from reaching the dilatation or not progressing with the dilatation, also the need for repeated dilatation is, would also be
repeated
to
dilatation.
maintain that.
That is what is very
this thing. So all these things will come in. So I think we'll wind up, and I think any last question? You asked one question. Contraindication for dilatation, and then.
If at all there is a long segment stricture, if multiple strictures are present, then we will not dilate. And if there is pseudo diverticula which is present, then we will not dilate, sir.
Long multiple irregular strictures.
And the pseudo diverticula.
And in this patient, one complication happened?
Already perforations. Perforations.
Yes. So in the interest of time, we are not discussing, but you should be prepared to answer all the questions about surgical management, and in terms of also which conduit to be used, what approach to be used, what is the timing of surgery.
Sir, in our institution, we use a modified left-sided colon conducer.
They are waiting for the rounds.
Already 3B.
Thank you, sir. We will move on to the next session. This is a ward round. I would like my colleague Dr. Rohit to take over. Rohit.
Morning. We'll start. First, can you hear us?
Yes, sir, we can. We can hear and see you.
You can come in. Yeah.
50 years male, known case of acute necrotizing pancreatitis follow-up case. We have done nephrectomy plus diversion ileostomy for prolonged communication in the month of March. So now he came for restoration of continuity. So we did subtotal colectomy plus subtotal cholecystectomy, POD3.
What was the need to do subtotal cholecystectomy?
In the month of May, he had acute plasma cholecystitis. We did percutaneous drainage.
You want any? You can ask questions. You want any more information?
So why this means this time subtotal colectomy has been done?
So on evaluation for restoration of continuity, we found a clinic flexure stricture, clinic flexure descending colon stricture. On colonoscopy biopsy, it was low-grade restoration. So intraoperative, it was difficult to mobilize the entire colon. So we did subtotal colectomy.
Left colectomy was not possible, so we have subtotal colectomy and
What problems of a colon large bowel we expect in acute necrotizing?
The spontaneous fistula can be there.
Fistula in communication. Fistula will do what?
Necrotic collection can erode this wall of the colon.
If you open, what do you see? Colon. You see some small fistula opening or something else you see? Then there is the fistula. Then there is the collection of the stool in the abdomen or the fistulization through some wound or something. What do you see it?
The necrotic material. And most of the times actually we will not be able to localize that site.
You attempt to see it. You try and figure out where is the hole between the colon and
No, sir.
What exactly you see? You see only a small area which is there. Yes, sir. Something else you see.
Frozen types, it will be completely adhered to necrotic wall collections. We generally don't attempt to go.
You do see any type in colon and necrotic.
This is the third day, right?
Yes.
Third day of an IGO sigmoid anesthesia. So this patient is, let's say, shows a very high tachycardia, 120. And his abdomen is, you feel there is a slight tenderness. And otherwise, the patient is maintaining his dignity, urine output is fine, but only the point is he has a tachycardia and he has
abdominal tendons. Now, how would you really assess this patient? What do you really suspect in a patient on the third day has a mild tenderness and tachycardia?
So, there is chance of an osmotic lead.
That is one aspect. Anything
Respirate.
also, you can go down on day 3 post already. You go around and you find the tachycardia and tenderness.
So I will suspect
You said one is, as I said, you are asking various other causes. So one is you think is the leak of CRTA. What else?
it can be any respiratory complication, including pneumonia, cardiac acid. Can be even urinary tract infection. That can cause tachycardia. Cardiac complication.
What cardiac complication would you expect? Fit how old?
3 years maybe.
50 years old.
It should also match with your abdominal dermatitis.
I've given you 2 plates. No, I'm not going to give you tachycardia.
So you have to take both into account.
The most probably it is osmotic leak correction in the pelvis. That is causing tachycardia.
Anything else is also else can be a part of it.
So the standard of obstructive complications that you can get into and complications after support for it.
Select abdominal collections, post-op ileal after without leak also.
Clean surgery or clean surgery.
Contaminated.
No infection problem. Totally.
Cervical site infection.
So what is trying to ask is other than anastomotic causing this kind of.
What are the other things can also cause dilatation?
Any other causes can present like this.
Injuries surrounding is vessel injury that can cause correction.
Collection, anything happened to the bowel, or there could be
Ischemia causes. Ischemia of the bowel.
patient
Like this.
Yes. Yes.
Okay. That is the clinical scenario.
Okay, you go about
Yes. What we should have here. So there are so many causes which can lead. How is the approach now?
ECT abdomen to look for the one is
Which one will you prefer? Ultrasound or
CT.
why?
Ultrasound will not show the bowel vascularity and osmotic leak also it will not. Septated collections are there, that also will not be shown by ultrasound.
So the post is better.
Yes.
So you said CCT, oral contrast, IV contrast, oral and contrast.
or no contrast.
Suppose that investigation shows that there is anastomotic leak.
I will first counsel the patient. That is,
You have to decide what you want to say. What you want to do. What are the various options?
What you want.
What are you going to counsel about?
At least you are. You know what you want to do.
plan for diversion from it.
You want to do diversion.
Yes.
Even if it's a contained leak, you still want to do diversion.
It's already very clear. Create a leak.
So the patient contained purpose means contained leak there we can.
Sir said only technically. They have found a leak on CCT with rectal contrast. So straight away, they will just decide to do diversion ileostomy or Are there any alternative options?
This patient was already previously necrotizing pancreatitis, we had already pancreatitis, so we will not.
They won't even proceed.
So they will not tolerate the means the consequences of the leak, so means they will plan for diversion. They will not wait.
Then if it's contained leak, drain is working very well.
Still, you ask for other investigations also simultaneously. Other than basic.
Means I will check complete blood count and procalcitonin, urea, creatinine.
So, how much they help you in making a decision? Let me ask you one simple question. WBC count is 11,400. Then your CRP is raised about 12. And your procalcitonin is slightly raised. Now, does it help you to make a decision whether you should conserve this? Or did you ask another question whether the drainage, what is drain draining, is what is localized or not localized, overall how the patient is doing? Don't you think all these factors matter to you, especially when you make a decision to go in again and disrupt and take it? And I agree, I mean, if such a massive leak, you will do.
I'll ask the same question again. Suppose this was the right hemicolectomy, elective. Same situation, tenderness guarding, tachycardia, and you have done an investigation, CCT, you find a leak. What will you do?
So I will observe the patient.
So that's what I'm saying. When do you observe? When do you know it?
That is exactly what we want to ask you on the round.
Retrocutaneous fistula, day 3 post-op. How will you decide? How will you decide?
So the patient is not having any fever, no any means sepsis related symptoms, and patient is not tachycardia, and the means blood pressure and urine output is adequate. Yes, sir, monitor.
Right.
Yes, sir.
Or today, that's where you like to closely observe whether it is spreading, not spreading, localized, what is the pose. If you find any stage you are finding he is progressing, you immediately take them. That is really important.
Any factors of the CT which will tell you you are going to fail conservatively? Regarding the leak, no connection. There's a leak, it's last time. There's a leak. Everything has done. So you should have told us. Contained leak coming out of the drain. No intra-abdominal collection.
Coming out of the then I will closely monitor. If it is the same shape, check.
No, and the question is, many times the leak on the third day may not be very evident. It may take 4 or 5 days. Only technical leaks usually happen in first 48 hours. Systemic leaks will take 4 or 5 days. So, third day is a very window actually. If you on third day because it's a very tricky question. If it's a technical leak, patient will start showing second day only. If it's a ischemic leak, it will show on the 6th day or 7th day.
Sure.
Third day is very tricky question. You must remember, examiner is asking, there's a lot of thought process by people asking. I just wanted to test your clinical, how would you take a decision on the round, maybe palpate and all. So, sometimes, on the round, you quickly ask, I want to do CT. It's okay, but maybe I would wait for a day.
After the CT, and look for any, other than the leak, any evidence of patient collection. Is there any suspicion of dyslipidemia? In that case, you are justified in doing re-exploration and diversion.
This is one scenario where you do ICG, definitely to do sigmoid kind of communication the patient.
I think
getting necessary and all. I would say that ICG. Anyways, what I think
Who is the candidate? Candidate is who is presenting? Yeah, tell us.
So he's a 29 years male, in case of carcinoma lower rectum, post neoadjuvant chemoradiotherapy. So now he is post of failure of ultra low angular resection plus diversion.
That's an idea.
So, what do you think?
When you come for the round, what are you going to look into this particular? You come for the round.
Day 3.
So what are you going to look into that patient? Then you come on the day 3 and you are talking to patient and then you're physically examining? What are you really looking for?
Sir, I want his, I want to see his whether he's conscious. Is he
On day 3, you expect him to be unconscious. Why don't we tell us the relevant?
I want to see what I know status. I would look at his pulse rate, his BP. I would also check if he has any tachycardia, his saturation is okay. And in abdominal findings, I have and his hydration status.
Why are you interested in the hydration status? Specifically. Is he likely to be more dehydrated than other patients? Expected.
Since the patient has a stoma, I would want to check for hydration. It might be unhydrated. He might be dehydrated. So I would like to check for that.
So if you suddenly find his stoma on the third day and drained some 2000 or something like that, and now they are not adequately replaced it. So how would you go about looking at his dehydration now and trying to replace it? What would you ask? What are the parameters you will look at it? What investigations will look, and how will you correct it? It's a very, very simple question.
The parameters that I look at are urine output, tachycardia, blood pressure, and in laboratory investigation.
Would you not also look at the dryness of the tongue, all these eyes, overall, all that also, you also don't miss that. I mean, I understand the complete the list.
Will you look at the ICU chart?
ICU chart and
how would that
How much input output was there? What is
So how do you calculate the fluid deficit based on the ICU chart? They've given 3 liters, urine output is 1 liter, stoma is 2 liters. Are you happy as well?
No, sir. I would also look for insensible losses.
How do you calculate insensible loss?
Are there any other drains behind?
The drain output.
Drain output. Insensible loss, what do you assume it to be? And what are the factors which change insensible loss?
600 ml.
So 500 ml as a reasonable insensible loss, and any factors which will increase this?
So the presence of fever.
Fever, pyrexia, and
the patient is
tachycardia.
It also increases.
Very good.
So they said it's ultra low, third post of the diversion ileostomy also done. You agree that what they have done diversion ileostomy, or you would do transverse colostomy?
Sir, in a young patient,
First time. Why not diversion colostomy?
So both of them have overall equal equivalent in most patients. It is a personal and the physician's choice. And I would prefer for a young patient who can possibly tolerate more like
You decide based on age whether to do diversion ileostomy or colostomy. Why young and
Why is the rationale of doing this? What is your philosophy?
in the elderly patient with possibly CKD, I would try to avoid an ileostomy and I would go with a colostomy.
the other advantage of ileostomy.
Because with a CKD, would you think you'd have an ultra-low?
Why suppose you are doing a patient, morbid patients, you are doing a colostomy. Why can't the same thing be applied even in fit patients?
What is the disadvantage of colostomy?
The disadvantage of closure, there is the risk of leakage with colostomy.
Which is simple to do.
Simple to cover.
So have you ever done colostomy? Temporary situation.
So for most of our patients, we do this.
So you do colostomy. But temporary also.
So what will you look at in the stoma of your
Sir, I would look at the color of the stoma, the good protrusion of the stoma in an ileostomy, and that would be.
If you're looking dusty, what will you do? But you're not very sure, you're looking dusty.
So day 3, I will not do anything. I will wait and watch.
48 hours is more than enough to know whether it is vascular or not vascular.
What's the leak rate of ultra-low mental resection? Not answer first question.
48 hours is more than enough to know whether it is dusty or not. It's not black, it's dusty.
Why does skinniness happen? Because of what?
Venous congestion. So
Condition to be because of
could be because of slightly tight stomach.
So you cut 1 or 2 stitches. It's okay. That's fine. Just trick question. Trick question. Yes, these are all trick questions I'm asking because see, that's the way you judge your whether you worked in the ward or you're not worked in the ward.
So what's the leak rate of ultra low anterior section? What is ultra low?
Ultra low is when the anastomosis is performed at the pelvic floor, following
What
the
is low?
anastomosis is performed. Below the peritoneal reflection is 200.
You don't know the leak rate of
10%.
anterior section. 5 to 10%. What's the leak rate of right anterior? No. I think it's 1 or less than 1%. So why do you think there is difference between right colon and low anterior section?
Almost, it is because
It's almost 5 to 10 times more than right colon. So there has to be some reason why the leak rate is more.
after the vascular supply of the left colon
Please
is
tell me.
poorer than the vascular supply of the right colon. Vascular supply of the left colon is poorer than the vascular supply of the right colon. So
Anything else?
then the extensive pelvic distance. The lower between the rectum higher than the face.
Why we are asking that only? One is vascularity of left side and sigmoid rectal area is less compared to right.
What have you done pre-op?
Radiotherapy.
Does it have any variation?
That also has
Exactly.
So second is chemoradiation. Any other ones? Does any age or something happen? Of course, you can't control it. Okay, we'll move to the next. What about rectum? Rectum is not serous covered at that level. It's totally extraperitoneal.
Peritoneal support which is there, it is not there. Many other organs in the peritoneal, it's
The most important.
It's in many of these areas. Too. Thank you. Thanks.
54-year-old male, known case of Crohn's disease. So we had vaginal perforation in the month of May. We have done experimental laparotomy, and that we found vaginal sigmoid fistula. We have done sigmoid resection anastomosis, segmental vaginal resection, and end vaginostomy, and the distal mucus fistula. So he has come for restoration of continuity. We have done this post of baby.
Any more information you want?
Have you seen the patient?
No, no problem. Any more information you want?
If some of them want to speak before they get otherwise he'll tell you.
First of all, what she told, did you understand what scenario she repeated? This is a 54-year-old man who underwent a medical surgery of
So sigmoid fistula, they dissected the sigmoid and suture grid, and the jejunum and the other end they brought out, and the stoma and mucus fistula. And now they are restoring continuity of small one. Yeah. Any more information you want about this case before?
This is cross disease. This is the information we want. I would like to know the birth state of the patient.
No. I mean, not for today, but in general, is this all the information you need to know for a patient of Crohn's disease?
I would like to know what medications he is on for the Crohn's. What do you expect? What do you might expect?
And why is it important?
I would like to know if there are any steroids which are being given for the patient.
Any other drugs? Which will be for
biological agents or
do you have any idea?
He was on good days previously before the first surgery. Now he's not on any.
Does he have an ICU actually?
I would like to know if patient is on RILES.
He has a right.
What is the time given for Crohn's? So, few days is what? What is duration? What is nutrition? Yeah, then you give prednisolone, you give biology. What are the other drugs which you probably give? Okay. Do you think this patient would have been on MMS salicylic acid before surgery? Patient did not. I would be astonished if he was. Why would I be astonished? He's there. He's there. I would be very astonished. Why would I be astonished? Because he's already on steroids. No. There is a stigma of and how does it work? Is that because unless they're crushing it and giving it down, then it's still up. There's no way because it's not going to act. So it would be silly of the physician to do that. So you need to know a little bit of medical gastroenterology along with your surgical. It's not an isolated. Like to know whether he was on biological in the meantime. They said no. Should he be on biological? Plan post-surgery surgery. I know this. I would like to know the status of the Crohn's disease post-surgery. I would like to pre-surgery. Pre-surgery. Operative findings. Findings.
It likes to be running say 1250 and it's not I mean the third take is running 1200 next kind of thing. Otherwise it's stop at pulse is fine, everything looks okay.
I would like to know the hydration status and disease with the patient.
Passing the urine, no issues.
If there's a fluid loss,
that's okay, but the bile is 1200.
calcium exposure daily. I would still very sick because patient is clinically stable. And I would like to know
do not like to ask whether peristalsis is there or not there.
I would like to know that abdominal findings, whether portions of the whether he has pancreas or not. I would like. And I would like to know if there is any abdominal extension is present or not.
What complications can you see or you look after jejunal stomach closure?
Restoration of small bowel continuity. What complications? Expect in a case of Crohn's disease. I might expect an anastomotic lesion and any active Crohn's disease that can be present, and patient is on steroids. If he's not on steroids,
alter what happens?
No, sir, he's not.
He's on steroids, but it's on locally, not on system.
Not on.
What insert setting of 1200 ml RT? What electrolyte imbalance do you expect?
I would expect a hypokalemia, hyponatremia.
How do you correct hyponatremia, hypopathy?
Hypokalemia, I would calculate the potassium deficit.
How do you calculate potassium?
I would like to send electrolyte.
Okay, so potassium is 2.8.
2.8. I would like to formalize 3.4 minus potassium into 0.4 into the body weight of the patient. That will give the potassium deficit.
Is it? Is there a formula for potassium?
To correct, but actually 60 milligrams to the patient.
That's a better answer. Yeah.
1 to 2 milligrams per kg body weight. I would calculate. Then I would replace 2 IV because patient is on right.
Correct. Is that enough for him?
No, sir. I would like to add at least 20 to 30 milligrams because
for the loss. Do you expect the future loss? So you'd like to correct for that. That's right. What is the maximum amount of potassium you can put in one IV? In a this peripheral IV line.
If they have monitors.
Yes, he's a nice you want him with an ECG monitoring.
30 milligrams.
Is that all?
In 1.6.
Yeah, 1.40 milliequivalent for the nice available.
Long gas is an ICU. Should stress on that.
There's a calculation of potassium, especially when you're taking markers of cardiac issues. There you want to correct potassium fast. You want to do infusion pump. So how much you give per hour? How many milliliters per hour? That's what they said. That's not correct.
What is important?
What maximum you can take, regularly how much you do infusion pump, which is safer, it is safe. Whatever. You can do maximum up to 20 milliliters per hour also. Usually normally you do 5 milliliters per hour. So whenever we see when it's corrected, you can stop it. It is not corrected, it will continue.
How many interviews of ACL is 40 milligrams? If you tell the nurse, so there is no mistake. How many ampules of ACL will you take at one point to get 40 milligrams?
Depending on the volume of the ampules.
You have only, I don't think you have 120 ampules of ACL across the world. It's all standardized. Practical. So what wrong is for practical thing? Have you seen an ampule of ACL?
Each ampule is 10 milliliters.
10 ml?
1 by 10 milliliters.
No, it's
Is another question on how you calculate sodium?
Sodium. The sodium is 126.
Does it matter to you? Okay, how will you?
Here there is a formula, you can tell it. It's called 0.6 W deficit.
Anything else you want to ask? Anything else you want to ask? Any other things you would like to know? No? Fine. If other questions on rooms?
After that, what about the patient
On treatment? Exactly. How will you restore the treatment of Crohn's after that?
What treatment will you advise? But he is now in a phase of remission, right? No activities. So, do you give any further treatment or you just keep the patient on?
I would like to keep the post-operative status.
Recover.
The patient is stable, no active lesions, then I would wait.
Wait for active lesions.
No, sir.
Do you believe that in fistulizing Crohn's, this was fistulizing Crohn's, yes, biologicals need to be used?
Before resection, after resection.
Then after resection, we would like to start him on biological so that
When there is no active disease.
When the patient is absolutely fine, why do you want to give biological?
Used in the maintenance or?
There is for maintenance, there is already patients. Patient is started on infection and then we'll continue biologicals for maintenance. So, in moderate to severe disease.
Which biological? Most commonly.
What precautions before you start biology?
There should not be any active infection.
Particularly any. How sure are you this is Crohn's? If the gastroenterologist told you this is Crohn's, we believe.
I would like to review.
What else can it be? Which looks similar to Crohn's. Really. But for a gastroenterologist, you are not going to explain. Which other disease would you expect? Tuberculosis.
But the role of other brain is very important for other brain. You wanted to know the activity of the Crohn's also. How do you know the activity?
Like we do endoscopy and then check the radius, whether there are any active mucosal lesions, whether there are any granularities. The ankylosing absolutely.
Thank you. You've done well. Thank you.
So, this is 59 years old male. 59 years old male. He is known as functionate process growth. So he is post-op day 5 because pancreatic ductal.
Day 5. So,
most critical day.
Stable day 5, what do you want to avoid? What do you expect and what do you want? I want to know what are the drains, what are the tubes, and regarding police catheter and the vitals.
The rate kept at the pancreatic anastomosis is 100 ml. 0 centimeters.
Okay, and what about the registry?
Right, is insipid.
Day 5, ICU insipid.
Only is removed. No other drains.
And I want to know the details of the surgery also. What was the time? Any feeding access was done during the surgery or not?
It's feeding diagnostic.
Feeding diagnosis. And I also want to know the brain fluid amylase whether it was done or not.
Brain fluid amylase is 2005. Serum amylase is normal.
And drain quality is 7 minutes.
You want to know more information about the registry?
Yes, price to output, how much is the output price to output?
Today it is 100 ml.
Yes, that's 24 hours.
What are you going to look at patient now?
First I want to examine the patient, the vitals.
Vitals are normal. Pulse is about say 90 and BP is normal. You will not put is adequate. Overall, he looks quite okay. There is, you see that there is no deviation.
I want to see the drain qualities. And I want to palpate the abdomen. I want to check the bowel sound.
Abdomen sound, bowel sounds are sluggish.
No distension.
What next? And I want to ask about the patient whether has passed.
What is your concern at this stage? Now see, you know that the average is 2000 and but otherwise patient looks okay. Now what is your concern this day 5? On day 5?
The concern is patient according to the IASG
Happy or not happy? All these reports.
Will you call it as a pancreatic fistula?
Yes, sir. It is a pancreatic fistula, POPF, biochemical POPF, and with GG also, according to the IASG classification. Sir, POD is 5. If it is keeping beyond 3.
No. You are keeping, or the patient or the aspirant has made you keep, or it is a voluntary decision by the team to keep. See, that is what you are not asking.
Just put the drain even if it's not draining much for 1 week or so.
No, they keep a rice tube also.
Yeah,
it is an individual policy. You not ask whether it's 100 ml last 3 days. Some people will say drain fluid amylase is 1000. I want to keep rice tube for 2 days. You may not be following ERAS protocol, right? So what you're saying is correct for ERAS protocol.
According to the IASG based.
No, but the IASG based criteria is in a particular setting. Now I can put a rice tube in myself and keep it for 7 days. Will you call me delayed gastric empty? Correct, no? So it has to be in a setting.
Level is not something which is really significant. If you put a rice tube anyway, you know.
About the situation we have
Maybe as the patient is having biochemical POPF, pancreatic fistula, so maybe that may be one of the concerns for keeping the rice. But maybe some other factor,
No, so that is for the local team. You have come to another hospital, tell us what is my wrong suggestion is you don't criticize what the local team is doing by telling them that they're getting EG or the rice tube is there 2 days longer than it should be. So you just have to say what to do.
What you can do and what are
you're visiting another hospital.
We are interested in how will you assess and how will you take a decision. That is what our concern.
As the patient is having POPF, that is biochemically proved, and the rice tube output is only 100 ml last 24 hours. I want to assess for another 1 day or 2 days.
Would you like to see there's a collection inside, is it
Yes, sir.
bleeding or not?
Sir, as the patient is not having any tachycardia, vitals are stable. So
you will not do any
present,
investigation.
immediately I don't want. Immediately.
So when do you want an investigation and when otherwise how are you going to just conserve it?
Sir,
or
if
what?
suddenly the drain output becoming low and patient is having symptoms like patient is becoming febrile or patient is having tachycardia or there is sudden fall of BP or there is a routine blood examination showing some lymphocytosis.
I'll give you another scenario. This patient goes on, 100, 70, drainage is coming, otherwise patient is stable, you put him on to some rice tube is removed, you start taking on liquids and all. On 14th day, he starts getting a large amount of blood. So what will you do? My question is very clear.
Yes.
Patient is otherwise improving. On a 14th day, he has a huge dream. All blood starts coming through his brain.
But then patient is having late post-pancreatic hemorrhage, extraduminal, so it's coming through vein.
You don't know whether it's coming from urine or it's coming from the drain.
No, there's blood in the drain.
The blood in the drain.
Now you're on the wrong.
Rice tube is removed.
Yes.
The patient is in the ward.
Yes, first I want to check the vitals of the patient, and I want to check the immediate hemoglobin and.
Are you going to wait for hemoglobin report to come, or you want some
No,
immediate action?
Immediate, sir, I want to call the blood bank.
You call the blood bank, 5 units are now.
And I also plan for, I also want to look renal function test, what about the evaluating level.
And you want to wait for 2 hours for the creatinine?
No, sir, that I will check the previous day which is available, the latest evaluating level.
Normal.
And I plan for contractional CECT,
You
angio.
have an ID first, then
Yes, sir, I
given
will.
all that access, you will consider it. Because you must have removed all that access first, right? And
Resuscitated and resuscitated.
yeah,
And
so what do you think, what has happened? Why the bleeding has come? Now, where
sir,
the
as
bleeding
the
has come
patient
from?
is now,
What is the common thing with that?
the patient is already having biochemical POP, so maybe because of the POP that can cause post-coronary hemorrhage.
From where?
The most common site is the from the, it can be from GDA stump, which was which is tied
Erosion or leak of that.
or it can be from the cut surface of the cannular, or it can be from the other from GJ side also, or it can be from other.
Will the GJ side come in the play?
No,
Yes.
it will not come.
So if
This is the first to say is okay.
A40.
See, you relax. Then you're not
Secondary kind of
so you don't keep giving answers just because after you given 2 correct answers, then I think you can stop here. So what is the action?
Patient resuscitated, you have done CT angio. That's what is your plan?
Yes.
So you have done CT angio.
While the CT angio is going on, is there anyone else you want to urgently call?
Keep them ready.
What do you think is going to happen after CT angio?
Sir, I want to discuss with the intervention radiologist.
You're going to just discuss with him.
No,
He
sir.
said, I'm in bed, I'm not coming. What are you going
No,
to
sir,
say?
I want to discuss and making available.
You want to say, come down now, I'm doing a CT angio, I want you standing in the hospital because in 5 minutes from CT angio, what will happen if you don't act for 6 hours?
If it is if any
His
positive,
pulse is okay now, BP is okay now, what's going to happen 6 hours later?
sir, it can be hemorrhage bleeding. There will be some
Absolutely. So he might be dead after 6 hours. So there is no time. So you have to. So that is what the examiner is looking for. That this is not something where you are doing in a
idea
relaxed
is
manner, waiting for blood.
why I asked you these 2 questions. The 3rd day or 5th day when you saw that time to go slow, be conservative, that is all fine. But in a situation when there is a bleeding, you have to be very quick and organize everything very quickly. Now this kind of an decision and assessment we want to do in this particular examination. You understand my point? It's not only a question of how will you assess, but how will you quickly do it. That's what we are looking for. How promptly you will do it, or whether you will sit on him. But there are so many times in a surgery we realize sometimes we sit on it, sometimes we have to do. But this is one situation where you have to act very quickly in hours.
CT angio done. It only shows a clot in the right side of hypochondria. No active bleeding site is detected on CT angio. What will you do?
Practical question.
It happened to us.
Yes, sir. So in our hospital, we are doing empirical embolization.
It's no empirical DSA. Then you see what you see on DSA.
Yeah. You will go ahead and do DSA.
Yes, sir.
Irrespective. So why then why do the CT?
I not do
Why not go straight for DSA?
Roadmap for the
So the interventional radiologist would want the CT angio, so in case it shows it's the GDA or a small jejunal branch from the SMA, then they know which vessel to cannulate first. That's all. For his happiness, you're doing it. Sure. Good.
So, this is a 55-year-old male, case of hepatocellular carcinoma. Day is post-op day 5 of right posterior section. Hepatocellular carcinoma, segment 7 and 8.
Day 5.
Day 5 of right posterior
This is the same patient we just presented yesterday.
Same.
You want more information?
segment 6 and
Close to it. I want to know about the pre-operative investigation of the patient.
With what aim do you want?
I want to see the child score and status of the liver.
Cirrhotic,
It's a non-cirrhotic.
Non-cirrhotic. So what about the volumetric?
It's a right posterior. You really want to know volumetric?
I think you were seeing yesterday case. No, that's the same case. If you remember those.
Non-cirrhotic liver, the right posterior.
So as of now, since POD 5, I will first of 4 more severe patients, clinical condition, and their parameters, and I would see the urine output of the patient. If there's the drain, I would like to know the quantity of the drain, color of the fluid that it is.
When do you remove drain after the liver?
Should you not ask why the drain is there on the drain?
So that is the same question. Like, when do you remove drain?
So basically, our concerns are.
The question is, when will you remove a drain after the liver? You have to see. I don't want explanation. I want an answer. Then you can explain. Will you place a drain in all cases? So you routinely use the drain. So what is the logic of placing the drain? You explain to me. Then when will you remove it?
Sir, if drain is not the drain out.
So you wait for it to not drain.
If drain output is less than 50 ml, and
you wait for it to be less. What is the purpose of putting?
One is to see if there is any hemorrhage.
Okay. When do you expect hemorrhage to stay?
Hemorrhage will be, sir, early.
Early. How early?
Yes. It will be as early as 24 hours or within 24 hours.
24 to 48 hours. It is going to be.
Yes.
What is
Bile leaks.
How soon will you see a bile?
It can occur up to around 3/3 BOD.
So if by 72 hours, even if the drain is 60 ml or 80 ml, there is no bile leak or there is no blood, is there any rationale to keep this drain? You don't necessarily have to.
If it is not serving the purpose, there is no point.
Is there any harm in keeping drain?
Yes, this can lead to complications.
Which complications?
It can lead to infections, retrograde infections can occur. Second, it can lead to erosion of some structures in the vicinity, like blood vessels, or if it's prolonged, it may lead to sometimes injury of just erosion into bowel health.
Okay, now you're seeing 80 ml of pure bile in the drain. Now what do you do?
80 ml of pure bile in the drain, with considering the patient to be clinically stable with no abdominal pain, I will just observe him, and I will not further investigate him, as he is not.
Even after 7 days. Okay.
How long will you observe?
Also bile is there.
Then, sir, I will go for an imaging, look for the area of
The question I asked.
for how long we will wait.
Persistent bile leak.
80, 100 ml, it is not reducing. It is a constant 100 ml output. What are you going to do?
That imaging.
What imaging will tell you?
What are you suspecting for which you want to do an investigation?
I would like to see if there are any biliary radicals that are leaking, so that will be different.
No, now there is a bile leak. Now what do you think is leaking?
So what do you want to
We will plan for an endoscopic broadly to relieve the pressure.
straight away go for endoscopic spectroscopy or before getting endoscopy?
What are the possibilities of what is leaking in a right posterior sector? It's important where the liver is actually.
One is it can be from the surface, sir. It can be small.
Okay, so what usually happens to cut surface leak over time?
They over a period of time
They settle down. So the very fact it's 100 ml, it continuously means it's unlikely.
Yes.
So what are the others?
Other, it can be from the sectoral branch that have been divided at the time of the surgery. So, or divided or clipped, maybe that has given way and that is leaking.
Yes. So which way can you divide a sectoral branch? No, so which way can you divide a sectoral branch? There are two ways you can damage any bile. Right. So whether is it in continuity or not in continuity?
Yes.
Why is that important?
Because then it will be important. Then it will be helpful. If it is in continuity, only then a bleeding decompression is going to help. Otherwise, it will not.
Disconnected, that will not break.
How will you setting? How will you manage?
How will you know whether it's disconnected?
We can do a HIDA scan, sir. And
Have you ever done a HIDA scan to manage such a patient?
Oh, HIDA scan will help you. No, it's not bile leak.
It will just show bile leak.
That's all.
It's not enough. It's not enough. No. It will just show bile
It may
leak.
give, but it's not practical.
It may not be.
It was done. I mean, there are papers on this, we used to do it. And
Such a situation, you need a specific investigation to delineate what is happening.
Where is it leaking from? That's what you want to
So
know.
what is the specific
MRI
investigation?
with MRI.
So you do an
So
MRI.
that may be helpful in showing you
Whether it's connected or not.
Connected or disconnected.
Suppose that MRCP, MRI shows that it's a disconnected segment 5 and 8 duct is leaking, not in communication with the rest of the biliary system. That's a strong possibility, no? If you have a persistent biliary fistula following post-resection.
Then if it's not settling, then we have to consider for exploration and
Like, can you ligate this?
or else we
If
can
you
switch
switch it up, what's going to happen?
or else
If you can switch it, it's or find it. What's going to happen? The liver is intact, portal venous supply is intact, arterial supply is intact. If you tie off a segmental bile duct, what happens? It's going to blow out again because bile is going to keep being produced. It's all triable. So that's not a good idea.
this biliary enteric and smooth that all.
Are you going to be able to find the duct? And it's a normal diameter duct of 1 millimeter. And then put a rule loop there.
Best option is what?
I want to do a formal right hepatic
So completion right.
So no rush to do it. Yeah, the patient is stable and the bile is draining.
Let me ask you another question. If you find you have done a typical bisegmentectomy and you have a borderline FLR, on the fifth day you come to the patient is not, you feel is not responding to you very well. He is still confused and all. What will you do?
You understood the question?
Yes, sir.
What's the
Problem is for most likely POD5 is post-operative liver failure. He is going post-operative
So
liver
tell me,
failure.
how will you confirm it and how will you treat?
We have to see the general condition of the patient and certain investigations will be required in the form of I will need an LFT, I will need a PTINR, I will need a saturation of the patient, I will need a urine output of the patient and blood urea nitrogen levels. And then to grade whether it is A, B, or C. And accordingly, the management, if it is a grade A fistula, that can be managed in the ward setting.
If I heard you right, you only said about LFT and what else?
The PTINR,
Blood urea nitrogen. Tell the significance of those investigations.
those all investigate, if urine output is less than, if it is a 0.5, greater than 0.5 ml, so this goes in favor of 1 grade A liver failure. If blood urea nitrogen is less than 120, 150, it is again in favor of
which post of did sir tell you?
day 5.
What is the importance of that?
So at day 5, we have to see the synthetic functions of the liver may be impaired. It will be in the INR and bilirubin will be raised. So if there are two, one is Gaussian 50-50 criteria.
What is that?
Where there is a elevation of bilirubin to 50 micrograms per liter, that comes to 2.92 milligram per deciliter, or INR of this PT of around 50. So if those are at the day 5, so this is considered to be a post-hepatobiliary liver failure. Or else by IS International Study Guideline, it is any post-operative acute dysfunction.
So how will you manage post-bisectomy, liver failure which is confirmed by your LFT PTINR?
It will depend upon, as I told, we have to grade it, whether it is A, B or C. If it is grade A, it does not need any deviation from the treatment that patient is already receiving. If it is grade B, we have to give certain medicines, like we have to give FFP to the patient, albumin has to be given to the patient, dialysis has to be considered for this patient.
You have tried all the conservative measures, patient is
How is FFP going to help?
For grade B, it is recommended.
How is it going to help?
It's going to improve
Giving FFP is going to improve
clotting.
And why do you want to improve the clotting? What is the patient bleeding?
But since the liver is not functioning, so we want to support it with that factors.
So if you give FFP, how do you know if the liver is improving or not?
We have to monitor lipogram.
So you give an FFP, so now your coagulopathy going to be meaningful.
I think we finished the answer.
Liver failure not important.
Then we have to consider if there is a liver failure not improving despite the best support external liver device not improving, the salvage is
Salvage what?
Sorry, look, we have to consider removal and transplant.
Why do you think he's had a right dissection? Commonly, 99% of indications are
Very high level.
tumors, no? Are these transplant? So 7 days, 8 days, you go to liver failure after surgery, are they candidates for?
Again, yes and no answer. Whatever, probably no, but if there is a living donor,
You are a very brave man. You are a very brave man. Okay.
we were forced. In one situation, we were forced to.
Relatives will always ask you. Yeah. See, relatives will always ask you, be firm and say no.
The relatives forced us to answer that.
Yeah, say no.
Thank you so much. Thank you so much. I appreciate all of your advices. We were a little more tricky.
Mahesh?
Yeah. Done?
Yeah, you can continue. We are done.
Okay. Right. Thank you. Thank all the faculty and the students for that. We move on to the last session now. This is what we normally have in our regular exam post lunch. There are 4 or 5 segments in this particular thing. One is instruments, operative procedures, specimens, research methodology, and radiology. I would like to request the faculty to come up and then brief the students on what is asked and what is expected out of the students in this particular segment. Briefly. Sir, Shastri sir. It's for completion's sake rather than anything. You can make it interactive. We can make it interactive. We kept a specimen, some instruments on the table also.
Well, let me say from my limited experience as an examiner, we have got very experienced examiners like Ashok Kumar, who is sort of the traveling examiner of India. And Anil Agarwal, I should not forget, another traveling examiner. And Dr. Shastri, these are all the expert examiners. They examine the examiners. No, but by the time you come to the afternoon session in the examination, let me tell you that 99.9% whether you're going to pass or fail has already been decided by the clinical rounds. This actually doesn't really change the outcome of your clinical performance. Maybe a very rare borderline candidate may, with very brilliant answering in this, may scrape past his poor performance, but rarely it affects it. So, that's the first honest thing I should tell you, that by the time you come to this, your fate is already sealed. This is not going to change it much. But what we expect here is that we expect you to know your instruments, know the name of the instrument. So you should know what is the difference between a Mayo-Hagar needle holder and a Ryder needle holder. You should know that. I have found that many examiners, many students don't know that difference between the various needle holders, the various types of forceps. So you should know that, because unless you ask for that, the nurse won't give you that particular instrument. You can't be asking her for again and again a change of instrument. And you should know what it is used for. Why you will ask for a Ryder, why you will ask for a Mayo-Hagar. You should know. You don't ask for a Mayo-Hagar to do a vascular anastomy. You don't ask for a Ryder to do an abdominal wall closure. You should know that which is used for what. So that's what we expect from the instrument. The specimens are more like, at least in my opinion, a starting point of discussion of the disease, what operation was done, what could be done, what are the various operations. And of the most important, I think, of the lot is the operative procedure which you are asked to describe. And in the operative procedure, when you are described the operative procedure, a brief, you should answer by giving a brief on the indications. When would you do it? How would you prepare? What position you will place the patient? If you are used to using a sandbag under a particular shoulder or a back for a particular position, you should say that. So the positioning of the patient is very important. It should be told. And then what incision you will select. And then the operation that you select. And if you are doing an operation which has multiple ways of reconstruction, for example, you do a total gastrectomy, you could do a Roux-en-Y esophagojejunostomy, you could do a Hunt-Lawrence pouch, you could use a pouch to replace the stomach between the esophagus and the duodenum. So there are multiple ways of reconstruction. If the examiner asks you these questions, you can tell. Otherwise, we just ask you the reconstruction, just ask you the operation. Tell one reconstruction which you normally do. Don't start there telling so things can be done. You are doing what you are going to do, you tell the reconstruction that you normally practice. If it's a straightforward Roux-en-Y gastrojejunostomy, say that. If it's a loop gastrojejunostomy with a jejunostomy below, say that. Whatever you routinely do, these are all accepted operations. That is what I would expect, and pass it on to.
In examination, as Ramesh Sadhanari said, most of the times your fate is decided. Mostly we give, at least I give preference to the ward rounds, because the case discussions must have gone well, but ward rounds where unexpected questions are asked. So if you answer well, I think most of the times you are through. And in the post case presentation, operative things most of the examiners will concentrate on, and the students try to explain, which is not done routinely in the institutions, in their hospitals. For example, a Whipple's procedure, even though if you do a routinely PJ, you start explaining PG. So that's where, surgeon teacher will ask whether that's done routinely in your institutions, which is not done in fact. So that kind of a thing, whatever which is routinely done in an institution, it's better to explain than, vague answers. So I do expect this kind of things rather than unusual things.
While describing, for example, an anastomosis, the answer should be complete so that the examiner doesn't have to ask you questions. Sometimes I ask on the rounds, what anastomosis, how do you do it? They will say, jejunostomy. Now, then I'll ask them, end to side to side. Then they will say, side to side. I will say, what suture? Then they will tell what suture. Then I'll ask, continuous interrupted? Then they will say one answer. So, you should not give this chance to the examiner. So, when you are asked to describe what anastomosis you do, you should tell them, I will do the gastrojejunostomy. You do what you routinely do. I would define my routine gastrojejunostomy as a horizontal juxtapyloric gastrojejunostomy done with a single layer of 30 PDS. So the entire answer is clear. It's single stroke given your suture, you have told what is the lie of the thing and where you're doing. That's what I do. So you should give complete answers. So like if you're doing a hepaticojejunostomy, you are asked, how will you do it? Sir, I will do it with the Blumgart-Kelly technique. If you say that, you really don't have to define the technique because everybody will understand what that is. That it's an interrupted where you take the anterior layer all and hold it up. Then I do the posterior layer, then I do the anterior layer and do it. So don't wait for the examiner to keep asking you the questions. Certain questions can be answered in one sentence so that the examiner can move on to the next question.
The specimen part is, it's very difficult, frankly speaking, it's difficult to identify the specimen for the examiners too. So probably if you identify, it's a starting point for a discussion. So I don't think you should be very serious about the specimens part. Yeah. 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 True.
First thing I would like to confess is I always thank my staff that have crossed all these examinations and sitting on the other side of the table. Because I can always get into the minds of the examinees and what kind of idiosyncrasies you would face on the examination. After all, your examiners are also human. They have their own biases. And the expectations are unfortunately not uniform. That puts a lot of burden on the examiner. This examination system being as it is, you'll have to unfortunately face the system and try to find the best way of wriggling out of the system to get onto this side of the table. Now, this is the last part of the examination. The examination system does allow some marks for these significant marks, in fact. But again, this is not for, you are never solely judged on this level. Most of the time, as already mentioned, point or more theoretical or practical. Don't think you can be coached on that area like this. Question like this, coach please. But for the examination purposes, it's best for you to prepare yourself with the standard instruments. Most of the time, what is judged is whether you had an exposure to these instruments at all, where you use and how you use, rather than the parts of the instruments or technical details. How exactly you use and what are the various indications where you use this kind of instrument. Most favorite instruments are the ones, the staplers there, the laparoscopic instruments, or the vascular instruments.
Vascular instruments especially are a favorite. They keep them and you should know their names.
And it's always good to know where exactly you use each vascular instrument, which kind of vascular anastomosis or surgery. Well, these are some of the tips as far as the instruments concerned, but I think you should prepare yourself. Maybe you should list out the instruments and write down your own. See, the best preparation is where you use your own brain to make a summary for yourself, because that would be more lasting. Not only about the instruments, but even from sessions like this, how exactly you would benefit yourself. What I would do, what I have been doing even at this stage from our Monday clinics is, when I find a question which has more than one answer, Monday web clinics, you're at a loss to answer how exactly. When you have two options, you don't know what the examiner has a bias for. So those are the questions I would list out myself and try to make answers for myself. See, when you
but if it's an operative option, then the best thing is to select the operation that you do in your situation, because you are familiar with that procedure. Isn't it, Raj? You don't agree with that?
Yeah, you already mentioned that. Yes, that of course is the standard answer. But then the questioning does not stop there. Your own whatever procedure you've been seeing in your place may not be the best. So you should know the advantages or negative or positive points for each option. That is what is expected of you, rather than making a decision right now at this stage. I would select this option because this is the best option. This is the one which I have been seeing in my center. Although that is one favorite answer for many people, and many examiners have been trying to tell you that what you see in your place you should mention. That is true in a way, but that is not all. It's an evolving situation. Your circumstances may be limited in terms of resources, in terms of skill, in terms of the clinical material itself. But at this stage, you need to have an open mind of various options and what are the advantages and disadvantages, and keep with the evolution of these options over a period of time, so that this becomes a basis of your learning and you improve upon it as you pass out. After all, exam is only one step in your ultimate career. But this should be the right step so that you prepare your mind to the evolution of a problem. Where exactly you stand, what is your level of understanding at this stage? I think that is much more important than sticking to one procedure which your center is doing. In the worst of circumstances, yes, when you do not have a clear knowledge of all the options, that is the easiest. But this is what we have been doing in our center. Most of the time, okay, if it is, there's no way for me to check whether that is the procedure you've been doing in your center. But I have a right to question that. I would question a little more subtly, saying what are the advantages you find, and is there another option which may have a better advantage, which is done in elsewhere. I think that also is important, apart from saying all the time that you want to you want to do this because it's done in your center. Now, the preparation, as I said, is from your web clinics and from these. If you revise, if you go back, our attention span is not too much. What you have listened to in this 1 or 2 days, you may retain only maybe about 30-40% of it. You need to go back for each case. What were the questions asked, and not necessarily the solutions that were given here. You work yourself on that and try to get an optimal answer and use your mentors to correct those. See, you that develop your analytical skills, the way you go into the literature and try to find an answer for a clinical problem, and it improves your writing skills, and you have the advantage of having mentors, the senior mentors for in general, for a general, a question has depth. A broad sense is what is judged generally in the examination, a theory examination, whether you have a grasp of that particular problem. If you go too much into depth, yes, a question has components, and a component may have a depth. There you are tested into the depth of it, and you need to go into the depth. So how you formulate your answers is an art that you need to practice over a period of time, and that is done best by identifying the clinical problems in this kind of sessions in your web clinics on Monday morning. Write down those clinical questions and try to make answers for themselves, for yourself. Improving your writing skills, not in bullet language, as you would probably answer in an examination. Get it corrected by your mentor, and that would become a kind of a permanent thing for you a basis over which your learning would improve over a period of time. When the subject changes, you can improve upon it. That you would see in 3 years, the way subject is changing so fast, you would realize that what you have learned in the first year may not be completely true in the end of third year. So you have to become a part of the evolution of a problem. That is what you have to concentrate on, and that would serve you best even in the examination. These are over a period of time, I've realized that this would give you the best way of learning from books, learning from your clinical experience in your own center, and learning from sessions as this and the web clinics, and you have a lot of web clinics these days. Don't go by the content of those web sessions. The content is important, but they are not always priority based, they are not always evidence based. You have to correct yourself. You have to go to the literature yourself and make evidence based solutions out of these clinical problems. This I'm saying out of experience, because a lot of times you don't have time to correct yourself in sessions which are not reviewed. You may go with kind of strong impressions sometimes. So you have to, at your stage, your maturity, you have to go into the subject, make solutions for yourself, and then correct it by your mentor.
I want to say that the kind of consensus guidelines which are coming in last 5 years on every small topic, whether it's a SAGES, European, American, Japanese, or even Indian, I think they are changing so rapidly that we should at least try to see guidelines which are done in 3 or 4 years, not something which was done in 2012 or 10. In fact, we should normally try to look at guidelines which are done in last 4 or 5 years or something, and try to see whether there's a new guideline which has come, and then try to see how it applies to your situation and how you need to adopt all some of these aspects. That is something which exercise we should do as a student all the time.
Ashok, sir.
Shastri has rightly mentioned what I feel that during the clinical presentation, both the longs and the cases, short cases and odd round, you should be very good in history taking, and once you take the history, you are able to make some differential diagnosis, and then after examination, you can include or exclude some of the differential diagnosis, and based on that, you plan your investigation side by side in your mind. And once the question is asked, what will you do next? You should be ready by that time while analyzing. These are the possible investigation to reach the diagnosis, which stage the disease, and this should be possible therapeutic intervention. You may be wrong, but maybe sometimes they totally go upside down the clinical analytical mind, but majority of time you will be true. That's not if you make a wrong diagnosis, they're wrong. It's a way how analyze, you logically explain your way of planning and execution would be acceptable. And ward round is mostly the post-operative cases to see how you manage these post-operative cases. If something goes wrong in the first day, second day, third day, like you take the biliary case, if the bile duct, bile drainage is coming or blood is coming, how will you do? Suppose that the patient is ileostomy or colostomy, what will you look the first post-operative day on a patient, whether this is dusky, this is functioning, not functioning, edematous, it is blackened. So you can then, how will you manage it? Why this has happened? These are the few things happen. And then suppose that you have taken a pancreatic case, obviously there are several questions will arise. I mean, the post-operative pancreatic fistula, bile leak, burst abdomen, external varicose, hematemesis, melena. So what went have gone wrong? That is the one part. But the most important bit, how you take corrective decision in the post-operative period. So we are looking for that. And the final is your success or failure depends on not whether you have correctly diagnosed or not, but the way how you have analytically analyzed and presented the fact. And most of the time, if you are able to have a basic knowledge of the subject you are through, and if you are accessory knowledge in the form of recent advances and current knowledge would be add to extra mark, but it's not to stop you at that point of time. These are the few things I will add. The instrument has been discussed, pathology has been discussed, operation, you have to pick up a slip from there. Which one you will find you don't know. Sometimes you pick up one you haven't seen, you don't know about that operation. Sometimes we ask you second one, again you don't know. Then we ask, okay, what operation you have done or seen, describe that. So you, if you say I want to do total gastrectomy, then you should know. Don't suddenly jumped in, I will do extended cholecystectomy or gastrectomy. Think which you can better explain or know, only then open your mouth. And that start from obviously the indication, then the anesthesia, then positioning of the patient, step by step procedures. Then if you can successfully tell time permit, then the post-operative complication is also being discussed. And the other important thing in addition to that, I'll suggest you read this. Statistic is the part of this examination, because as a postgraduate training, you are supposed, you do thesis, you publish paper, you search the literature. So you should know how to search the literature, how to find out the material, how to write introduction, how to publish a paper, how to collect the references. And these are the few things related to then statistics will come, which statistics you will apply based on this, your thesis or project, and based on the data. And so, because you're supposed to know all these is a part of your training. If so it is part of the curriculum and part of the training. It's not only theoretical knowledge and only surgery. There are so many things you have to know about the instrument. Like instrument, I may ask you, tell the first identify the instrument. Once you identify, then the next question is, what are the various parts of the instrument? Then what are the various surgery which you will use this? And then comes the technical part. If the instrument is stuck up, sometimes if you know better, then we will ask who invented this, who described this. So there are many things, and I'm sure if you are able to have a basic knowledge and skill, minimum required criteria, you are through. But if you fail to the basic history and clinical examination, that is the problem for taking a further decision based on this. And if you have any question, we can answer any query in your mind.
You've got all the gyan from all the people, and it's all very important for you to get through the exam. I would be more interested, because we've been speaking all this time about what issues you have in mind, because there are all these people sitting here, and I think next 20 minutes, half an hour, you should use this. Your 4 points, if I have to say, I would say be confident, but no overconfident. Have clarity of thought. Take time to answer the question, but don't start with repeating the question. Quite irritating. So gather the question, take time, and then ask. I also
And if you
feel
don't know the answer, once in a while to say I don't know is perfectly acceptable.
also, you know, it's not about when you are discussing your body language, method of discussion should be not at looking at approval from the examiners and then proceeding. It is clarity of your thought which should come out. If you are looking at ultrasound, it doesn't work like that. So you need to be more confident. And the other thing is, because you are at this level, you are post MBBS, MS, and now super specialty, we expect that you would be discussing rather than presenting. By that, what I mean is there should be a mature ability to discuss things maturely. So if you give a certain option and the person questioning you says, what about this? That doesn't mean that you are wrong and you want to immediately change. But you should have the ability to discuss out why you have chosen a particular path and what are the benefits or disadvantages of that, or why you have not chosen. And once in a while, as always we say, and what Ramesh has said, that you may withdraw and say, well, I may have to review what I was thinking, and this is what I would go across in future. So these are some of the things. And the other thing which I always say is that, for some critical areas which you will get, esophagus, rectal cancer, pancreatic cancer, you should have very strong literature backing in terms of the approaches which you are going to suggest to the examiner. And when you have some randomized trials which are well documented, are accepted by all, you should have it in your armamentarium to quote that and support the option which you are choosing at that point of time. So that is also important. About instruments, my thing is that you put everything very clearly that what is. But I feel it's an opportunity or a push to you to look and see that you should be comfortable to use these instruments and know the problems, troubleshooting, and the places where you're going to use it. So that's the idea, and that's what is going to be asked of you at that point of time. These are the few things which I want to tell, and what I want is.
One thing at the end of the examination, what one is looking at the examiner from you, that you are being awarded the highest degree in your area, and you have to give expert opinion in different situation referred on a patient to you, or maybe your general surgeon is looking for you answer from you. Even the educated patient come to GI surgeon for a very specialized opinion. So whether you are able to take a decision or not, that is more important, with confidence and with really with a little bit of maybe reasonable knowledge on the subject. That is we are looking before you are awarded the degree.
So everything said. Thing is, you look for whether you are safe surgeon or not. That will be the main assessment actually. And nowadays people are missing out on bedside clinics. Some people are missing obvious VGP, obvious neck nodes that we cannot. The same way, be truthful. Examine an exam. Find out your trained with the line. That also many people don't follow. Nobody is expected to know everything. We go in that line. Are you a safe surgeon? Not only a surgeon, an operating physician. The small things can cause patient life. So it's the basic things were thorough. How to manage hyperkalemia. When there is a reduced urine output, instead of hydrating the patient, the dehydration should not be last. Not make out any obvious mistakes in small. When coming to operative surgery, always discuss consent, proper consent. Very they would look into that. You are discussing proper consent. Everything, all the people said, don't. You have to face that. As will be there. But most of the exams are always consent. Look at always your safe surgeon or not. So everyone keep learning. The more of license to learn more and more. Be specific also. Don't waste your time. Yes. And answer specifically. Don't waste the time also. Time is very short.
Sir, last 2 days we've been hearing students telling I'll discuss with the radiologist. How much of image reading do you expect the students to know on their own and then interpret them? Can you be?
I think we expect them to know the fundamentals, but I think the radiologist, see, you see small pictures of the CT scan on a picture, but the radiologist is actually seeing it in a giant monitor. So obviously, with very high resolutions. So obviously, they will pick up things which we may not be able to see with our naked eye, but gross things we should be able to see. And I think fundamentally knowing whether it's a T1 image or a T2 weighted image in an MRI, whether it's a contrast CT or it's a plain CT or it's a negative contrast in the oral contrast, these things they should be able to make out. And then identify at least on a CT scan the stomach, the liver, the gallbladder, the pancreas, the duodenum, and the small intestines and the colon rectum. Identify the vascular structures in the contrast. These they should be able to do on a CT scan. MRI, I expect them to do less because still many surgeons, even we are not familiar with MRI.
Because I'm not familiar with MRI. Today, I think it is not right. It is important that you should know about MRI also. Where MRI is indicated, you have to say MRI.
Yes, you have to say yes.
That is not the answer that I am not familiar with MRI. So you
So
should
there are
be
certain
knowing about
areas where MRI is a must. For example, rectal cancer. To do the local staging, you have to do MRI. And you have to be able to read that MRI. Because CT simply cannot give you the information that the MRI can give. So you must read that, and I don't know how many of you noticed yesterday, but on the MRI report, they had actually written T3A, T3B. So that is called an MT3, that is based on the MRI. And that is what the ESMO uses to know whether to do a new adjuvant in a T3 stage or not. So that's how so that you should know. And you should know if I ask you, which trial has brought MRI into focus, you should be able to say the Mercury trial. And you should be able to say Gina Brown is the radiologist who brought it into the knowledge of everybody, that MRI is superior and it can be used much more than CT scan. So these names, some names you should know. I found that a lot of students, when I used to ask them, what is the operation of Pusto's operation? They will say it's a lateral pancreaticojejunostomy. It's actually not. The Pusto's operation was done many years ago. When Pusto did it, he did it with a splenectomy, and then he opened the duct, and then he inverted the whole pancreas into the jejunum. That is the original Pusto's operation. None of us do it. What we do is the lateral pancreaticojejunostomy, which is the Partington-Rochelle modification. So you should know these things at your level, because in chronic pancreatitis is an important disease for you. So in diseases like chronic pancreatitis, Whipple's, you should know the various named operations which are routinely practiced around the world, so that when you say that, the examiner doesn't have to ask you what is the procedure. He understands that you know the procedure.
What I would say, ultrasounds usually as an examiner, we don't expect students to really interpret, because it's a dynamic, at that time somebody has done. But everybody expects that you should be able to see the CT and correlate clinically the extent of the problem, and you should also be able to see what problems you will face at the time of surgery based on your CT. Are you able to evaluate CT on your own? And as Chetan said, some of the MRIs today, something like rectal MRI or these you should be able to read at least them today. I think we have now to go into the next phase. You may not be able to read all MRIs, but definitely these 2 or 3 you should be able to read. And I think examiners would now expect them. The other investigations like say PET scan and others, I don't think till today we still expect them to read. But
I will say
many centers we see that during exam they put up interventional procedure images also.
If it's only image, yes. Dynamically, it's not. Many of these are dynamic investigations, so there are limitations to those investigations.
Most of the times
or
your
video.
Dr. Ramesh and Dr. Supe has mentioned, quite often we have discussed the radiology during the clinical case discussion. Means your planning and already done. So you know how to, you should know obviously how to read the CT scan, even the MRI. If not MRI, then MRCP is a must to read. And barium study is another part if it is required, like you mentioned, esophageal stricture, corrosive injuries, and all this kind of. Last session where we discussed the MRI, this radiology, if it is not discussed into the clinicals, quite often we put some films to in the post-operative session to discuss. And the first question is identify the imagings. And quite often people fail to see the barium swallow, barium inma, or it is a CT scan or MRI, even T-tube cholangiogram. So once you identify the X-ray, then the next question is what is the abnormal finding? And then if abnormality you have picked up, then next question would be what is the likely pathology? And if you can successfully answer, then we can go into the obviously clinical discussion if you have not done well into the clinic, so that we can reassess here. So plain X-rays, obviously, this T-tube cholangiogram, CT scan, relevant MRI, barium swallows, barium studies, you should be able to interpret normal and abnormal both. And this is a must as an expert surgeon.
I think we have spoken enough. Now it's time for you to come out, because this is a wonderful opportunity. The galaxy of consultants, examiners.
You can ask some
mentors,
your doubts
your
or,
concerns.
over the last 1.5 days, we have discussed some cases. If in the cases you felt that the examiners were leaning towards a treatment which you didn't like and which you think should have been discussed, you can bring it up, because we are not make mistakes. So you can bring it up, and you have a doubt, we can clear it. Yes, please come to the mic and speak so that everybody can hear.
During the history taking from patients, how much stress should we give to the word the patient uses? Sometimes they use the exact organ names, and should we base, as it was discussed, the education status of the patient, whether he is able to correlate it properly, or should we still keep a broad mind and not base our differential?
No, the history, when you say the presenting complaint, it's actually the exact words that the patient said. You may be translating it from Hindi to English or from Tamil to English because the exam is held in English, but you should tell exactly the words that the patient said. If the patient knows that he has a tumor in the liver and comes and tells you in his presenting complaint, मेरे कोई liver में गांठ है, then you say that. That is what the patient presented with. Then you can tell what was his symptoms and what was. But the presenting symptoms is as per the book, the same. But nowadays, I think the examination is, there are 4 cases in 1 hour. So usually you don't get time to take a detailed history. The history is written and given most of the times, and they just examine. So you don't have that much. We don't have these 45-minute cases anymore, if I'm not mistaken.
Come back again. Some of them will come back again because this was probably during the Corona time they had changed the pattern.
But come back to the 45-minute case.
1 or 2 cases will be there.
15 minutes.
So because 15 minutes, 4 cases is what I thought.
Yeah.
And then the ward round.
It may come back. See, the answer to your question is very simple. We have to understand in India, we have a multicultural sensitivity. So you get patients from all corners. So when you are taking history with the patient, it's better to use patient's words and ask him what is it and all. But when you are presenting it to the examiner, as he rightly said, you may translate it and may put it in your scientific way, but it should be more focused. But when you are taking a history, it's better to use patient.
If I've understood his question correct,
that history should be in the patient language. The layman who does not know about the disease will merely describe the symptoms and you have to tell the symptoms and duration. Educated man, suppose that he has already undergone cholecystectomy, he knows he has undergone cholecystectomy and has developed biliary stricture, he will say, I was operated in so and so hospital by so and so surgeon, and I have developed a benign biliary stricture. So now you can start exactly in the language of the patient. Sometimes, if you during the history taking, you will also take a leading question which you may draw from the patient, which the patient has not really given to you. So it is also art taking the history, how to get the information out from the patient which is written to corroborate this history and reach some differential diagnosis.
Anil wanted to say something.
He's saying that probably what he's trying to, the question as I understood, that mostly the patient talks about in his general language and he doesn't know the specifics about which organ, what diagnosis, what the biopsy, etc. But now that thing is changing because a lot of these educated people who are coming and a lot of them would have read the reports and probably with the Google and all that would probably give to that. So I think you have to use a bit of discretion. That conceptually it means that you do not present what the decisions that the patient has made or what he thinks that this should be the next step or whatever. I think, but probably some things you can even specific if he says so. Like, a lot of people, they will come and say, stomach mein dard ho raha. So now you obviously will not use the word stomach. You will say he's got the pain in the upper part of the abdomen or wherever. So I think you'll have to
Use the stomach for the whole abdomen.
Yes, that's right.
Colloquially, stomach is
Yes,
for the
so
whole
he's using the stomach for the whole abdomen. Like as you said that if he specifically says in the liver there was
But
some
there are patients today who come with having been investigated, they know what they have, and they are educated people, software engineers,
I mean,
highly
as
who
Sudeep
comes
is
and
saying,
says,
he'll say, I have a periampullary tumor and it has been biopsied and you do a Whipple's on me.
He
So
says,
then
I have a
he'll-
net in the tail of my pancreas.
So basically,
comes
when
and
you
says that.
in the history taking, when you say that the patient is a software engineer by profession, it solves all your problems later on because then you understand that the level of the patient.
Solve all your
It
problems
won't solve.
because you have to answer so many questions which
Google has thrown up.
Google has
No. In history, in the exams, in history taking, when you say that so and so is a software by profession, comes with presenting
then you can ask a leading question to him. Tell me, what should I do?
Suppose if the patient,
Tell me, Google says I should do.
Because often they come and tell you that I took these tablets for pain in my knee for 30 days, after which I developed pain in the abdomen. So it is up to you as a doctor to agree or to separate it of the decision.
suppose if the patient says that he has an itching, jaundice, and clay colored soup, can the student say patient has an features of obstructive jaundice and fever with
I don't think in the presentation you would say he has features of obstructive jaundice. You will say he has itching, clay-colored stools, and eye-colored urine. And then you would go on to the rest of the things. And when you give your diagnosis, you will say, based on this, he has got obstructive jaundice. That's all.
One more thing I'll tell you, if you have any language problem because it's going from north to south or south to north, you are being given interpreter as per the guidelines for both the NMC and also by the National Medical Board. So you should not be worried for the patient. Somebody can interpret for you in the patient's own language if language is used.
Sometimes there are chronic patients, because there are certain diseases which are brought. They will be brought for every examination. So if you are intelligent enough, you can at the end ask, do you know what you have a problem? And I know that, for example, my friend was going for the neurology examination. And when he went to examine the examiner, the patient said, sir, give me 100 rupees. So he gave him 100 rupees. Then he said, sir, I have syringomyelia. These are the findings that the examiners want. This is what you should tell and this is what you should not tell. And exactly he passed the exam with flying colors. So sometimes, you also have to use your common sense.
Like the case which was being discussed today about a choledochal cyst. So now it is possible that the patient might tell you that when we went to that ex hospital with that ultrasound or this thing imaging, and he was told that has got a choledochal cyst which needs surgery. So then obviously you would not be talking about that, because then there is no point of discussion. Because, and sometimes you can use the word perhaps or something. If there is something which the patient has deduced, you may say that he or she attributes this to this. So which automatically gives the examiner an idea that even though the patient is saying, but obviously you are not agreeing with that, and you have kept an open mind to look at that what the diagnosis could be. So I think you have to, there is no, clear-cut rule to say that this word has to be used or this word may or may not be used what the patient is saying.
I think 2 plus 2 is not 4 in most of the times what I have seen.
What is it then?
In
What do you want it to be?
in medicine, it is 2 plus 2 is not 4, right?
You should say
Yeah. Yeah, medicine. Yeah.
No, for accountants also. it's
So,
not.
so the thing is, the present day, we have lost the art of taking a history because most of these patients come back with investigations. I think that is where the problem is. I think it is case to case basis how you interact with your patient. You
The
should
problem
look at the
is
important.
that when they come with the investigations, the resident, the first thing he does is he looks at the CT
That's what I'm
scan
saying.
and reads the report.
Yeah, so they
Then
don't,
he asks the questions in the
which is relevant to it.
So
that is not right. And many times these patients know, if you ask, did you lose weight? They try to hide because they know it's a loss of weight is associated with the cancer. Many times, no sir, I started dieting now and then that's why I lost weight. I think you should not take it at face value. You should probe further, and then whether you want to give it importance to it or not is depends on case to case basis. Rather than blindly follow what they, because sometimes
I
they
have
try
not
to
yet
hide.
come across a patient who's hidden loss of weight. They've all told me
No, they told.
they've lost
But
weight.
they add that I have been dieting of
Yeah.
late, and
If you ask them, they add. Otherwise, they don't tell.
One more thing also. Most of our patients come evaluated extensively in other centers. So they themselves will be able to tell they have underwent a PET CT, they have underwent a MRI. So should we mention all these things in our history and limit further probing?
I don't think you'll get those investigations in the examination. So in the examination, you have only the patient.
Per se is telling that once he got admitted, he underwent an
No, if he tells you, you can tell the examiner. He says he went for, but unlikely that he will know the details of what
I mean, at the most, you can say that the patient went to X hospital and several investigations were done, including a CT, MRI, or
And a
PET
PET.
scan.
You can tell that.
Because obviously your discussion is going to start based on your history and examination.
see, the examiner is seasoned examiners, all of
See,
them.
in an MCH examination, we assume that your history and physical examination, by now having passed an MBBS examination and an MS examination, that this has been judged in detail, that you have got through that. So here we are interested in knowing the management, because you are a super specialist. You are the last port of call. So you are the person who has to take the decision. What treatment is to be adopted? Is it medical? Is it surgical? Is it a combination? You have to tell. So most of us would concentrate on the management to judge your actual performance. The history and findings, maybe a little, some questions may be asked, but they don't, I don't consider them important for your examination.
You have to be smart enough. Even if he tells you the findings, you just say that he has been thoroughly investigated, including so and so being done. Keep that information to be answered when he asks questions.
My
Question
question
is important, sir.
Request the candidates to ask
that's what
about controversy, if there is any confusion about management of patients, individual diseases.
Do you have any confusion about it? That's what I said yesterday. So many cases we discussed. Do you have any confusion on any management issues of various cases that we discussed, which you felt left you confused and didn't give you a proper conclusion? You can ask those questions.
And remember, this is the last time you can ask questions to them. From here onwards, they will ask questions to you. Because they are going for exams.
Go to the mic.
Everybody to come up and ask.
For the esophageal carcinoma, always I think we may be questioned about the role of transhiatal esophagectomy versus transthoracic. Again, common question asked.
So unfortunately, my friend Chandramohan is no more. A strong supporter of transhiatal. What is my? I will tell you what is my opinion, and then you can ask the others their opinion. I do a transhiatal only for a lower third tumor, where I will do the dissection of the tumor under vision, which I can do by widening the hiatus or cutting the hiatus around the tumor. The normal esophagus, I actually, since it's a normal esophagus above that, I actually don't do a transhiatal dissection at all. I just use a saphenous vein stripper, which I pass from the neck esophagus, and I just invert the esophagus out into the specimen so that there is no dissection with the hand or with any instrument inside the chest at all. So that is how I do the transhiatals. And for the middle third, I do not advocate a transhiatal. I would give neoadjuvant, and once it is time to operate, I would do it thoracoscopy. Anybody else would like to make a comment?
Basically, the exam answer should be, we also do quite a fair amount of transhiatal. The exam answer should be that I would like to do this by a transhiatal method, though it's oncologically not oncologically inferior, but we have found good results with that. Fair enough. You are admitting that it's.
Would you do it for the middle third?
No, it's only for lower third. Of course, it's only for lower third in, growth you will be doing.
I think you should know the pros and cons. I would disagree with that saying oncologically inferior, because those who are proponents of transhiatal and the way Dr. Ramesh described that in the region that they can see, they are doing the same procedure as they would have done in another transthoracic esophagectomy, and it's a normal esophagus that they're taking. So I think you should be aware about what you're talking about, because at the end of the other spectrum is the three-field dissection. So I think you have to, what examiner is looking at is your approach. If you are trained in a center where transhiatal is the way to go for either limited tumors which are in the lower part of the thing, then you have to justify that. I think by and large what it stands out today is that most centers for intrathoracic tumors do not go for transhiatal.
That's what I said.
Right.
Thoracotomy or thoracoscopy.
And also, so the thing is that it is at the lower end where this may occur, and if you justify it by saying that for that region you are able to do with a reasonable clearance as you would do in a thoracoscopy, so that is fine. And the other thing is that again you should be aware about controversies or the views that people have about what will be the pulmonary morbidity, because if you, Dr. Chatterjee is fond of saying that who says that the chest morbidity is going to be any less. So I think these are the things you have to be aware of. So I think in an exam and at MCH level, everyone is looking at your approach. I think not just the right or the wrong answer, because when you reach this level, there's no one absolute right or wrong answer. So what they are looking for is the approach. And the same thing, if I also extrapolate on what everyone has said, that in the exam also, the examiner is trying to look at that whether this person is safe to go into the to have an independent practice with the right approach, and as what Jason said, that you have to keep that all the things in the armamentarium, not that because you are a surgeon, so you will only go for a surgical approach. And I think that is what the person wants to hear, and so that is very important. Yes.
I want to say one thing based on this question. Many times I've seen a student who comes to you and he's a blank in one particular area. I mean, he probably has not seen those kind of patients at all. For example, somebody may not have seen corrosive patients at all. Somebody may not have seen a particular kind of patients at all. The solution to this is that some of you where you do not have such patients, and these patients are common in examination, it may be better to go to such a center and see for 15 days and try to understand the pattern of this, and you don't feel very blank. Because, you know, sometimes a patient comes and he says, sir, I have never seen before, then the whole discussion is theoretically. But if it is not so, at least gather some information about areas which are very commonly kept cases. Otherwise, you will fall flat at the time of exam.
So I think it will be very difficult if people have to go for corrosive esophagus or things like that. Some areas people don't do. So, for example, a center doesn't do liver transplantation, then that candidate should be sent ideally to a center for a month of where they do regular liver transplants, and he can get to know the basics, and also it may influence him to become a liver transplant surgeon at a later date. You should not deny him the opportunity. So I think liver transplant is one field. Second is obesity surgery. So many of the GI centers don't do obesity surgery, but some of the GI surgeons would like to do obesity surgery. Then they should request their heads that they would like to visit for a month to a busy obesity center.
But you know,
Ramesh, there are now so many centers which have come in DNB and MCH where the full spectrum of surgeries are not done.
Exactly.
I think this is a flaw in our whole system which has really come now. So we need to find solutions for this.
I think that
either we need to have some kind of an online or some connections of that. I think Ashok, you may have a solution. But I am feeling this.
It's not a forum for discussion here because you were rightly mentioned.
Yes.
There is no informed training as well. It varies from center to center in addition to the facility. And so this can be discussed separately. I'll suggest the only thing for the student point of view, suppose that you get a clear case of esophageal corrosive injury and you are not seen it and you are very, very uncomfortable, you can say, I have not been seen, and the examiners will be definitely giving you another patient in addition to that, happily to examine. And this is the part of the training center, which area is deficient, where to send before their examination or after you finish your training program, and that is totally
sometimes, but a disease doesn't exist. Sometimes a center in South India, they may not see a CA gallbladder. But when if they are put in examination in Delhi or SGPGI, a CA gallbladder case,
but then the point is that you can't be excused for not reading around it.
You should have read about.
If you are shown a case or you are asked a question that it is T2, incidental gallbladder cancer. Now you can't say that you have not seen a case.
Exactly.
Because you, again, the same way that you are going for exam in other places, you may be practicing in other areas. So you are not making a GI surgeon for North India or South India or things like that.
Exactly, but
so I think
this can,
from
they
the
have to
student's
read.
point of
That's
view,
what I said.
from the student's point of view, even if there are logistical issues about sending people across to other centers, you should have read around it and your approach has to be fine. And the examiner will give leverage for not knowing some of the intricacies of doing that procedure, which only you would know if you have seen those procedures.
So our center number of liver transplants is low. Only last 3-4 years we are doing.
It may be different for different centers.
So I send them for a month if they are interested to either Soin or to Subhash.
I think the point was, I want to tell you that if there are some areas which are blind spots in your career, please try to read about it and try to know from your friends and be ready. Because what Ashok said, we will give you another patient to you, but that impression will still remain that he is deficient in that common area.
There's another.
This is no deficiency because theory examination assess you each in every area.
Ashok,
you are supposed to know
we have been
theoretical
examiners
part of
many
each and
times.
everything.
Practically, if somebody have to change the case, it gives the impression.
Second point I would like to tell, there is a habit of some of the candidates, especially those who are trained in heavy laparoscopic practicing centers, to tell what operation you will do, lap anterior section or laparoscopic right hemicolectomy. I suggest you don't do that. What operation you are going to do, you say right hemicolectomy or you say low anterior resection. If the examiner asks you whether you will do it open or lap, you can then justify your answer. Because suppose you say lap and then you have never done one, then the examiner will say you have never done one. So it can get you into trouble. So don't, I've seen this answer coming quite often that they will say without thinking laparoscopic anterior section. Don't do that. Practice saying anterior section, practice saying thoracic approach for esophagectomy so that it is not said to be open or to be thoracoscopic. If they ask you, you can tell what you want to.
Any more questions? Please.
In the morning regarding that patient with that case that we discussed in the morning regarding the patient with obstructive jaundice who had cholangitis and later came with ENBD in situ. So what would be the role of an ENBD guided cholangioscopy for the patient to look for something? I mean, cholangiography to look for the disease. We were going for a USG, then we did a CT scan. Is there a role for the cholangiography for this patient now that he has an ENBD incident?
You need not do an MRCP then, but the problem is that the ENB guided cholangioscopy, X-ray may not show you the pancreatic duct. It may not show you the upper end as well as the MRCP did, because there's a narrowing there. So sometimes the imaging may be poor. So you can do it, and I think it's a good option sometimes. Like whenever we have a fistula, people forget that one of the best investigations to do is the fistulogram. They still go for CT. You can actually do a CT fistulogram, which can give you tremendous information. So, yes,
so
it can be done.
In that particular case, it doesn't make sense to have a cholangiogram because you know the level of block and the reason for what you're doing. Sometimes when you're doing this ENBD for a hilar block, then it is relevant because is there any progression? Is there a change in the assessment of the level of obstruction and where it is extending on the right or left? It may be valuable in that situation. So since you specifically said in this patient, I don't see, you have seen a lesion, you know it is lower end block, and cholangiogram is not going to add anything specific in the management of.
Harik has rightly mentioned here the purpose was kind of sepsis and cholangitis, and the first attempt by internal drainage by endoscopy has failed or blocked. That's why external drainage was preferred in case of thick bile or maybe concretion, so that this better control. It is useful. It's not cholangiography. Here you don't want a roadmap because for see the biliary anatomy, we know the exact pathology and the plan is already there. It is a bridging gap to manage the cholangitis. But in some patient, like suppose that is a suppurative cholangitis secondary to CBD impacted stone, sometimes in case of bilioenteric fistulization, aerobilia, cholangitic abscess, very, very useful, whether the stone has completely cleared or not, whether in the peripheral duct or central duct. And sometimes if you change the position, you can, contrast can go into the duodenum also, because head down and various left and right position, you can see the lower trunk very well. But here definitely it is not indicated.
But I personally would not have put an ENB. I would have put in a 10 French stent into the CBD because your ENBD has a very small lumen. It's usually 5 French or 6 French. So it's very small. So it's very long tube. And most of the drainage that occurs around the tube into the duodenum. It is not actually coming through the nasobiliary tube. So I don't know why they put an NB tube for cholangitis. I would have actually put a 10 French stent. Probably the previous stent might have been a 7 French stent, which gets easily blocked. But a 10 French stent is short in the duodenum, would be the ideal treatment for a cholangitis.
I would just add on to this to say that you should be aware about the various centers now going more and more for ENBD. So I think the Japanese approach has also changed. So I think you should be aware about those theoretical aspects, and then can decide on, as Dr. Ramesh has said, that is the approach that you would take. Because classically people used to talk about that if you have to send the patient home, so you will exchange, even if for cholangitis you have put it as an ENBD. But I think some of those concepts are changing, so I think it will be worthwhile to do that.
In India, we would be very reluctant to send a patient with an NBD home, right, because they don't talk.
Exactly, but I'm just talking about is that
it's very uncomfortable to have a tube out of the nose for 2 weeks.
Agreed, absolutely, but
I don't think.
In such situation, if the stent is blocked and not working, they use ENBD quite frequently. And patient be sent home with ENBD and then asked to come back for follow-up.
I think from where we started by saying that your fate is sealed by the time you come to the stable viva, I would just say that please don't take it lightly. I mean, even if your fate might have been sealed, and partly it is because that there is less aberrations in the sense that your performance in table viva also goes in line with or tuned with what your rest of the performance has been. So that is why there are no major changes in terms of, you know, the decision for passing or failing. But having said that, your examiners are looking for some specific points, like some things stick in the mind because it is not the quantity of errors, but the quality of errors. So there might be something which are sticking in the mind, and so the examiner may show you another CT scan or an MRI.
Actually, I would like to
just
give you an example.
Yeah.
Dr. Shastri was there, Dr. Ashok Kumar was there, and I was there for an examination in SGPGI. In the morning, in the cases, four cases, there's one candidate who did very badly. And we thought that he will definitely fail. But then when the ward rounds came, he did brilliantly. You remember, Shastri? You also commented, the boy just, it was complete reversal. From hopeless performance, it was a brilliant performance.
Right.
And we cleared him. Because I think in the first stage he was a little nervous. Maybe that is why he made some
That is the point I was going to add, to say that it may be an opportunity to catch up. Because the examiner is trying to look at that the blunder or the error that you did in the first half, was it a one-off or is it part of the way you are? So I think that is what they are looking at. And I think I'll also give you another example, that in one of the exams, in this place only, AIG, Hyderabad, I think some of the examiners would be remembering, one of the senior faculty from another center said that our two candidates appeared in the exam, both made different diagnosis and both passed. And I said, did you ask him that what was he asked? Because one of the ones who was shown a colonoscopic picture, I don't know, Mahesh also was there at part of that, this thing, that he made a different diagnosis. But then when he was again asked, do you think it is that? He retraced and came to the right thing. So what we were looking for was the approach. And I think he rectified, and that is for anybody to look at that image, and there was a reasonable reason why he could have thought about otherwise.
Dr.
So I think,
Dr. Anil, I'll say कि we should not give a message that the clinical part is only important. Each and every section of the examination is equally important, and they have given separate passing mark and separate maximum mark for all these four sections. And you should take a message, every section is equally important, and after compilation of all the section, the pass and fail or success or failure is decided. 4-5 section is made because of if somewhere you faltered, somewhere not make it, you have given chance at another section to improve upon and compensate. Because sometimes everybody cannot do well everywhere.
Anyway, the candidate has to do his best in all the sections.
So you have to do.
We'll take the question.
So this is the way.
We'll take the question.
My doubt was regarding yesterday's discussion where we had CHEP, hilar cholangio, probably periampulary as diagnosis. The ultrasound was not much contributory. So the candidate said, I would like to do an MRI abdomen and thus an MRI. The very next question was, why not a CT? So how do we go about?
Sorry, the ultrasound was contributory. It showed dilatation till the lower end. Now, what does that imply? It showed dilatation till the lower end. Yeah, so that information you got. So the differentiation between hilar cholangiocarcinoma and carcinoma neck of gallbladder and periampullary disappeared the moment they said that there is a block at the lower end and it is dilated through. Then it became a lower end block. So it gave you the clue.
The standard protocol, if ultrasound shows hilar block, next best investigation is
MRCP.
If it's lower end block,
a triple phase
pancreatic protocol, CT abdomen is the standard answer.
Standard answer. So in that, with that ultrasound, we would have expected you to say a CECT triple phasic pancreatic protocol because it was dilated till the lower end.
One point that I would like to highlight on what Dr. Shastri touched upon, that on one hand, it may be said that this is what you're practicing in your center. But you also have to judiciously use that, because you cannot say that for anything and everything. And they are also looking for that how rigid or open you are in terms of, because again, wherever you will be practicing, like it depends on that when you are asked that what will you do, you may choose among those two procedures, like even as Dr. Ramesh said, laparoscopic versus open. you may say that you'll do an anterior resection, and then if you're asked a supplementary question, then you can say, or otherwise you can talk about. But otherwise, you have to, if you are asked that what are the options, then you have to talk about those options. Out of those, you may choose X or Y. Because in Bombay, there was one exam in which one of the candidates, all the examiners were trying to ask him that the bilirubin was 15 or 17 or whatever. So will you stent? He said, we don't stent. He said, okay, it is 17. It is 20. He said, we don't stent. Now, the point is, then the question was put up to him was that some centers do stent. So what do you think is the logic and what is the level at which you would do? So you have to be aware about the various practices. Like, so you have to filter out and you have to be a little open in your mind in talking about what are the approaches. And sometimes,
if you ask Bill Jarnagan from Memorial Sloan Kettering for a hepatic resection, for a Whipple, he doesn't bother about the level of bilirubin.
That's right.
Even if it's 25, he will go ahead and do it. That's what he says in the meeting. What now? So that candidate may work in a center where they
that
don't
is
look
right,
at that level of bilirubin.
But the point is that his answer would be accepted that he's not stenting. But if you are asked that why do people stent, then you have to come out with the answer. And then you have to be aware about what the practices in various centers are. You cannot be excused for saying that what are the advantage and what are the disadvantage. He has to know that their infective complications would increase. So I think these are some of the things that they have to be. And the other thing is that I think, again, what was talked about, that you can't throw, as Dr. Sadiq said, that you can't say ultrasound in a vague kind of a thing, or MR, or when you are talking about CT versus MR. Don't throw the MCQs at the examiner, and don't look for what the examiner may be wanting, because somewhat it's good to catch those hints, but you do not have to, and the examiner is looking for that what you are saying and you are defending it well. And the other approach that some people want to go is that your answers will not change depending on whether Dr. Shastri is examiner or Dr. Ramesh is examiner, because even when the examiner at their center may be doing advanced laparoscopic or whatever, you are justified in saying what the answer would be. And again, to give you an example, in our center, one of the cases, because we were doing on those lines, our candidate who's heading one of the departments in Delhi, he said that no, I would not resect this. He knew that we would probably go like something like a CA gallbladder with jaundice, but which is fine that if you read the imaging and he says it is an advanced tumor and these are the options which are there, and so possibly we will go for this. So I think the examiners are looking for the approach and they are not looking for that right answer or the wrong answer.
There is no right or wrong answer. It is an answer which is logical.
Next question.
Sir, good afternoon. What I wanted to ask is an extension of the radiology section that we discussed. Sir, we are used to seeing the images on the console and the dynamic images. But sir, during the FAT examinations, when we went and we were shown the static films and the plates on the view box. So what I wanted to ask was, it is a little difficult to interpret like an MRCP in a single static image. So how much of time do we get to interpret those images, and will it be held against us if we are not able to identify the exact pathology based?
If I am to understand your question,
yes, sir.
You wanted to see the dynamic imaging.
Yes, sir.
But we are in the exam, they are showing you only the static images.
Yes, yes.
Well, it is difficult to bring the dynamic images in an examination in all centers. So maybe the reason why they show you a static image. But most of the time, the static image which they show you will be a very obvious pathology, which you should be able to identify. It will not be one of those things that requires a dynamic image to make a diagnosis. It will be something obvious.
Static image which is kept in the exam.
Any more questions?
Is usually a representative film which you should be able
and
to make
most
out.
importantly, even the examiner is seeing those static images only. So you have to say that with the available images, this is what I make out, because the examiner is
have to go
also
to the
not
mic.
seeing the dynamic image.
Yes.
Oh yeah, Mike.
Next question.
Sir, I have a question, sir.
Yeah.
Sir, my question is regarding a patient of chronic calcific pancreatitis who happens to have jaundice at the same point of time. And upon evaluation, we are not able to discriminate what is the stricture, whether it's benign or malignant.
So,
Sorry, you're not clear. We can't hear you.
sir, in the setting of chronic pancreatitis with jaundice, if on imaging we are not able to discriminate whether the structure is benign or malignant, how should we go about it? Should we offer a Whipple to the patient or?
Where? In the head of the pancreas?
Yes, sir.
The head of the pancreas. Well, you should make attempts to see what is the pathology. There are certain guidelines clinically. For example, if the bilirubin is about 10, H. Ramesh's paper says that the chance that there is something in the head is of malignant nature is high. If your bilirubin is normal, but the CA99 is say 7,000 or 10,000.
No, sir, in the setting of jaundice only.
Huh?
In the setting of jaundice only, with a structure which is.
So if there is jaundice.
With an indeterminate structure.
So basically, I'll tell you, the exam answer for this is that there are surrogate markers.
Then, you will spill tumor tissue. So if you have poured the but now when you go in, you find it is fleshy and that you suspect, that is the time you can do a frozen section. I think you should not deliberately core for a frozen section.
You can refer to our paper actually on how to differentiate million per million masses.
I think everything is important here.
Sir, and if post-phrase, it is a histopathological surprise of a malignancy, so how should we go about those?
Damage is already done. The damage is already done. So to do a Whipple in the situation, I don't know whether most people would agree because
it's multifocal.
Because by now it would have already been spilled. So I think the only option is to give chemotherapy is my opinion. Others can.
We'll take the next question.
Multifocality in this kind of
Maybe you
tumor.
can discuss with the patient.
Sir, my question is, in case of obstructive jaundice with a lower obstruction, if there are indications of preoperative biliary drainage, then one of the discussion it came up that plastic stent is indicated, but we have read that in guidelines and also they indicate recommend short covered self-expanding metallic stent.
The best stent to drain is a SEMS. There is no question about it. The SEMS drains better than any plastic stent because it opens up to 1 centimeter and therefore it gets much more drainage than even a 10 French stent. But most of our patients, many of our patients, I would say, are unable to afford a stent. So, a SEMS. So, what we do is routinely put in 2 plastic stents. We don't put in 2 10 French plastic stents. And we have found the 2 10 French plastic stents drain almost as equal to SEMS in these patients. Their bilirubin resolves rapidly. They rarely get blocked. And the groove between them also continues to drain. So, this is an alternative that we have found. And we know that it is very useful. Sometimes even for palliation, patient can't afford SEMS. We have put in double stents and they have lasted 18 months, 24 months. We have got cases like that. So, that could be an alternative that instead of a single plastic stent, you can use 2.
So, indication would be important. If you need long-term patency, need neoadjuvant therapy for borderline, preferred one is SEMS to be placed. If your indication is for cholangitis, there's a short-term stenting, then as Ramesh said, we can put a plastic stent, multiple plastic. If the patient cannot afford, there are other circumstances, then you need to choose based on what is available, what can the patient afford.
Yes, Sushan.
My doubt is about gastroesophageal adenocarcinoma, especially CVD2 and CVD3. Do we always have to take a 5 centimeter margin, sir? If that means that the lesser margin we can avoid going into the thorax.
The margin for an adenocarcinoma would be 5 centimeters, in my opinion. If it's a squamous cell carcinoma and it is not at all in the esophagus, then I think a 10 centimeter, because squamous has the propensity to spread a little bit more. I think you have to go into the chest then. I think any cardioesophageal junction tumor, if you do not excise the hiatus along with the tumor, the resection is not actually a complete resection. To go between the hiatal fibers and the tumor is not a correct procedure. So if you're going to remove the hiatal fibers, you might as well open the chest and do a esophagogastrectomy and then do the anastomosis just below the arch of aorta or the inferior pulmonary vein.
Any more questions? If there are no more questions, I would like to. Yeah. Please take the mic.
Any specific indication for short course radiotherapy with early surgery within 1 week for carcinoma rectums? Short course radiotherapy with early surgery.
In our center, it is a routine to give only short course radiotherapy for all patients. Very rarely we would choose early surgery. No, we have stopped doing that. We no longer do that.
So basically now the current evidence has conclusively proved that even for short course therapy, you have to wait for a longer period of time and not as what it.
So, and while waiting for the long course, for the short course, while waiting for the 6 to 8 weeks, we give 2 cycles of folfirinox, not 5-FU fluorouracil, but folfirinox. So that is also very useful, and that should especially be given if your MRI shows extravascular mural tumor in the vas vessels. If it shows tumor, you must do chemotherapy with folfirinox, preferably 3 cycles, because these patients are prone to liver metastasis and others if you don't give them aggressive chemotherapy.
Yes, sir.
So that person GE junctional carcinoma, most neoadjuvant good response. Tumor is downstairs. Still, you have to give 5 centimeters, or you can take that to the margin.
I would give 5 centimeters. I would not hesitate to open the chest. Somebody in the morning said, it is not the tumor, it is the patient's life that you are bothered about. So for that, you give the best clearance, which is 5 centimeters. And if you have to open the chest for that, you have to open the chest for that.
Any more questions?
Probably a pure gastric fundus tumor where you have a long intra-abdominal esophagus and you can get up to the hiatus and you can do a hands-on or stapled anastomosis and get with it by getting about 4.5 centimeters instead of 5. Maybe that would be acceptable. But that would be a pure gastric site.
Such cases are very less. Most of the time,
they are not
recurrences.
So I always go and I always like to excise that hiatus. So when my specimen comes out, there will be a cuff of the diaphragm round the specimen. That I feel is a very important thing which the laparoscopic surgeons don't do. That is why the esophagogastrectomy I always do by open surgery. I don't do laparoscopy because you can't do that cuff very well by laparoscopy.
Yes.
Extension of my question, sir. How do we calculate the margin? Is it the pre-neoadjuvant or the post-neoadjuvant proximal extent of?
This is a very difficult question to answer because the first guidelines that were formed for the head and neck cancer, and those were all squamous cell carcinomas. And there they said your resection margin should be the pre-margins. But then when we came to rectal adenocarcinomas, we have now making a statement that by neoadjuvant treatment and downstaging, we can convert APRs into sphincter saving. If you are converting APRs into sphincter saving, that means that you are now using the new margins. You are not using the old margin because the old margin was an APR. Then you should be doing an APR. But if you are converting it to a sphincter saving procedure, so there does seem to be some evidence that in adenocarcinomas with chemotherapy and radiotherapy, there is a shrinkage. The tumor moves up to by 2 centimeters. You can use the new tumor border, gross border, and do a sphincter saving procedure. So for adenocarcinomas, probably that is true. For squamous cell carcinomas, probably that is not.
Here, what analogy sir is giving is that you are reducing the margin length. You are taking the previous margin into consideration, but from the 5 centimeters into the lower rectum, you are accepting 1 centimeter or 2 centimeters. You are accepting it, but you are taking into consideration the previous margin only. You are not giving 5 centimeters margin clearance. You are giving instead 2 centimeters margin or 1 centimeter margin. That is what it is. So we take into consideration the previous one. The excision length will decrease.
But suppose the tumor was at 5 centimeters before, and you have to give 2 centimeters clearance, which is what we normally expect in the rectum. It will come to the anal canal. And that is not a very happy operation for the patient. The patient suffers miserably after that with incontinence, nocturnal incontinence, and whatnot. So, if you give radiation and chemotherapy, and this tumor now from 5 centimeters moves up to say 7 centimeters, you get the 2 centimeters. That 2 centimeters will allow you to have a cuff of a rectum onto which you can do a stapled anastomosis. So, there you would now use the new margin as your guide, because that is the reason why we are able to do sphincter saving, converting APRs to sphincter saving by neoadjuvant. Otherwise, there will be no point in neoadjuvant if the margin has to be the original margin, because the original margin was an APR, then you have to do APR on all patients. So since that has changed, see, the number of APRs done today are only about 10 to 20%, whereas 60 years ago it was about 60 to 70%. So why is because of this, that in adenocarcinomas, the biology seems to be different, and that you can go ahead and do a resection. There, of course, you should send the donut for biopsy and make sure that it is clear of tumor. And we have also seen with adenocarcinomas that T1 and T2 tumors sometimes completely disappear. There is no remnant of tumor after neoadjuvant. Then you take multiple biopsies, you do an MRI, you do a diffusion MRI to see whether there's a tumor. Nothing is available. Everything is negative. And you do a PET scan, there's no uptake whatsoever. Then the question that the Haber gamma, some patients start to wait, and some patients opt to wait. And we had about 11 patients who have had this complete response, and we have been waiting on them from a period of 5 years to say a few months, because the last patient is about 2 months. But of the patients who were from before, there's only one patient we had to reoperate. He didn't develop a recurrence which we could feel, but he developed severe perianal pain, so severe that he said, do me an APR. And we did it, and there was no tumor. So there seems to be in adenocarcinomas that we have to take a different approach, and that the new margin may be the reason that we can do it. But in squamous cell carcinomas, I think we have to still stay with the entire esophagus, which is squamous cell carcinoma. It has to go.
Any more questions? If there are no more questions, then I would request Dr. Pradeep to come up onto stage for closing.
So on behalf of the Department of Surgical Gastroenterology, AIG, on behalf of Dr. G.V. Rao, who is away for a meeting, an urgent meeting, we thank the IASG for giving us the opportunity to run this 12th GI Surgery Clinics, and also we thank Chairman Dr. Nageswar Reddy, AIG, for providing all the infrastructure and help for this. Also, we thank wholeheartedly all the faculty members who have come here, who took off their time, holiday, and came and participated in these clinics. And also the patients who also have agreed to be examined by the students. And we also thank all the support of the clerical staff, the audio visuals, and who have provided all the infrastructure facilities for all this support for these 2 days. And for this support from the pharma, the Sun Pharma and Ethicon also are supported for this program. So we also wholeheartedly thank the Sun Pharma and the Johnson Ethicon for making this possible. I thank all the students also who took interest and actively participated. And on behalf of the all the faculty, we all wish you best of luck in your exams. The exams is only part of your life. Actually, your examination starts after you start practicing. I think it's only so I don't think you should go wholeheartedly that you should go with very confidence and participate in the exams, and all of you will come out, pass out like colors. All of you, I wish, I would say, send back home.
Wonderful 2 days, which I think has not only been useful for the students, but also for many of the faculty sitting here. We have also learned things. We have learned new concepts. So it's a learning. So yeah. So I now know some of the answers which I didn't know when they were asking questions. So now I know if I have to write an exam. Yeah, we have learned new questions also.
So everybody is learning. Sir, regarding last question only, regarding clearance. Majority exam consider this pre-radiotherapy, pre-chemo radiotherapy margin we consider. You can reduce the margin of clearance.
No, I don't. That's what I said. I said adenocarcinoma, you can change.
No, friends.
Thank you very much, sir. Thank you, all of you. Wish safe journey back home.